all our distinguished guests, faculty members, delegates joining us both in person and online, and to members of the press and media. On behalf of Sri Madhusudan Sai Institute of Medical Sciences and Research and the One World, One Family mission, we extend you all a very hearty welcome to the 13th edition of SCORE. My name is Dr. Pooja Natarajan. I'm a cardiac anesthetist working here, and I shall be your Master of Ceremonies. The Sri Sathya Sai Comprehensive Orientation and Rapid Revision for Examination Program, that's the SCORE 2026, is a two-day academic program for exam-going residents of the DRNB, CTVS 6 years course and MCH CTVS 3 years course, with the primary objective of providing pearls of success for the exam day with didactic resources and presentation for excellence in examination process. It brings together renowned faculty, teachers, and students to ensure meaningful and continued evaluation of the participants to build up on gaps in knowledge, strengths, and concepts and draw a line between applicability and prudence in the goal of faring well in examinations and a fruitful career as a CT surgeon. Why SCORE? The residents attending the program will have a chance to go through their exam day with the novelty of faculty, teachers, and examiners, providing pointers through stimulated environments, including the art of case taking, case presentation, with discussion with detailed feedback. In addition, delegates will have the opportunity to witness and take part in enriching real-time simulations involving assemblage of the cardiopulmonary bypass circuit, troubles during conduct of cardiopulmonary bypass, instrumentation, and various other decision-making scenarios, which every resident is expected to be familiar with and competent at. The symposia also includes didactic and interactive lectures with the who's who of cardiovascular surgical sciences to address fundamentals, bolster concepts, and fill any gaps in the addition to bringing a fresh lease of learning in an environment that has forever, over a decade, redefined the teaching in cardiovascular surgery. Now, to begin our first session, may I now invite Dr. C.S. Hiremat, our Organizing Secretary of SCORE 2026 and Chief Cardiac Surgeon and Director of Heart Valve Bank and Academics of CTVS at Sri Madhusudan Sai Institute of Medical Sciences and Research, to render the welcome address and provide an overview about the SCORE program and the DRNB examination pattern. Over to you, sir.
Good morning, Sairam. I welcome you all to this Sathya Sai Rapid Examination Oriented Program, which we started 12 years back. The days where we had challenges in training a resident, and 12 years back, with the help of the residents and few of the dedicated teachers who have the passion of teaching, of continuing that education program, came together, and we all charted out this program, and today more than 760 plus students across country, outside country, got benefited by this program of SCORE. We named it 12 years back at Sathya Sai Institutes. Been continuing to do it. Due to some logistics, we were a bit delayed. Normally it is conducted at the first weekend of March. That's how it is, so that for the exam going students, either DRNB or MCH, we see that prior to the exam, this is conducted as a preliminary examinations. The entire purpose of conducting the SCORE program is you go through that examinations, the exact pattern, how you face them, what are the questions asked, what are the loopholes we have, what are the loopholes the examiners have. Because finally, what is an examination? An examination is just a conversation of an English language between an examiner and examinee, that's all. And 3 hours examinations or 6 hours examinations or the entire day examination will not reflect what you have done in the last 3 years of MCS course or last 6 years of MCS course. In MCS courses, we do have an internal examiner, whereas in the national level, we do not have an internal examiner. If you ask me, it's a blessing in disguise of not having an internal examiner, because he'll be biased whether you have worked or no in the last 6 years, 3 years, what you have done at the personal grounds, at the social grounds, everything he'll be knowing. Here, you are a clean page standing in front of that examiner or exam. So that is one which you go, and there only your knowledge speaks. And the subject is so vast. In fact, cardiac surgery, once we take down, my teachers, many of them who are sitting here, always tell that cardiac surgery, sky is the limit to growth. Initially, when we were students, it was just adults, slowly pediatrics pitched in. Then subsequently, as you see, different specialties have come up. Depends on your interest. There are some very few hand-picked surgeons who can do all the variety of cases. They try to restrict themselves into adults, pediatrics, minimal access, robotics, thoracic surgeries, vascular surgeries. The field is just expanding day by day and based on your expertise. On this occasion, I'd like to offer our gratitude to Bhagwan Sri Satya Sai Baba, whose under vision and mission we started these free institutes where education, nutrition and healthcare is totally free of cost. With that concept, we ventured into this, and I will tell you that starting these programs or any of these institutes is not easy. There are many good people on this earth who come forward, join together their hands and take it forward. We need to leave behind a legacy. Many teachers, the stalwarts we have lost in the last few years, they left behind a legacy of good teachers, and those good teachers, in fact, they leave behind good students. The lineage between a teacher and a student is being continued in this institute by Sadhguru Sri Madhusudan Sai, who was a student of Bhagwan Sri Satya Sai Baba. We will come to know in the subsequent meetings glimpses of what we have been doing here. I would like to welcome few of the best teachers in the country. In fact, if you ask me the best teachers in the world, there are few people who have joined online across the country also. We have today professors, Professor Dr. Anil Tendulkar, a master batsman, who they are all unstoppable in teaching. And I think many of you would have heard, and in the next 48 hours you will know that he will never be tired. It's you who get tired listening to, you also will not get tired. That's how it is. He teaches, he makes you laugh, he sees that you are active always. The other teachers, Dr. Sitaram Bhatt, they are all my teachers, whom I became a student and had this passion of cardiac surgeries, who was ex-retired professor and head of the department of Sri Jaydev Institute of Cardiovascular Sciences. We do have amongst us Dr. Vinayak Shukla, the ex-professor and head of CMC Vellore. See the commitment. He has started morning 3 o'clock from his place, has driven down all from CMC Vellore, has come to the campus 7 o'clock sharp. We had breakfast together and he is here amongst us for the next 48 hours. This drive, at the age of all of them are, I think, 70 plus, the drive to teach the students. Always that passion is there. In fact, many of the time the feedback what I get is, teachers are more active and more passionate than the students. That's the common feedback I've been getting for the last 12 years. I hope someday that turns around and that will be really worth it. We have other faculties from different hospitals. We have got Dr. Arun from Apollo Hospitals, Chennai. Thank you, sir, for coming. And we have Dr. Pranav, who was there with Satya Sai and he was abroad for some time. I welcome all of you for this. There are other faculties who are joining because multiple commitments at their own institutes. Shortly they will be there. They are on their way. Many students are on their way. We have crossed 431 registrations this year, and of which around 136 are offline amongst us. There are cases. I got the news morning that some were hesitant to take cases. You have to take cases. Do 1,000 mistakes here, but none elsewhere. Do 1,000. This platform is created to do mistakes. and never get insulted, humiliated, nothing. Even if it goes online also, least bothered. Who is bothered about what? You are here, if you study well, if you do well, if you pass the examination, it's your career, not somebody else's. Never fear of, the fear of insults, humiliation, you should go beyond that. And if you ask me, I am the living example most of the times for everyone. So not to worry about those things. Even I was a student, we were all students as we started. In our days, we never had a morphology class. If you want to know my stories, when I was a student, I used to give 500 rupees to the mortuary guy in our Victoria Hospital in Bangalore. I used to run, get a heart from there. Because mortuary guys normally without a small booze, they won't do mortuaries. So that I used to support him. What to do? I wanted a heart to get. Because no morphology classes across the country. And teachers like Sitaram Bhatt and Dr. Prasanna Simha, I used to sit with them and dissect the heart to study the anatomy. Those were the days like that. And they taught with that today, and if you ask us, we surgeons, we hardly believed much on echocardiography because echocardiography is all subjective. Somebody shows VSD is there, somebody shows this. We have our own challenges. But if you know as a surgeon the anatomy well, you need not depend on anybody. This is what my teachers have taught me, that trust no one except your own self. In fact, the teacher himself, the teaching, what I extended is, don't even trust me, trust your own self. That's the way we teach, because surprises are known on table. You can't blame the echocardiographer, you can't blame the cardiologist for the mistakes what they have done in seeing echo. They have done, it's done. You opened the patient on table. That courage should be there to handle and bail out the child or an adult to see that you send him home alive. So these are things which over a period of time you learn. Today multiple courses have come up, multiple specialities, and candidates who are interested in fellowships abroad, multiple fellowships have come abroad. I've been sending students across the world for their training. They come back, and most of them are independent surgeons. And I also welcome online our faculties. Professor Sampath Kumar is there online. He was the ex-professor and head of the department of Ordination of Medical Science and Research. He has come to our institute multiple times. He is my teacher. In fact, repair of the valve next to Carpenter in India, next to Alan Carpenter in India, Dr. Sampath Kumar took the lead. He is students, Dr. Prasanna Simha. We all do multiple mitral valve repairs. Thank you for joining us, sir, online. And Dr. B.R. Jagannath, who is a professor earlier at Hyderabad at multiple hospitals, and today he is with us. He has joined online because of few logistics. He is out of station. So all these people are there, teachers, morning. In fact, they are the first ones to join online and be there and waiting for all of us. So with this brief introduction, I think I'll just take you through the examination pattern, how exams are conducted, people who are not familiar. Can I have my first slide, please? Now I'll be taking you through the exams, what is the actual stark reality, the score and your targets. Of course, it's a new beginning for all of us. People who are attending the score for the first time, definitely it's a new thing for them. People who have passed also are attending online. Some of them who are passed are here physically also. So the probable marking system, as we all know, we are sitting examiners today for MCH and DRNB. In fact, we set the curriculum for the National Board. We have put up proposals how we can further modify based on the current requirements in the curriculum of the National Boards. So out of 300 marks in a practical examination, you have got case presentation where there are 4 cases. That carries 200 marks. There's nothing called as a short case or a long case. It depends. Usually, invariably, the examiners, the first case takes long. You are new to them, they are new to you. So they also have something wherein, yes, let me see how much he knows on the first case, what to take. But don't be on the biased concept that the first case decides your future. No. Every case will decide what's going to happen. So 50 marks per case, we have that marks, and then come to table viva, which all we are same. Everything follows on the same grounds, which carries 40 marks. ICU rounds have been taken, where just to prove, to know whether you have really worked in the ICU or not. It's a simple practical questions we ask around normally. And then, of course, biostatistics and recent advances are 20 marks, which you should be familiar. A little on biostatistics and the current guidelines of certain cases, which I have a separate topic for that. And the passing marks, as we all know, is 150 marks. As I mentioned, case taking is entirely 2 hours only. It is 30 minutes per case, and it depends on the examiner how you present. The first, suppose initially they start off with history, findings, and all. It goes in that way. The subsequent cases they come in the reverse order. Some may start from the operating room, or they start going to the operating room, or what's your diagnosis, what makes it, that you will come to know those cases. And normally we give 30 minutes per case. The findings goes like this, as I mentioned: history taking, examination, arriving at a diagnosis, summary, and what is the justification of that, what are the DDs. Try avoid knowing the diagnosis prior to taking a case. If you have that in your mind will be biased. It does not give room to think of any other diagnosis. And even if the examiner tells you have seen the case, he knows that you have already seen the case, you know the diagnosis. Okay? So this is one thing you should always know, that not to go with a biased mind to see any case. Give a differential diagnosis. That initiates a very healthy discussion. This is what I keep telling all the students. As I mentioned, you consider it all long cases itself. It depends how you. There are certain tricks and tips how you can lead the examiner. Some examiners may catch you. He is leading me, but most of them do not know. It goes on what you know, and you take them along the track. That's a trick over a period of time. Only on repeated presentation of cases you will know the trick. This is a platform to present repeatedly cases. So that presentation will improve your vocabulary, that improves your communication, what exactly you have got to do. And of course, we have cyanotic congenital heart diseases, normal cases which are VSDs, PDAs, coarctations, ASDs, and cyanotic congenital heart disease. Most of them it is TOF or TOF physiology. That's the commonest case what is kept. And of course, in valvular heart disease, single or double valves, redo cases always will be there. So the focus mainly is on how you enter the chest and what are the challenges you face, types of redos and all. And in thoracic, always you have a case on either a destroyed lung or a thoracic mass, empyema thoracis and all. And individual discussion goes on whether actually you have seen a thoracic case, your training you undergone or not, or 3 months of short postings you have completed or not. All these things will be seen. Sometimes we do have a case of constrictive pericarditis. It's quite interesting, and people should be aware of that. Of course, ICU rounds and all, in that they normally take you around the ICUs, where management of hyperkalemia and hypokalemias, all these are taken to measure. Pacing modes will be asked. Respiratory distress management will be asked, cerebral protection strategies, inotropes, dose calculation, normal physiological dose. All these are important just to know whether you really worked in the ICU, because we surgeons, we are posted on duties. Irrespective whoever is there or no, you should be firm enough or good enough to see that the ICU is taken care by your own self, so that you are in a position to train others, your youngsters. In table viva, we have instrumentation, chest X-ray, CT thorax, MRI, angio, which we will be having. People earlier days, they told, reading a CT and an MRI is difficult, sir. Should we know it? No. Now today's technology, you need to know a CT scan, how to read. You need to read an MRI. And angiogram, of course, there is no holiday for that. Coming to cardiopulmonary bypass, you will be having oxygenators, cannulas, different sizes. You will be asked, sometimes some of the examiners may ask you to draw a CVP trace, sometimes draw an arterial trace. The discussion may go in that way. So even the pulmonary artery traces can be asked for. Cardiopulmonary solution is important. If you see, you have one of the pioneers in cardiopulmonary solution, Dr. Del Nido, who has a keynote address in these 48 hours. So spend time, see, and you can question him directly. He is the one who invented Del Nido across the globe. And today there are masters. Even Dr. Anderson is there with us, who is a master in cardiac pathology. You have got only 2 classifications, any cardiac diseases, either Anderson or Van Praag. There are 2 strong heads, always 2 strong heads are there most of the time on the opposite poles. And Anderson is quite kind enough, and he has supported, helped our Indian fraternity of associations, and even during the COVID master classes, we had a lot of his series, a boot camp on the anatomy classes, which are there on the website where everybody can have a look. So he has agreed to be there, and even his keynote address is being arranged for the benefit of all students, and even the perfusionists also. And of course, even in the recent advances, we do find on topics to be taken. These are all come to if you have answered well, next slowly you go to the gold medal categories, wherein some recent advances you should be a must know. And exclusively based on the feedback of the residents, over a period of time, we have modified the score program again and again. And this time you will see during the inauguration how artificial intelligence can support a cardiac surgeon. That's in fact a game changer in the medicine history. We are implementing it shortly today with the help of a company from United States who have come forward. That shortly I will be showcasing that part of the presentation also. Well, my dear students, that cardiac surgery is undoubtedly a vast and it's growing day by day, as we all see. What you have learned today, tomorrow is not a waste. That adds on to what you have learned. But keep your mind open for learning. Keep a mind open to embrace artificial intelligence. Keep a mind open for embracing today robotic surgeries. So many things are coming up. In fact, it's a formidable and defined learning curve for every specialties. Realize it is not mastered in if you cannot master it overnight or in 1 month or 1 year or so. No. An examination leads to certification in cardiothoracic and vascular surgeries. It's a reflection just to see that you are, to label you as a cardiac surgeon. Definitely today in the world you need a certificate, and that will be provided through a period of training and drilling by we teachers. Cardiac surgery is just not about, cardiac surgery is not only operating. You need to be a master in the operating room, as I mentioned, in the intensive care, in the ward. In fact, if disaster arises, you should know how to run a pump also. That's how we were trained. If you ask me to sit, run a pump, we are ready to run a pump today. But today's specialties have come up on its own. They are their team members. So slowly we draw, but you should be knowing. Any mistakes on the pump side, you should be the first person to alert. Every time you won't have a trained person with you. As they get trained, they keep moving, Everybody wants to grow. Your job, a job of especially a person like me, my job is to keep training. They come, they go. They come, they go. That's part of my life. All can't be trainers. So that's one thing which we know. So tomorrow you may be a trainer or juniors may come. So not to, your surgery should not stop. You should be so confident that anybody who stands in front of you, you should be in a position to continue what you have been doing. Of course, sincerity and hard work, there is no holiday for this. Common issues and diseases are understood clearly when everything comes together. You cannot learn the subject without caring for the patients. That's very important. Aim for a reasonable diagnosis, but be more reasonable with your approach. That's where how you approach, the language what to speak, the dress code, how do you groom yourselves. All these things are important for examiners, okay. So all these small things, take it correctly. So mistakes here and there, they can always get you through. Always keep thinking, judge your intuition with logic before answering question, except if you don't know. Do not tell that something else wherein the examiner immediately he takes a call, oh, this is only, he is only bluffing, or that becomes difficult for examiner to set his mind back to normal in that short span of 2-3 hours. So if you don't know, you can always tell, sir, I do not know, sir. Fine, nothing harm in that. Even the examiner doesn't know so many things. Don't think that examiner knows everything. No, we are learning from students. When we conduct examinations, especially me and my teachers, we learn so many new things during the process of examination. The student tells them something, we go back and read, oh, he answered something else, this is which I do not know. That's how the mind should be open and the discussion should be healthy. Ignorance is not a crime, but willful negligence is. Then mediocrity is the wall between hard working and hardly working. That's very important. If generations before you could do it, why so you can also do it. Finally, why score? The simulation of examination, one of its kind in the country, past 12 editions has helped us to build success across the country. It is one-on-one interaction. Don't miss an opportunity to talk with your teachers. This is a platform. They will teach. Nobody tells, no, you cannot ask this question. No. So they are always here available for the next 48 hours, and in that group you can start asking questions. Because unless you ask, it's difficult for us to understand what's going on in your mind. So that is what one needs to an examination. Till date, we have crossed around 750 plus, as I told, the alumni of SCORE program, and the pass percentage is 90 plus of them. In fact, sometimes one of them commented a joke in the sense a few years back, whoever attends SCORE will pass, only 1% fail. Sir, I asked, who is that 1%, sir? They told me this. 1% are the ones who don't attend the examinations. So that was what the feedback I had got in the last 12 years. So make utilize of these 2 days, take active part, make mixtures here, as I keep telling everyone, active interaction. It's only an interaction. And 2 presenters per case can spend more time. If you want 3 of them, 3 can come here on board. We can divide among that. There are multiple teaching sessions which we are slowly planning further also. As we all know, master classes in congenital heart surgeries, cardiac morphology, myocardial protection, all these are lined up today and tomorrow. Subsequently, crash courses in cardiac, thoracic and CPB are planned. And my way of training to plan, you are the youngsters, you need this. There are, after 5 years, because once you step out, once you have a degree, to get trained is much more challenging. It's not easy to get trained in cardiac surgery. The learning curve is long. So slowly I am planning to cater to surgeons who are more than 5 years of experience, surgeons who are 10 years experience. For them, we are planning. So whether it is today's current concepts of endoscopic cardiac surgeries or robotic cardiac surgeries or minimal access cardiac surgeries, a training platform is required. So based on the taste or requirement of that particular surgeon, I am coming up with these curriculums shortly. Within this year, slowly we will be having those sessions also, wherein those senior surgeons can come down and learn themselves. So these are the platforms being made available on a platter for different category of students. A student can't become a professor immediately. If everything has a stepwise, we need to grow. So during the growth process, at that particular years or age, what is the training required? That's what we are looking at, and that's how the training is being planned. Then quick lessons on the bioprocesses, ECG, echocardiography, chest X-rays, cath studies. These are all routine, what we have been doing. All these things will be there. And this year, what's new, as I mentioned, this year we have one of the pioneers in the country, in fact, pioneers in the world. His name is Professor Mylswamy Annadurai. He is a former director of U.R. Rao Satellite Center and the former project director of Mangalayana, Chandrayaan 1 and 2. I think Mangalayana mission movie many would have seen. He is the man behind the mission. And today evening we have his session. Now, apart from the inauguration session, we planned, and in the evening we have a one-to-one interactive session. He has promised to spend the entire day with us. Of course, during the inauguration, the evening will be there. And we have a list of questions. How space research and cardiac surgery go together? What are the similarities, what we have in this? What are the challenges we face? How failure is handled, and we keep moving. Plan yourself. Do not miss that session. Be here. It's the evening fireside chat what I have planned. I request all the students, faculty, and our in-house staff members also will join in large. It will be a very good session. He failed multiple times before he landed the satellites on the moon. In fact, yesterday, 2 days back, I spent more than 6 hours talking to him one-to-one, asking his journey. And there he tells how his thoughts and ideas were made a mockery in front of a large ISRO meetings. People laughed at him. People laughed at his thoughts, his ideas, his instruments, what are required. He made multiple instruments to prove that water is there on the moon. And even NASA laughed at him. And with the instruments, he tells me, I do not know, Dr. Hirayamat, I went on thinking this is right. And one of the NASA scientists, one of the major scientists told, Dr. Annadurai, if you are right in your thinking, you will be called as the moon man of India. And he was right in his thinking. He landed a satellite where none of them in the world till attempted to land it on the other pole of the moon. And he's here amongst us today. How innovation can take you somewhere else. We at Sri Madhusudan Sai Institute of Medical Sciences, we are working in collaboration with IIT Madras to come up with India's first indigenously built cardiopulmonary bypass machine. Today we have bypass machines, cardiopulmonary bypass machine, everybody has seen. It's made by only 2 countries. It's a big monopoly itself. So Make in India, which is costing more than 2 crores plus today's machines, we are working up with a cost of less than 50 lakhs. It's already into the animal trials. Shortly clinical trials will come up. So this is just one of the innovations I am just telling you. Slowly, there are multiple things which are coming up. The machine is already ready. It's just waiting for some clearances from the government. So how innovation can be planned, whether it is cannulas, rings, vascular rings, pediatric rings, we are coming up with another innovation which is coming up. Absorbable pediatric rings for mitral and tricuspid valves, we are working on another project. So multiple things are there. So he can guide us how innovation can take a lead. And we are blessed to have him amongst us. And he has played a vital role in the Make in India robo also. He is part on the governing council and board of directors of Make in India robos. And I will tell you, with his help, they have come up with a robo at the war field. The robo goes through a drone. It flies in the war field where a soldier is being hit by a bullet or whatever it is. And recently I happened to see that video where it goes, and if there is a bleeding, suppose there is injury at the femoral artery or somewhere in the chest, the robo goes there, and the people who are sitting, there is a separate multi-equipped, separate, can call it as a large medically equipped truck or a big bus at a distance. The drone goes there, a robo comes out of the drone and goes and does the medical required emergency. And they are making arrangements to lift that soldier back into that nearest equipped operation theatre, very near to that war field. Innovations are just, it's just mind-blowing. You can't keep thinking to that extent. And he is the man behind all these things. We are really blessed to have him today. Utilize his brains to the maximum. In these next 12 hours, he'll be with us. So let's see how it goes. Evening session, we are also waiting for that. We are waiting to listen to him. Of course, Professor Robert H. Anderson, a good friend of mine, and a pioneer in cardiac morphology in London. Any medical student, as he enters medicine, nobody misses reading Anderson's pathology. And he is a master. Today, he is 85 plus, active and dynamic. He'll be there live with us. And we'll be spending quite some time to understand the morphology. Without him, we would not understand the anatomy of the heart at all. He has simplified to that level. And of course, Professor Del Nido from Boston Children's Hospital. You give Del Nido cardioplegia every day. And today, you are going to meet him. Who is Del Nido? He has agreed to spend, even the time differences are much more, he has agreed to spend time with us. We had a good number of master classes in the COVID times. They are there all on the website. You can go through that. Meantime, you can have additional information about him and interaction. Keep the questions ready. Don't hesitate. Take the mic, ask the question. Who knows? It may be a simple question. If people laugh at you also at your question, do not bother. You have a doubt, you ask. A teacher's task is to show you the path to the fountain of knowledge. It's up to you on how much you drink or of how much you merely gargle. Thank you. Once again, I invite everyone to this institute. Sarah.
Thank you so much, sir, for the welcome address. We shall now commence our first formal teaching session. May I kindly request Dr. P. A. Sitarama Bhatt to share his insights on the art of presenting cases of patients with cyanotic congenital heart diseases. Dr. Sitarama Bhatt is a retired professor and head of Department of CTVS at Sri Jaideva Institute of Cardiovascular Sciences and Research, Bengaluru. We welcome you, sir.
Thanks for arranging the slides. I never knew that I have to give you a talk. I thought that perspectives of an examiner, and I did not see the duration. I thought usually it will be 5 minutes, 10 minutes, and he made 9 to 10. I said, what can I talk for 9 to 10 minutes? He said he will provide me the slides. He dished out my slides, which I presented in UN Mehta, and asked me to talk on that. So slides are provided by him, and I had prepared it for 20 minutes. So he has consumed about 30 minutes of my time, 1 year. So he is a clever fellow. So that there will not be enough time for me to, talk nonsense. Students, I understand that the score is for the students. So I am addressing to the students who are taking the exam. Score had started 12 years back, and I am associated with that since then. I am not seeing the same face again here. I only see the teachers, like Tendulkar, okay, Shuklaji, okay. But the students are always different. That means, that shows the success of the score. The score guys do not come back here again. That means they clear their exam. They clear their exam because they get the clarity how to pass the exam. I know after your MCH, 90% of you will end up as coronary surgeons doing Rema Lima Y. But to go to that, you have to pass an exam wherein tetra is always a case. And tetra is a case which impresses the examiner if you give correct answer, fluent answer. clear answer. So these things, the slides which come later will show you, will tell you what are the questions that are asked in cardiology in TOF. Many examiners I have seen telling me why cardiology questions who come for the program like this. But the guy who appears as the first candidate will have seen, as examiners which have gone to throughout the country, it is cardiology questions. Until the time runs out, you would not have reached the surgery part at all. It ends up with only cardiology questions, which you think that for the first time in your life, you are hearing those questions because your teachers never talked about it. Because your teachers never talked about it, you are not prepared for it. And many of the students told me that this is the first time they are hearing that question because nobody asked it. So TOF, remember, it is in MCH, there is a long case and 2-3 short cases. 50% of you get TOF as the long case. Even in DNB, TOF will be stretched to a longer extent to make it as a long case. And assessment happens with how you talk, you present your case in a case of TOF. Why this happens? Even when I took the exam in 1992, my long case was TOF. Even today, the long case is TOF. The DNB exam which I took in 1992 December, I had long case as TOF. Even today, DNB exam has got TOF. Why so? It is so because I am telling it as a narration, it's a story, but all the slides are very helpful for the examination. Because TOF is a typical example of a cyanotic heart disease with decreased pulmonary blood flow. It is a typical example of that. What are the other examples of cyanosis with reduced pulmonary blood flow? They are single ventricle PS, DORV VSD PS, congenitally corrected transposition VSD PS, DTGA VSD PS, and VSD PS. I have written 6 and 7, the tricuspid atresia and PS, and ASD and PS, because there is no VSD in that. They belong to a different category of cyanotic congenital heart disease with the decreased blood flow. What is TOF physiology? You tell 100 times TOF physiology, you should have a correct definition of what is TOF physiology. In TOF physiology, blood flow to the pulmonary artery from the ventricle is obstructed. So there is an obstruction for the blood flow from the ventricle to the pulmonary circulation. That is 1. 2, see, good-sized VSD allows admixture of blood between the ventricles, and desaturated blood finds its way into the circulation instead of to the lungs. So there should be a good-sized VSD which allows mixture of the blood, and this desaturated blood finds its way to the systemic circulation. Now, how much it goes to the systemic circulation and how much it goes to the lung depends upon which system offers more resistance. The one which is offers less resistance, flow will be more to that. For example, pulmonary artery, if the resistance is less there, to the aorta, if there is a resistance is less. So remember, triology of Fallot, that is ASDPS, is not a TOF physiology. So if you say diagnosis of TOF physiology, you shall not include this ASDPS in that. Tricuspid atresia with PS is not a TOF physiology. So in TOF physiology, don't include these two. So as I said, amount of blood flow to the PA is determined by which of the two great arteries offer lesser resistance. If the lung offers more resistance, patient is more cyanotic. What are the causes of cyanotic congenital heart disease with increased pulmonary blood flow? All your T's come here. The TAPVC, the truncus arteriosus, TGA without PS. TGA with PS is your tetraphysiology. Tricuspid atresia without PS, HLHS. The common question that is asked is, which is the commonest cause of cyanosis at birth? It is TGA. So always put TGA in the top. Don't start with the truncus. In other, these congenital heart diseases, which we have mentioned with the increased pulmonary blood flow, actually cyanosis may not be clinically visible, clinically seen. They may have a saturation of 85-90%, but cyanosis is not seen. The causes of cyanosis without obstruction to the pulmonary blood flow. Typical example is Epstein's anomaly. The shunt happens at the ASD right to left because of the tricuspid regurgitation. It is not because of the reduced pulmonary blood flow. So when the examiner asks you, give me an example for, you told about increased pulmonary blood flow, you told about the decreased blood flow, the question will be, which has got a normal blood flow, no obstruction, but patient cyanosed. You say Epstein's anomaly. Cyanosis in older age without obstruction to the pulmonary blood flow. There are the other causes of cyanosis with no obstruction to the PA are SVC draining to left atrium, IVC draining to left atrium, LSVC with unroofed coronary sinus. The last one you can say or leave it. So again, why this TOF is the case which has been being given to you in the examination? Because it is one of the common cyanotic congenital heart disease case that is available in the ward. It is the common one, not the tricuspid atresia thing, now the truncus. Okay? So these statistics you should know because this is asked in the examination. This 3 to 8 per 1,000 live births, that is the word you use, per 1,000 live births. The prevalence of the congenital heart disease, not percent, 5%, 2%, 3%, no, 3 to 8 per 1,000 live births. Look at that, 50% of them are acyanotic congenital heart disease. VSD, 25%, ASD, 15%, PDA, 10%. The commonest cyanotic congenital heart disease is TOF. All the rest, you see, they are all in the range of 1%, 2%. Okay, so what is the percent of truncus? You say 1%, 2%. What is the prevalence of TAPVC? Say 2%. Fine, but TOF is the commonest one, and it is 6 to 8% of the congenital heart disease. DTGA is as common as cyanotic heart disease, but they are not there in the ward, okay, for you to be given the case, okay. Which is the commonest congenital anomaly? It is the bicuspid aortic valve. Bicuspid aortic valve, 2% of the population. That's if there are 100 people here, 2 have bicuspid aortic valve. Whether all bicuspid aortic valve end up with the intervention? No. Only about 40 to 50%, half of them may require some form of intervention during their lifetime. 50%, majority of them will go to the graveyard for other reasons, not for the bicuspid aortic valve. It is the commonest congenital anomaly, but does not come to you often. Prevalence amongst all congenital heart diseases, see, TOF is 40%. These are all the prevalence among the patients who come for surgery. If you see a surgical pediatric cardiac surgery program, about 40% of the cases are TOF. And if the adult surgeons take up surgery of TOF, 40% of the congenital heart disease you can manage. The rest may require a trained pediatric cardiac surgeon, But TOF, if you understand it properly, you can do those cases along with the ASD, VSDs, PDAs, which are left over from the cardiology side, but the TOFs will not be managed by the pediatric cardiologist. It is by you, and if you take care of them, to that extent, roughly about half of the cases you can handle. So all the rest, except the TGA, maybe 12% of the big pediatric cardiac surgery, TGA may be 12%, all the rest, 2%, 1%, 2%, 1%. So any of those diagnoses, don't use the word 25%, 30%, 5%, no, don't use that, 1 or 2% you say. These two, you say more. So again, why you have a TOF case? Survival at 1 year for a TOF is 75%. Only 25% die. Survival at 3 years is 60%. So at the age of 4 or 5 years or 6 years, which are the patients who come to you for the examination, there is good number of TOF survive that age. And 30% survive 10 years. Distinction, first class, pass class. Remember that. Because this is a frequently asked question. Naturally, if you don't operate, what happens? Survival at 1 year is 75%, survival at 60 years is 3 years is 60%, survival at 10 years is 30%. 5% live beyond 45 years. Okay? That is the survival of the rest. Except the single ventricle and CCTJ, see all of them around the range of 10%, 10%, 20%, 10%. So TAPVC, tricuspid atresia, TGA, truncus, 90% are not there beyond infancy. Okay? Again, historically it is important, the TOF disease, because it was the first congenital heart disease treated by a palliative surgery. Okay, first. So the story will be very, very interesting if you read the history of cardiac surgery. Cyanotic congenital heart disease was the first, the TOF was the first diagnosis which was treated by a palliative surgery. Helen Taussig, Alfred Blalock, Vivian Thomas proposed a surgical solution, creating an artificial ductus through left anterolateral thoracotomy in 1944 at Johns Hopkins Hospital in a 15-month-old child weighing 4 kgs. At that point of time, it was a big thing in the cardiac surgery. So much so, until 1950, about 1,000 kids, in 5 years, 1,000 kids underwent BT shunt by the same team in USA and in European countries. When they ask this question, the immediate following question, if you answer it right, will be, when did the first congenital heart surgery was treated? It was in 1939 by Robert Gross. PDA was ligated. Remember these two, 38, 30, it was published in 39. The Second World War beginning, PDA, Second World War ending, BT shunt. Okay? Easy to remember. And again, TOF was the first corrective surgery that was for any cyanotic congenital heart disease, and was done by Walton Lillehay using a controlled cross circulation in 1954. Again, the story is very, very interesting. Let me talk about it later if I get time to fill up that until 10 o'clock. For these reasons, TOF is very, very commonly kept, because they can ask you questions on history of cardiac surgery. It is also kept because the result of surgery is dramatic. A patient who was blue suddenly becomes pink the next day. The commonest cause of pink clubbing is after TOF surgery. When does the clubbing disappear? After 6 months. Cyanosis disappears on the same day of surgery. Now, what is cyanosis? The moment you say patient presents with the cyanosis, the question is, what is cyanosis? Have a nice definition. Cyanosis is the bluish discoloration of skin and mucous membrane due to increased level of deoxygenated hemoglobin more than 5 grams per deciliter in a systemic arterial blood. The next question will be, what is central, what is peripheral cyanosis? Peripheral cyanosis you'll be always answering, central cyanosis you don't answer. Central cyanosis is aorta has more deoxygenated blood. That's why it is called central cyanosis. Peripheral cyanosis when the patient is in cardiac output, low cardiac output. Okay. So to understand whether you know for me to understand whether you know the meaning of this increased level of deoxygenated blood more than 5 grams, the next question that is asked is, if an adult has 10 grams of HB, what is the saturation to produce clinical cyanosis? If there is 10 grams, patient is anemic, 10 grams HB, so by definition, if you have to have 5 grams of deoxygenated blood, patient saturation has to be 50%. 50%, if the saturation is 50% is desaturated, 10 grams hemoglobin, so 5 grams of deoxygenated blood. So for a neonate of HB of 20 grams, saturation to produce clinical cyanosis is 75%. Okay, anything, a saturation more than that will not be detected as cyanosis. But then remember, astute clinicians detect cyanosis when the reduced hemoglobin is more than 3 grams also. Definition is 5 grams, but 3 grams you make the patient to walk. The cyanosis may be apparent to your eyes, but an experienced eye will detect even less. This hyperoxic test, Tendulkar tells me not needed. Am I right? Last time you told me this is not needed. Okay. Some examiners ask you this question, I have seen, but generally, so for that you have to have a right radial ABG done in room and after 10 minutes of oxygen. If the PaO2 is more than 250, no cyanotic congenital heart disease. If the PaO2 is less than 100 millimeters, the patient has cyanotic congenital heart disease. Okay. So cyanotic congenital heart disease happens in 3 major circumstances. Pulmonary obstruction with avenue for right to left shunting, as in tetra, discordant AV connection, as in transposition, and when there is a common mixing chamber, either at the atrial level, or in the ventricular level, or in the great arterial level, as in truncus. What are the effects of chronic low oxygen saturation and cyanosis? Commonly asked question. 1, clubbing. 2, polycythemia due to increased erythropoietin production. The polycythemia end up with iron deficiency anemia, clotting disorders, risk of thrombosis is high, there is platelet dysfunction, altered bilirubin metabolism ends up with the patient having a calculus cholecystitis, there may be glomerulosclerosis, there may be gout, scoliosis, there may be splenic infarcts, brain infarcts, and pulmonary artery thrombosis. Okay, all these are, what are the types of presentation of a cyanosis? All these things you can tell. They can present with the gout. One of the examiners was very particular until he got the answer gout. Okay, gout, because it is given in book. I had not seen one. Collaterals, bleed, and the patient may present to you with hemoptysis. What is TOF anatomy? You have a large, non-restrictive, subaortic, malaligned VSD. There is RVOT obstruction at various levels. Aorta is overriding. Overriding means portion of the aorta is committed to the right ventricle. This aorta is dextraposed and has a clockwise rotation. And there is RV hypertrophy. in the examination, any question, if you don't know the answer for the given question in a tetra, try to find the answer in these three. You say VSD, examiner says, You say RUOTO, examiner says, You say overriding of the aorta. Okay, yes. Okay. So answer will be in any of these four morphological features of TOF. What is the embryological basis of this defect? It is a conotruncal anomaly. Van Praag's theory, you are expected to tell these things. Stenson's describes this as a monology, and that is the explanation given by Anderson. If the subpulmonary infundibulum is not developed, aorta tries to fill that gap. So aorta is dextraposed and anterior and clockwise rotated. In the Van Praag's theory, if these are the two bands of the trabecular septum marginalis, and if this is a conal septum normally coming in between, Van Praag's theory is everything is because of this conal septum, which is moved anteriorly, cephalad, and to the left. This causes the defect. So these three words you remember. Conal septum, is deviated to the left, caudal, and anteriorly. So that causes all the problems of the morphological problems of TOF. Syndromes associated with CHD. You usually generally say that no family history, no history of. Immediately the question will be, what are the syndromes associated with TOF? So it is Down syndrome, trisomy 21, or DiGeorge syndrome, 22q11 deletion, and you should know this. Examiner will be waking up from his sleep if you use the word TGA. TGA is a complex problem embryologically, but not associated with any syndrome. What syndrome is associated with the TGA? You start talking about Downs, you are gone. TGA is not associated with any syndrome. Chromosomal anomalies with the TOF may be a trisomy 21, 18, or 13, or deletion of 22q11. Now coming to the different morphological features of TOF and their consequence. VSD. VSD is large. Describe the VSD of TOF. VSD is large. Large VSD means as big as aortic root. It is non-restrictive, means there is no pressure gradient between left ventricle and right ventricle. The pressure remains same. Subaortic or perimembranous or both. Subaortic means portion of the VSD, the margin is formed by aorta. Perimembranous means portion of the VSD margin formed by the tricuspid annulus. Malaligned. This is very typical. If you may forget to tell all these three, the fourth one is you have to say malaligned VSD. The VSD is not, margins are not in the same plane. They are in 2 or 3 different planes. So much so I would say this VSD is not because of deficiency of any tissue. It is the margins are, the VSD is identified by its margin. By its margin. VSD may be subarterial, where there is no conal septum. Your VSD is directly underneath. Your margins are formed by the pulmonary artery and the aorta. Okay, subarterial VSD is a specific subset. Its importance is that whenever, if you see a subarterial VSD, a patient with the TOF with a subarterial VSD, these patients are likely to have a small pulmonary annulus. So much so, 75% of them require transannular patching. Okay, TOF patient you have got, who has got a subarterial VSD, the echocardiographer describes the VSD as a subarterial VSD. This patient likely to have a transannular patch in 75% of the patients. These VSDs do not produce a murmur. JVP is not raised because there is a VSD. But LV is not dilated. In a case of VSD, okay, acyanotic congenital heart disease, they ask you to tell the chamber enlargements, what are the chambers that are enlarged, and you would say right ventricle, pulmonary artery, left atrium, left ventricle. But the immediate question is, in which VSD LV is not enlarged? TOF is the one wherein it is, TOF physiology is the one wherein the LV is not enlarged. So much so, if LEDP is less than 30 ml per meter square, it is a contraindication for primary repair. You understand? So, LV, small LV is associated with TOF. In the ECG, sudden transition of R wave in V1 to S wave in V2 or V3. It is a classical feature in a case of TOF. Because of what? VSD. Okay. Usually, whenever you describe something, it is because of. You say, among the four, the VSD fits here. Okay. Why? That is a window effect. The large VSD, it detects the posterior LV wall, picks up the signals there, and that's why the sudden transition. Sometimes, examiners are also of the, to get some fun, what happens after surgery? What happens after you close the VSD? What happens to the sudden transition? What happens? Doesn't. It remains the same. Okay, it remains the same. Sometimes you may have to educate your cardiologist that it remains same even after close. In fact, you may develop, patient may develop right bundle branch block, a new problem. Okay. Surgical implications of a malaligned VSD. VSD is identified by its margin. You are not looking for a deficiency of tissue anywhere. Okay. That portion I will in the class, in the clinical presentation, I will show you. Because now I am almost at only 5 minutes left. Okay. So the second one, talking about the RVOTO. The level of obstruction may be low infundibulum, pulmonary annulus. It is associated with the subarterial VSDs, as I told you. 50% of them have a bicuspid aortic, pulmonary valve. The cusp, thickened cusp may be the reason for the obstruction. Cusp tethering may be the reason for the obstruction. Pulmonary trunk may be small. Proximal pulmonary artery stenosis may be there. A previous BT shunt would have distorted the pulmonary artery. Beyond the bifurcation, from the middle level of the LPA and RPA, in TOF, the pulmonary artery normalizes. Okay, normalizes. Commonest combination, that is 70% of your TOF patients have either, they have infundibular and a valvular stenosis. Majority of them. Measurements of the PA. Z-score. You should be aware of the Z-score. What is Z-score? Commonly asked question. And sometimes, whether it is in millimeter or centimeter is some funny examiners will be asking you, and some students give it answer as mm, okay? It is a number. Z is the number. Number of standard deviations away from the mean value for the reference population is the Z score. Up to, no, this is, if it is -2, -1, still it is considered adequate, but -3 and beyond is considered inadequate pulmonary arteries. So where do you measure the McGoon's ratio? What is McGoon's ratio? Diameter of the RPA and LPA, you add them and you measure them at the pre-branching point, because pre-branching area is where it normalizes in TOF. There won't be any obstruction there, okay? Normal is 2. Adequate for VSD closure is 1.2. Inadequate, if it is 0.8, don't do corrective surgery. Don't close that VSD. Nakata index is another one. So more severe the cyanosis, more is the obstruction at the REOT level. But the converse is not true. Less severe cyanosis does not indicate less severe obstruction, because collaterals may improve the saturation as it happens in the pulmonary atresia, and patient may be acyanotic. Okay? Now, clinical consequences of REOTO. Children with the diffuse REOT hypoplasia with the small annulus and pulmonary stenosis are cyanotic from birth, and cyanosis progressively worsens. If a patient is cyanosed from birth, a case of TOF, you know that this REOT is hypoplastic, requires transannular patch. A patient with infundibular stenosis, the onset of cyanosis is delayed. Okay? Delayed cyanosis, especially when they have got a spell, you know that this patient has got an infundibulum. Pulmonary annulus may be normal, may not require a transannular patch. What is a spell? On feeding, on crying, or on exertion, or on exposure to any event which reduces the SVR, an increase in the rate and depth of respiration, resulting in deepening of cyanosis, limpiness, and lethargy, frequently leading to syncope and unconsciousness, occasionally convulsion, and sometimes death. You should include all these things: syncope, unconsciousness, convulsions, and death in your definition, apart from increase in the rate and depth of respiration. Okay? You tell this definition without making any mistake, your examiner will be very much impressed. He'll directly go to the surgery, which is your strong point. Okay? But, okay? How do you treat cyanosis, cyanotic spell? Not important in nowadays, the others manage it, but some people do ask these questions. Okay? But in that, you remember, especially in the Indian context, anything which reduces the SVR produces a cyanotic spell. We have got a custom of showing the small baby to son, especially in the tribal population. We have got a custom of grandma giving hot water bath to the kids, and this is the time they develop the cyanotic spell and come to the hospital. If you ask your patients the history in detail, this is what has made the parents to notice the cyanosis. A hot bath, and especially the grandmas, the greatness of the grandma is assessed by how hot is the bath, the water she uses for bath. Okay, and that precipitates cyanosis. Even in your books it is there, anything which reduces the SVR. So when you send home with a patient with a cyanotic spell, please tell them not to give hot bath. Okay, cold water bath, not hot bath with a cyanotic spell. Okay. So conditions which produce spell. TOF physiology, if a patient has got a spell, typical spell, which fits into that definition, these are the three diagnoses. TOF physiology, tricuspid atresia, pulmonary atresia. If that patient also has squatting, then the diagnosis is in the history itself. Why do you say TOF? Patient has got cyanotic spell, typical, and it is relieved by squatting. That's why I say it is TOF. Yes. So, spell plus squatting is pathognomonic of TOF. What is squatting? It is instinctive. Patient does it. The baby does it on its own. Nobody need to teach. It is instinctive. A posture where the children sit with their lower limbs flexed at hip, knee, and draw them towards the chest, especially after walking some distance or after exertion when they feel fatigued. Okay, this is squatting. Have the perfect definition, tell it, vomit it out in the examination, pass MCH, and then do Ruimalima Y. Okay. 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 So, spells and squatting is pathognomonic of TOF physiology. Clinical consequence of RVOTO. So, patient will have a crescendo, decrescendo murmur, ejection systolic murmur at the pulmonary area or little bit below that, depending upon the level obstruction. This is the only murmur patient has. VSD does not produce a murmur because there is no gradient across the VSD. This is the only murmur you are going to talk. Don't talk about VSD murmur. Lower the intensity, severe the obstruction. Absence suggests, yesterday you have seen patient had a murmur, today there is no murmur, patient is going for what? Spell. Patient is going for spell. Patient did not have spell, but there is no murmur. What does that suggest to you? Diagnosis TOF, not hearing a murmur, patient not in spell. You are hearing a murmur in the back. Okay. What is the diagnosis? TOF with pulmonary atresia. TOF with pulmonary atresia. You understand? No murmur, but no spell. Okay. Murmur in the back. There is no parasternal heave, no precardial bulge, even if there is RV hypertrophy. Your RV is ejecting into the aorta. Clinical consequences of RV. Okay. So, X-ray chest shows oligemia. One more. Okay. Okay. Overriding of the aorta. The third feature of your TOF morphology, overriding of the aorta. Aorta is, what is the meaning of overriding of the aorta? Aorta is biventricular in origin. Overriding is associated with more anteriorly placed aorta, clockwise rotation of the aortic reed, and enlarged aortic root. The question that is usually asked, as soon as you open your chest, what is so obvious in a TOF patient? The big aorta, anteriorly placed aorta, dilated aorta, and the origin of the right coronary sinus more towards the, away from you than towards you. Okay? Overriding ranges from 30 to 90%. Degree of overriding related to degree of malalignment of infundibular septum. More deviated, more overriding, because it has to fill that space. So more, if override, they say 80%, 90%, the cardiologist opens, or if you see the overriding is 80, 90%, this patient likely to require a transalveolar patch because the patient has got REOT hypoplasia. In contrast, in DORV, there is no aortomitral continuity. Both aortic valve and pulmonary valve are in the same plane. Usually this question is asked how to differentiate between DOF and DORV. These are the two things you are going to tell. No aortomitral continuity, and both of them are in the same place. And generally, these questions will be there about the DORV thing. Why DORVs do not have cyanosis? Use the word streaming of the blood. Okay? Overriding of the aorta, what are the clinical consequences? A2 is loud and single. Patient may present with paradoxical embolism. Even though there is PS and RVH, parasternal heave is not seen. And older patients, RV is subjected to high SVR and RV fails. In older patients, patient may develop AR. And here, AR, don't use the word Venturi effect in tetra. There are certain things you should not use in TOF. One is Venturi effect for the reason for AR, because Venturi happens with a high gradient, small VSDs, not with TOF. In TOF, aorta is dilated, okay, and there is no support beneath. And higher SVR, without support, it leaks. No Venturi effect. Don't bring in Venturi effect. The other thing which you are not going to tell in the examination in a TOF is pulmonary hypertension. Pulmonary hypertension, as far as you are concerned, no pulmonary hypertension, happens. It is a disease with a reduced pulmonary blood flow. Your PA pressure expected to be, except in certain circumstances, but you don't worry about it. Don't bring in, what are the modes of death after TOF surgery? Don't use the word pulmonary hypertensive crisis. You will be in crisis, okay? Severe crisis, okay? Okay, that is the consequences of RV hypertrophy. Means what happens in an examiner asks you the question wherein the answer is RV hypertrophy. For example, apex is RV type. Why? RV hypertrophy. X-ray typical boot-shaped heart. Why? RV hypertrophy and PA absent. Right axis deviation in ECG, RV hypertrophy. Parasternal heave is absent because there is aortic override. Okay, there is no precardial bulge because there is aortic override. So in nutshell, TOF physiology patient will have exertional fatigue. Don't use the word dyspnea, you get into trouble. Dyspnea, use the word when there is a left LA pressure increased pulmonary venous hypertension. Here, though the patient may say breathlessness, probably if you, on deeper questioning, it is a fatigue which they call dyspnea. So use the word fatigue. Don't use the word dyspnea. Spells and squatting, symptoms of complications of polycythemia, cyanosis, clubbing, apex well within the limits, silent precardium. Examiners are very, very interested in hearing the word silent. You say silent precardium, your examiner will be silent. On inspection and palpation, RV apical impulse, ejection systolic murmur in the pulmonary area, small heart oligemia, pulmonary bay is present. Cyanotic congenital heart disease with increased pulmonary blood flow. What are the truncus, TAPVC, all those things? They will present with these. Though these symptoms, don't put it into tetra symptoms. So increased pulmonary blood flow, you have respiratory symptoms. Cyanosis is mild. Babies are sick with congestive heart failure. They have exertional dyspnea, recurrent LRTA, pneumonia, diaphoresis, active precardium, Harrison's sulcus, obvious cardiomyopathy, precardial bulge. Okay? Don't put any of these things in tetra. Associated anomalies. Hirametre, can I continue? If you want to start the case, I will stop here. Huh?
Case, yeah.
Okay. 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 Yeah. This is the last one, yeah. We can ask all these things. Okay. Oh, okay. One thing I am very, if I come as your examiner, the question which I'll definitely ask is, what is the basis of TOF with embryological basis of TOF with absent pulmonary valve? The question that is asked is, absent pulmonary valve, what is the incidence of PDA? Incidence is 0, because embryological basis of absent pulmonary valve is absence of PDA in the neonatal life, in in the prenatal, in what do you call it, in fetal circulation. Okay, there is no PDA, so the blood from the right ventricle is not finding a way to go to the descending thoracic aorta. Lung is offering resistance. It regurgitates into the right ventricle and comes to the descending thoracic aorta through the overriding aorta. So for survival, absent PDA, for survival of the baby, you require a overriding of the aorta. So because the patient has got a overriding of the aorta, baby is live. Okay, it is because the column of the blood, the regurgitant blood in the REOT is preventing from pulmonary valve to develop. So absent pulmonary valve syndrome is not associated with PDA. Okay, thank you.
Thank you, sir. That was very well done. We shall now move on to our first clinical case presentation. The first case presentation shall be that of a cyanotic congenital heart disease. I request our examiners to join us. We have Professor A. Sampath Kumar, retired professor and head of Department of CTVS from All India Institute of Medical Sciences, New Delhi, joining us online. Dr. P.S. Sitharam Bhatt. He'll be in person. Dr. B.R. Jagannath, Honorary Senior Pediatric Cardiac Surgeon at Sri Madhusudan Sai Institute of Medical Sciences and Research, Muddenalli. He too will be joining us online. I also request Dr. Shiv Kumar Shivalingam, Chief of Pediatric Cardiac Surgery at National Heart Institute, Kuala Lumpur, Malaysia, to join us online. And we have three residents presenting this case, Dr. Janvi, Dr. Abhik, Dr. Rishi. The time allotted for this session is 50 minutes. The first resident will present the history, clinical examination component, and the second will present the investigations, operative management aspects. Both will thereafter contribute to the discussion on management, all three of them. So please note the buzzer will be sounded at 20 minutes, 40 minutes and 50 minutes. Faculty present offline have been provided with a scorecard. And let's begin this session.
Very good morning to everyone present here, respected faculty and my colleagues. Today we are going to be presenting a case on congenital cyanotic heart disease. My patient, 11-year-old male hailing from UP, informant being his mother, was brought to the hospital with the chief complaints of bluish discoloration of skin and mucous membrane since 7 months of age and recurrent episodes of fever since 1 year of age and episodes of fatigue on exertion since 2 years of age. My patient was apparently all right, 7 months till his mother noticed bluish discoloration of skin and mucous membrane when he was first at the age of 7 months.
I want to know whether she has understood an 11-year-old patient coming. So has she understood what does it mean after his talk particularly?
Yes.
11-year-old patient coming to you. So have you understood the meaning of that word 11-year-old?
What is the
No, sir.
implication of patient's age of
11-year-old.
If the baby presents at 3 months,
1.1 year, 11 year and 110 years. What is the difference? Same baby suppose had presented at 1 year. What would have been the thoughts in your mind? I don't know the case. None of us know the case. What thoughts come to your mind? All of your mind. 1 year old. Just now we gave a talk.
Congenital.
Sorry?
We are dealing with
What kind of
Give the
congenital cyanotic?
mics to this side.
A very severe form of congenital cyanotic,
heart disease.
which forces the parents to bring the baby to you. Now, which are these, forget congenital, cyanotic heart disease, who will come to you at 11 years?
TOF can come, sir.
Understood? So, don't just say 11 year, 1 year, 2 year. It means something. Understood?
Yes, sir.
Apart from TOF, which other baby of cyanotic heart disease will present to you at 11 years? I'm talking about India.
Sir, TOF, VSD-PS.
Cyanotic heart disease. TOF physiology.
TOF
So all
physiology.
that VSD-PS, PS-VSD, DORV-VSD-PS, all included. Any other group totally?
Mixing lesions, sir.
Now, this is what he was telling. Talk point blank, absolutely bullseye, continuously. Don't say mixing lesion. Then I will ask which. Then you will say at atrial level. Then I will say which. Then you will tell the answer. So straight away say intracardiac or supracardiac TAPVC without pulmonary venous obstruction. Okay? So
Yes, sir.
that word means something. Next you said mother says baby was all right till.
7 months of age.
So have you understood the meaning of that?
Late onset
Suppose
cyanosis.
the mother had said baby is bad since birth.
Then it goes towards TGA.
TGA. Anything else?
Truncus
Sir
arteriosus.
doesn't like truncus at birth. Sir gets angry at birth.
Obstructed
By the way,
TAPVC.
50% of the truncus may present at birth.
Obstructed TAPVC.
Obstructed TAPVC. Tendolkar age, Anil Tendolkar. T and age. Tricuspid atresia with
Aortic
severe PS
atresia.
or pulmonary atresia. So all severe form, aortic atresia. Understood?
Yes,
So
sir.
every word you speak means something. And I want to ensure that have you understood that meaning. Okay? Chalo, go ahead please.
My patient was apparently all right till his mother noticed bluish discoloration of skin and mucous membrane, first seen at 7 months of age. It was noticed when the baby was giving water bath to the child. It was relieved when she took him on his shoulder. Later, at 8 months of age, baby
See,
had.
my surname was is Tendolkar. So I was always last. So examiner is in hurry to go home. He has to catch flight. He has to catch train. So we are not interested mother giving hot bath or grandmother was giving hot bath. This cyanosis which apparently noticed after exertion over a period of time at the age of now story is 11 years.
Now 11 years.
So
sir.
now what is the tolerance of the patient?
Sir, now patient has intermittent episodes of cyanosis on exertion.
What is the tolerance? Child can go to school, cannot go to school.
He can go to school, sir.
Understand? That is more important. Now child is 11-year-old.
Yes, sir.
So don't start telling me at the age of 7 years, 7 months, how much was the sign? Over story. Okay? Number 2, cyanotic spells.
He had one episode of cyanotic spell.
How many years back?
So at the
Child
age
is
of-
11-year-old now.
So at the age of 8 months, sir.
8 months. So what is the importance to you as a surgeon?
The
Last 10 years, no cyanotic spell. So this child requires any emergency treatment, training, mother educating?
No.
Understood? So whatever you speak should have a relevance. And I think you have totally missed to write down that today child status is cyanosis, no?
No, yes, sir.
So what is the today's child status? Can go to school without any spell. Why the spell has disappeared?
RVO2 has become fixed, sir.
Fixed, number 1. 2,
Collaterals must have developed.
3, more important.
Child has developed squat.
Child has understood after walking so much distance, get a spell or feels extremely tired, so they reduce their exertion. Okay? Chalo. Next.
At 2 years of age, patient had repeated episodes of fever for which they had consulted, and then he was diagnosed with congenital heart disease and was advised surgery. But parents were scared and were not ready for surgery. Then he developed.
So is this fever at the age of 2 months, 2 years of age, any relevant today after 7 years?
No, sir.
So what you can do as a good girl? Don't tell. Okay? For some peculiar reasons, tetralogies are notorious for respiratory tract infection.
Infections.
Nobody knows. Sir, am I right?
Yeah, yeah. The respiratory tract infection is nothing to do with the
With the
patient's
patients.
problem.
It's nothing to
Like
do with
any other
increased
child getting some-
increased
Increased
blood
blood
flow. No. There's somehow some sort of decreased resistance and they just develop repeated chest infection.
The moment you say respiratory tract infection, what comes to the mind is increased pulmonary blood flow. And this is a situation where there's a decrease in pulmonary blood flow, something unassociated with. And otherwise, you will be dragged into situations of TOF with increased pulmonary blood flow. You understand?
So best thing,
is to avoid.
not to tell as a chief. You declared it as a chief complaint, isn't it? Every word of you speak is recorded here. So this is not even deputy chief. Just omit. And this is 11-year-old baby and complained for last 10 years. So we are more interested in today's status. Okay? Anything else you want to tell in complaints?
So dyspnea, fatigue on exertion.
You forgot that cyanosis, you must categorically mention cyanotic spells and complications of TOF. Sir gave a big list of complications of TOF. Now all mistakes she does, you are going to be responsible because you had given a talk and you were head of the department of Jayadeva. He was your teacher that time?
No,
Say yes. Say yes.
Yes.
Huh? So you are going to be.
I'm not into that.
So that is more important. 11-year-old, story of 10 years, we are more interested, has the child developed any hemiplegia, cerebral abscesses, undergone treatment? No. Okay?
Abdominal pain.
So there is history.
Just for knowledge, what are the causes of CNS problems in tetralogy of fellow?
Cavernous sinus thrombosis, brain abscess.
Maybe due to dehydration, sir. Maybe due to dehydration.
Very good.
There is a increase in the hematocrit level, and so thus leading to cortical venous.
So venous thrombosis, various types.
Then there may be brain abscess because of the right to left shunting which is happening.
So paradoxical shunts. That is, according to me, more common, paradoxical shunts. Paradoxical embolisms.
Embolism.
Okay? Not paradoxical shunts, paradoxical embolism. It's far more common. Anything else?
So because of chronic hypoxia, there may be global.
They are very intelligent. Chronic hypoxia can make them cardiac surgeons. That's the only thing possible. Otherwise, they are extremely intelligent patients. Anything else? These lung infections, because of coughing, can result in embolism to the brain through the vertebral venous plexuses, very rise in pressure. Okay? Chalo, good. But don't forget to give paradoxical embolism as a quick cause of CNS problems in tetralogy. And don't forget to include repeated episodes of cyanotic spells resulting in convulsions. Sir mentioned that, convulsion.
What is the name of this plexus? Batson's plexus.
There is no history of headache, seizure, syncope. There is no history of hemoptysis. There is no history of
Why there is hemoptysis in tetralogy?
bronchial artery can be ruptured.
I wanted this hemoptysis not because of aortopulmonary collaterals. It is because of submucosal collaterals, not that classical MAPCAs. They never bleed. They are submucosal collaterals. Have you ever assisted a tetrad?
Yes.
See the number of collaterals right from pericardium onwards that have developed. So similarly, there are lots of submucosal collaterals and their erosions because of infection. That's why that hemoptysis is never only blood. Okay?
There was an episode of epistaxis and bleeding gums 1 month ago for which the patient sought medical treatment. Other than that, there is no history of prolonged fever requiring admission, petechiae, painful joints.
Suggesting? You are trying to suggest?
Infective endocarditis.
Thank you.
And there is no history of limb swelling or puffiness of face, suggestive of failure. Past history, patient is not a known case of pulmonary TB or bronchial asthma. He was hospitalized for a cath lab procedure 1 month ago as advised by the doctor.
What past history tetralogy fellow known to have? Tuberculosis.
Tuberculosis.
Okay.
And other than that, there is no history of any surgery or procedures done in the past.
I'm going to speak in my talk on presenting a VAL case, but recently examining DM card students, patient undergoing procedure for the same disease, they tell only in past history, which according to me, the story should start from that, and then they should tell underwent this procedure and now the patient has this problem. So the more important in past history, patient has undergone any procedure for this.
No, sir.
So if this patient had undergone, say, BT shunt at the age of 6 months, suppose, then your story should have started, BT shunt should have been the part of current
Okay.
history. And story should have started 6 months age, BT shunt was doing well and now has got these problems. So don't try to tell, the lesson to everybody, don't try to tell a procedure done for the same illness as a separate entity in the past history. The patient had undergone balloon mitral valvotomy and they just made a reference. 10 years back, BMV done. So the story starts from that BMV. Okay? What palliative procedures tetralogy can undergo?
BT shunt, PDA stenting,
Procedures, not surgeries.
PDA stenting,
PDA stenting,
pulmonary valvotomy,
pulmonary valvotomy, if that is the only cause of RVOT obstruction. Branch pulmonary artery stenosis dilatation and stenting. Okay? So you should be aware what various palliative operations are performed, at least in India. Go ahead.
birth history. The mother had a normal full-term vaginal delivery.
This is a controversial part at the age of 11 years. Cardiologists, even a 25-year-old, so valvular heart disease, they start talking about birth history. Full-term normal delivery, as if the 62-year-old male patient remembers whether I was a full-term normal delivery or not, or it matters. So this question will be asked to you, okay? So best thing is to tell, not relevant.
Not relevant.
What does this mean? So what does that mean? Should I stop? So what is your diagnosis from the history?
It is congenital cyanotic heart disease with
Tetralogy of
tetralogy of
physiology.
physiology.
Why?
Late onset,
This case.
late onset cyanosis
Late onset cyanosis.
with hypoxic spell with squatting.
No history, no, you said.
No, sir, squatting, sir, there is. Yes, sir, history.
Anything else? First question I asked you. A child living to the age
Age of
of
11 years.
11 years. First itself is a... So don't forget every word you speak has a meaning. Okay? Very good. Next is what?
Oh, examination.
General examination,
What
sir.
is your name, dear?
Sir, Abhik De. Abhik De.
Abhik. ABHIK. Last time you had come for some... We had interaction because this name I had question.
ICTS, sir.
Okay.
Who is there?
Okay.
Sir, general examination. The patient is alert, playful, active also. With patient's height is 121 centimeters. Weight is 17.7
This
kg.
playfulness is, you are happy or unhappy? See, you are making some comment which matters to me a lot. A tetralogy is playful and another tetralogy is lying down in the bed, in the ward. Which of the two you will like to operate as your first case?
Playful.
Playful. Playful indicates what? Good saturation.
Good saturation.
At rest at least. And even doing play always. That's why he is playful. He or she is playful.
The height is 121 centimeters, sir, and weight is 17.7 kg. The height for age is less than third percentile. It is below -3 standard deviation, and weight for age is again less than third percentile. That is below -3 standard deviation, suggesting that there is stunting and also wasting. The BMI is 12.1 kg per meter square. That is less than third percentile. Next, the patient does not have any pallor, icterus, edema.
Now, this is a difficult place of talking about pallor in a tetralogy of Fallot. And I am going to tell in my talk, I am not telling everything I am going to talk. Don't be Raja Harishchandra. So best thing is not to talk about it. Unnecessary. Best part is examiners also don't know the answers. They will just ask you, how do you diagnose pallor in the case of tetralogy of Fallot? What is the definition of pallor in a tetralogy of Fallot? Understand? So pallor, normal hemoglobin should be with respect to their saturation. Okay? So best thing to,
Oh my God.
thank you.
Okay, sir.
And same thing about icterus. In the presence of cyanosis.
Clubbing is present with grade 4, sir.
4 by
4 by
4 by 4.
yes, sir.
So that is drumstick fingers.
Drumstick fingers, sir.
Okay, good.
Heart rate is
So
7.
what does that tell you?
It is a chronic hypoxia.
Chronic hypoxia. Anything else? Severe hypoxia.
Severe.
Which cyanotic heart disease never go beyond 1 by 4 or at the most 2 by 4? TAPBC. You will never ever see drumstick fingers. Eisenmenger's, you never see drumstick fingers. So drumstick fingers tell you it's a very chronic, not only chronic, very severe. Okay?
And this clubbing does not disappear with surgery.
More
It
than
involves
grade
both.
2 doesn't
Not
disappear after surgery. So if the mother starts telling you this cyanosis is since last 2 days, 3 days, she is bluffing because of the drumstick fingers. Just keep this in mind. Then clubbing is never, liver diseases, pulmonary AV fistula is never more than grade 1. Just remember this. So just 4 by 4 is not fun. It tells you all these things. Okay? Go ahead.
Heart rate is 76, sir, in sinus rhythm.
So clinically you should say regularly.
Regular. Normal volume character. There is no.
This patient had heart rate of 52. What else you will ask the patient?
Whether he is taking any medication, sir.
Okay.
Correct.
The saturation is 70.
Do you know any congenital heart disease where cyanotic heart disease, congenital, 11 years and rate 52?
CCTGS.
Very good. CTGA, VSD, PS. Always give complete answers.
Why the rate is low there?
Sir, there is associated heart block in CCTGS.
Very good. Excellent.
The saturation is 74%, sir, in room air. The blood pressure measured is 108 by 70 on both sides,
Good.
sir.
After every sentence you look at the examiner, I will start scratching my head and create some question to ask you.
If it is 110 by 40, inference, if it is 110 by 40.
So there is associated air or there is associated collaterals.
Very good. AR is known to develop after how many years? 10 years. Okay? So don't talk about AR if the baby is couple of years old. Okay? So 11 years possible. Patient may have AR or PDA or shunt functioning.
Coming to systemic examinations.
Don't say coming to and next, just continue.
Just continue talking.
Okay, sir. Cardiovascular examination, sir. On inspection, the chest is bilaterally symmetrical There is no dilated vein or scar, a sinus present. The apical impulse is seen in the
Is
left.
seen,
It is noted.
is seen?
It is noted, sir, in the left fifth intercostal space at the mid-clavicular line. There is no suprasternal or epigastric pulsations seen, sir.
By the way, on inspection, the correct word is quiet
Quiet
precordium, not silent precordium. Quiet precordium. Okay?
Palpation,
Why tetralogy precordium is quiet?
there is because of the large unrestrictive VSD. Because
So
of
there is
which-
no RV hypertrophy since birth. So there is no RV heave. Then apex impulse is usually, because it is RV type, is tapping in nature or normal. Okay? So precordial activity is formed by RV, body, apex, dilated aorta, pulmonary artery dilatation. So all the four things which give rise to precordial activity just are not going to show you. That's why quiet precordium. Other causes of quiet precordium?
if there are emphysematous lungs,
Emphysematous lung, thick chest wall,
chest wall.
large breast, हो गया. Cardiac, constrictive pericarditis. Okay?
1 minute. What is the RV pressure here?
it will be same as the systemic pressure.
Don't prompt him from behind. Here, let him answer.
Mic से बात करो.
Mike, to
It
speak.
will be same as systemic pressure.
Same as one.
Not maybe,
It
is.
So what was the systemic pressure?
108 by 70.
100.
So this much RV pressure, still no activity. Why quiet precordium?
Because of the large unrestrictive VSD, it is unloading onto the aorta.
Both the ventricles
Both
are
the ventric-
functioning, emptying in one common chamber, so it functions only like a single contracting chamber. So there's no difference. Whereas when you have a VSD in normally connected great vessels, the pressure difference is there. So you get a right ventricular heave.
And this is hyperplasia. So the RV doesn't fail that early and quickly. So it is used to this pressure since intrauterine life. So no precordial activity.
See, we'll come back to these pressures once again when we correct this deformity, the anomaly. So remember, this RV pressure will be there from the diagnosis till the end.
Okay, good.
There is no parasternal heave, sir. No epigastric pulsation. No
This is all inspection.
palpation.
Beta, when you said quiet precordium, no parasternal heave, why do you want to mention parasternal heave?
So best thing is to say what? Inspectory findings confirmed. So we have understood. Now tell something extra you found on palpation. That is the apex.
The apex bit. Apex bit is at the left fifth intercostal space at the mid-clavicular line to the tapping type of apex.
So what two things you have conveyed to the examiner?
The heart is not enlarged.
Very good. So it's a concentric hypertrophy. Heart is not
Concentric
enlarged.
hypertrophy.
So which are the conditions which are, disease is very severe but heart not enlarged? Are these concentric hypertrophies? Okay? So PS and classical is tetrad. Go ahead.
Percussion. The right heart border is at the right sternal border. The left heart border corresponds to the
Now,
apex.
normally nowadays, students don't talk about percussion. But if you talk percussion, talk properly. First thing is, liver dullness is in the right fifth intercostal space.
Yes, sir. The liver dullness.
Percussion starts with liver dullness in right fifth intercostal space. What things you have told to the examiner?
Situs solitaire.
Situs solitus. And number two, there is no viscereptosis. Okay?
The stomach tympani is on the right side.
Ayo,
Sorry, on the
right
left
is
side.
wrong.
On the left.
Left is right.
Left side. Sorry, sir.
stomach tympani
It's on the left side.
on the left side.
The right heart border
Very
is on
good.
the right sternal border, and the left heart border
So what
corresponds to the
right heart border is retrosternal. So what have you told the examiner?
right. There is no enlargement of the right atrium.
Very good. No enlargement of right atrium. Excellent. Go ahead.
The left heart border corresponds to
We
the
are
apex.
praising him.
Auscultation. S1.
This is what Dr. Shukla is trying to tell you. Don't keep on declaring auscultation. Sir, just go on
Continue
talking. Dr. Hiremat also told that it is telling a story. When the one thing, just keep on, we understand.
S1 is normal. S2 single, loud, the right second intercostal space. There is
Entire congenital heart is on second sound. And it has to be answered in a very standard manner. The second heart sound is single. Have you written down?
Yes.
Word single,
Single.
anywhere?
Yes, sir.
That should come first. And is formed by, who is contributing the single heart sound?
the
Aortic
valve.
component. Why aortic? Best heard in
The right
aortic,
aortic area.
the left third intercostal space. P2 is absent. This has to be told in this order. Okay? In ASD, what will you answer? ASD, simple ASD. Second heart sound, the S2 is
Wide space.
wide and fixed split with P2 component loud. This is how the answers will be given. Why P2, S2 is single?
Because there is pulmonary stenosis and also doming of the pulmonary valve, and also because
So
the
no
aorta,
generation of second heart sound from pulmonary area. Two,
because the aorta is
sir told no, out of the four, one has to be answered.
there is
Sir told lots of tricks, but you did not pick up the tricks.
there is overriding of the aorta, and there is
So
anterior deviation.
overriding is very important. It is not only just going anteriorly, but rotating anteriorly. RCA is very well seen in tetralogy fellow. Tomorrow when chest is open, you go and see. RCA opening is very well seen because aorta is rotated. Okay?
See,
Go
one
ahead.
question here now, this rotation, sir mentioned clockwise rotation of the aorta. Now I want to know who all have understood this clockwise rotation. What is this clockwise rotation?
Clockwise as seen from where?
Or from where? From the head you see or from the feet you see?
Feet.
So remember, it is from the foot end of the patient, the aorta is there, pulmonary artery is there. So it is clockwise rotation. So the aorta comes closer to the sternum. That's what we are saying.
That's why what makes second heart sound as the single one. Any other condition, single second
You
heart
all have
sound?
understood this
Though
clockwise
pulmonary
rotation.
sound present,
Truncus or anterior,
truncus, there is single sound only.
single sound. Pulmonary atresia.
Transposition. Aorta is anterior, pulmonary is posterior. Pulmonary sound not heard. Just like your friend who is transposed posteriorly is not heard. Okay? Go ahead.
There is a ejection systolic murmur of grade 3/6, which is harsh, crescendo decrescendo, which is
Now,
best.
see, moment you say ejection systolic murmur, it is understood. Okay?
Okay, sir. Best heard in supine position with the diaphragm of stethoscope.
More important, duration. Mild PS, what do you think? Murmur will be long heard or short heard?
Long,
Long heard. And as the PS becomes severe and more severe, the duration of murmur will become
shorter.
shorter. And sir asked you that murmurs totally disappears. RVOT obstruction, very, very severe. Only RBC is going through RVOT obstruction. So what is this?
This is very short duration murmur, sir.
Best heard
Best heard in the in the left third intercostal space
Why I am asking this?
because of the level of the obstruction, sir.
Very good. The level of obstruction, sir mentioned, the murmurs will be in different positions. Okay?
Yes, sir.
Os infundibular obstruction, third, fourth junction, you will get the murmur. Then only valvular stenosis, second space. Pulmonary artery, even higher. Okay? So the murmur where it is heard will tell you that. Go ahead.
There are no other murmurs appreciated, sir.
Which are
Like,
the murmur?
There can be continuous murmur present on the
फटकन जल्दी बोलो यार,
on the
continuous
on the
murmur or
interscapular-
PDA.
on the interscapular area, on the
First PDA.
PDA, sir.
PDA, what you're saying, interscapular area, I'm not very sure.
That is the collateral
अरे PDA
PDA
clavicle बोल ना.
on the supraclavicular area PDA. That murmur is not heard. Sir.
Excellent.
And behind,
Collateral, sir.
and one more place,
On the deep axilla.
Axillae
Axillary
of
area.
peripheral pulmonary artery
Peripheral artery.
narrowing.
so when you don't have a ejection systolic murmur, which means you're dealing with? You're dealing with?
Severe tetrad.
Pulmonary atresia, that is the case where you have to mention this. So you have to make sure that you get into the habit of auscultating the interscapular area and the axilla to make sure that we are not dealing with major aortopulmonary collaterals, and the axillary auscultation tells you what?
I mean,
Branch pulmonary.
Branch pulmonary artery stenosis, okay. All right.
okay, go ahead.
How frequently you see branch pulmonary artery stenosis in
Yes.
tetra? In which subset of tetra you see branch pulmonary artery stenosis?
In absent pulmonary.
Atresia, not in tetras. Tetra is a forward flow. If they have a branch pulmonary artery stenosis, what is the reason? Especially in a 11-year-old baby. As the age progresses, it's more and more prevalent. Thrombosis, pulmonary artery thrombosis. Typically, in TOF, there is no peripheral pulmonary artery stenosis. They are associated with pulmonary, TOF with pulmonary atresia. In TOF, you see that it is a consequence of pulmonary artery thrombosis because of polycythemia. Okay?
So you have finished auscultation?
Yes, sir.
Air entry equal,
Air entry is
both,
equal,
both
both
sides.
sides.
Okay? Chalo. Your diagnosis is fallow physiology. And what you mean by fallow physiology? You have to tell that. One very question commonly asked by examiners is, if this is a pathology, why call it physiology? Understand? So you should tell that by physiology we mean the flow of blood inside the heart. So it's a VSD with RVOT obstruction. I beg to differ with sir. Tricuspid atresia with PS behaves like a tetralogy fallow physiology. So it should be considered as fallow physiology. And the murmur is through VSD. Also could be. Okay? Question will be asked to you, why on examination you say this is tetrad? Same question asked to her, same question to you. Start, if you can look inside and answer, no problem. Another way of answering is most classic to general. There are two ways of answering. Depending upon the examiner's liking, disliking, you can answer. Simplest is go from general examination, precordial examination, like this you go.
From general examination, my positive.
But you don't say from my general examination. You just keep on talking.
Patient has cyanosis with grade 4 clubbing.
Central cyanosis.
Central cyanosis.
Grade 4 clubbing. Very good.
Quiet precordium on
Excellent. Quiet precordium.
apex bit is
JV, general examination, JVP
not raised.
not raised. Quiet precordium. Excellent.
The heart is
Small heart on percussion.
On percussion, the apex bit corresponds to the
Small heart, you have told a conclusion to the examiner.
on auscultation. there is a ejection systolic murmur at the left third.
First sound. See, Anil Tendulkar just goes by the format. First is sound. Heart sound.
S1 is normal, single
Array, S1 normal is not important.
Single
S2 is
single
and formed by
formed by the
A2 component.
A2 component.
Next, ejection, systolic, murmur. Understood?
Yes, sir.
So these are reasons why this is tetrad. Will you call this severe tetrad?
I'll call it severe tetrad.
So what is that which makes, out of the four things sir showed, which is the one which makes it severe and not severe?
The short duration of the
Which is that four component of tetrad?
RVOT.
RVOT obstruction. So now tell me why you call this as severe tetrad?
Because of the short duration of ejection systolic murmur.
Short duration ejection systolic murmur. Array cyanosis grade 4.
Grade 4 clubbing.
So
severe
must be
cyanosis.
very severely cyanosed. Grade 4 clubbing. Okay?
Yes, sir.
And then duration of the murmur. Excellent. And murmur is soft. Less than 3/6. Correct?
Yes, sir.
If it is harsh murmur with thrill, unlikely to be a severe tetrad. Okay?
Yes.
Chalo. Next is tang tang. Tang tang. Next is
Investigations.
Another 10 minutes, we need to wind up, sir. The
Yeah,
chief guest has.
we are absolutely on time. I'm constantly looking at her only. She is my monitor.
Yeah. She looks also scary only, sir.
The anesthetist, I got natural love, so don't have to worry. Go ahead.
This is a standard 12-lead ECG with a heart rate of
See, 10 minutes, so don't waste time on standard 12-lead ECG.
heart rate is 80, sir, in sinus rhythm with right axis deviation with a inverted P wave in V1 with a
Now,
normal
right axis deviation, how much?
degree of 150. I'm getting, sir.
Just
Positive
actually
150.
measure,
Yes, sir.
I think it is 135. See R wave in AVF, move that cursor, R wave in AVF, 5, 10, 15, 5, 10, 15, 18.
This is 13, that is 16, sir.
Correct. Which one is AVF?
Here, sir.
Not this one, that is 3. Okay. Okay. How much?
One.
13. And 1?
That is 16.
16.
17.
13 and 16. So it will be how much?
150.
Correct. So why it is never 179 or 118 tetralogy? Because both the ventricles are subjected to same pressure. So their hypertrophy is the same. So LV takes you on this side, RV takes you on this side. So tetralogy fallow axis is always plus 135 to 150. You will never get extremes. Remember. So don't just tell ISA summarily axis. That's an important thing in tetrad. Okay? This is the first time you can tell the other variants of RVOT fallow physiology on ECG. Okay? Remember. So don't just skip ECG as a axis. Next.
Have you understood what sir just now said? If this axis was left axis, then? No, he's answering now. Wait, you have finished your turn.
Associated AVCD, AV canal defects.
Sorry?
AV canal defects.
AV canal defects. Very good. Avoid short forms. Okay? AV canal defects. Tricuspid atresia. First time we come to know. Otherwise, child behaving ditto. What does these bells mean? Over. We should stop. Huh?
But so very little gap between the last bell and this bell you slept, huh?
No, another 10 minutes, sir. Another 10 minutes, please continue.
10 minutes, I
Yeah,
thought.
I am keeping a track on that.
Supreme Court has allowed 10 minutes. Okay. Understood? Next.
P wave, PR interval is normal. QRS complex, there is R wave in V1.
See, this is tetralogy fallow. Now you want to tell whether this is tetrad or something else. So don't waste time on PR interval. What is the feature of tetrad?
R right ventricular hypertrophy.
So R wave in
V1.
V1. See that?
Yes, sir. R wave in V1, and there is a sudden transition with S wave in V2, suggesting there is a malaligned VSD.
So don't try to suggest what? This. Third,
Inverted T waves.
your 11-year-old baby. See, I have not forgotten 11-year-old baby. You have forgotten. Tetralogy, sir said, which chamber is not well developed? Tetralogy, child having constantly cyanotic spells, constantly squatting, constantly not walking. LV is small. And if it is LV is too small, you won't be able to do any surgery. So where will you look for?
For the LV size, we can look for the circular criteria V1, V6,
Look at a
V6,
Better
V5.
speak clearly and loudly.
V6, V5.
R wave is V5, V6. Good size. Okay? Chalo. Next.
Anything else you can look at the ECG and say this may be there, may not be there about, can you distinguish double outlet right ventricle? May not be possible, may be possible, but what is it that you see for anybody in the audience? Looking at the ECG, double outlet right ventricle? Write down this question. When we come for sir's class, you all have to answer that. Okay.
What is that?
Q waves.
That is clockwise and counterclockwise loop of VSD.
Yes.
Inverted T waves, sir, in V1, V2. RV hypertrophy features are present. No LV hypertrophy, no volume overload or volume overload.
Next investigation.
Next
Supreme
investigation.
Court has given us 10 minutes.
This is a chest X-ray PA view of the child which is overexposed. The situs is solitus, sir. The
It
CT
is should be called hard plate. Don't say overexposed. Overexposed sounds mistake. Hard plate sounds purpose. Why I call it hard plate? Because the intervertebral space at the level of diaphragm is very well seen. So very penetrating X-ray. Does it fit into your diagnosis of tetralogy?
Yes, sir.
Yes, because
Because the pulmonary bay is absent. There is RV type.
Pulmonary bay absent? I don't understand.
pulmonary segment
Pulmonary
is
segment
not prominent.
Is not prominent.
That is called bay.
Pulmonary bay.
In our time, there used to be one TV serial, Bay Watch. So we could understand what is a bay. So pulmonary segment not prominent is called baying. Okay? I am little happy about this X-ray. Why? I am surgeon, though I have retired. Surgeon. Surgeon means which chamber happy? LV. Does this baby has LV?
RV type of.
Ayyo, Amma. I can see the ventricular contour like this. Can you or can you not? All of you? So don't keep on now harping on tetralogy fellow. Diagnosis is over. Now try to get more information as a surgeon. Okay? Apart from heart, what else you will like to report on X-ray?
Lung fields.
Lung fields. Bolo.
Normal pulmonary markings are visible with
So normal lung vascularity.
vascularity is
Surprise? Not surprise.
surprised.
I am not surprised. 11-year-old, how the child has lived, 11-year-old must have excellent, good collaterals. Anything else in tetralogy you are supposed to tell, particularly the examiners have got gray hair, aortic knuckle, left or right? Now you are looking.
Normal left.
Now you are looking.
Left side.
Left aortic knuckle, beautifully seen. Okay? This patient has undergone right BT shunt. I am telling you. Yes or no?
No, sir.
Why?
There is no rib notching and
Rib notching. Crowding of the ribs. Rib fracture, callus, synostosis, excessive blood flow on one side. Nothing of that sort is there. Okay? Chalo. Next. echo. What do you expect to see?
I will look for the level of obstruction, the
Level
degree,
of obstruction,
degree of obstruction, the sizes of the pulmonary valve, my MPA, main pulmonary,
pulmonary
artery,
valve or pulmonary annulus.
annulus,
Annulus.
then about MPA, RPA, LPA
Some
sizes,
examiners want VSD number.
number of VSDs.
So don't try to again waste time on tetralogy of Fallot. Something which so far you have not understood, found out is level of obstruction. Go ahead. Are? Level of obstructions. Three obstructions. Three obstructions.
And the most prominent.
क्या हो गया?
What about the echo? We want to see the echo.
And ठीक. They are not echoing our feelings. Okay. Go ahead. Are? Let us quickly come to RV outlet. किधर लिखा है RV outflow? You only know. This is from your institute? No? So this is all fabricated.
See, by the time you reach echo, you are already tuning your mind for surgery, no surgery, what is to be done. So how is this helping you? That's what we want to know.
We have to decide whether to go for a palliative surgery or for a ICR.
Okay, decide, not we, I have to decide. Okay, I'm not deciding.
Okay. I will look at the pulmonary artery sizes. If they are not, if they are of adequate size, I will go for a intracardiac repair.
Now, if they are adequate size, I don't understand anything.
Megun's.
So what is that? I still don't understand. You have to tell me in simple language, what do you mean by this?
The Z-scores of the pulmonary arteries, I'll see, sir. If they are less than 2 standard deviations, for then the
So
normal
if it
thing,
is less than, it is standard deviation -2, then what does it mean to you?
that they are too small and the pulmonary arteries are not big enough to take the flow, and I have to go for a palliative procedure, like a BT shunt.
Anything you can explain this more scientifically or something? Anybody in the audience, boys, students?
Boys, matlab girls also.
All, everybody included.
I'll calculate the Megun's ratio.
Okay, we'll come to that when we take the class. But remember, this
But
is very
RP,
important.
LPA size not mentioned. I'm trying. Next page. Okay. You have done it. They have come. Sure. बच गया साला.
See, in the X-ray, they may ask you, if you read Perloff, what is Taussig's axiom? Small heart, prominent pulmonary bay, and oligemic lung fields are Taussig's axiom. Small heart, oligemic lung, prominent pulmonary bay. Chalo, let's go, sir.
What is the, before they come? Not yet come. So what is the usual relation between pulmonary size and patient size? No charts available, just knowledge. 1 millimeter, Are, Pranav, not you. I thought correct answer. 1 millimeter per kg body weight, till 20. I'm 90 kilo does not mean my pulmonary annulus should be 9 centimeter. 1 millimeter per kg body weight, or double the body surface area. So all that you talk, you did not mention body surface area. First part, you told me.
BMI and everything, they were
BMI, BSA you forgot. So body surface area. So what is the weight of the patient? 17 kilo. So you expect the pulmonary annulus to be 17 millimeter. So what is the relation of MPA and RPA, LPA diameters? Anybody? 60%, not 50%, 60%. So 19 is what is required MPA, 60%. So नवापाचा पंचायत नवसक 54, 5.4. So 5.4 should be each. Sorry, 19. So 16 millimeters should be, 15 millimeters should be each RPA and LPA. Okay, and that is normal.
One question I have, how do you get the Z value -2? How do you get the Z value -2? Where is the chart? How do you read the chart? How do you read the nomogram?
What is the formula first? Patient size minus the ideal size divided by standard deviation. So the upper value is minus, it comes to minus Z value.
That is the calculation. Suppose you want to see the chart, the measured annulus is 17, body weight is 35 kilos. How do you get the Z value? Now open your book and take a picture of the chart and come back. I'll teach you in the afternoon how to get the value from the body weight or the body surface area and the measured annulus. It is given there in the book, but you'll have just skipped those diagrams. Chalo, good. Thank you so much, guys.
Thank you.
One word missing is confluent pulmonary artery.
Thank you so much for the wonderful discussion. May I request Professor Sitaram Bhatta to summarize the performance of the candidates? Dr. Anil Tendulkar will do that.
Hello.
Dr. Tendulkar, you did the examination. What do you think is the performance? I have given them 37 out of 40. Their communication skill is good, confidence is good, subject matter knowledge is okay. Relevant answers, okay. Analytical capability, okay. Body language, good. Teamwork, good. Physical appearance for the examination is good.
You are from the same institution, so you are an internal examiner. But the performance was indeed good. But what I feel, which is persistently observed, you don't know what you are talking. When you say 11-year-old patient, you must know what you are trying to convey to the examiner. The dignitaries have not come. Can I continue talking? Yes, sir. By the time they are arranging? Yes, huh? It is like a game of bridge. You know bridge game? I also don't know. But in game of bridge, you don't tell what cards you have got. If your partner says 1 club, you tell him 2 clubs. That means you are trying to tell him that, well, if you have got a king, I have got an ace also, or a queen also. So similarly, every word you speak should mean something with respect to etiology, mechanical problem, pH, complication, something. So where is that girl? Disappeared. Huh? Why have gone so far away? Because Jayadeva is far away from here, South Bengaluru. Huh? That's why. So when you said 11-year-old, you must understand whatever you please sit down. You must know what you are trying to convey. When you say baby first complained at the age of 7 months, it means something. So every word you speak is picked up by examiner, and examiner is trying to find out whether have you understood or not. Okay? Otherwise, examiner assumes you have been told a case by the supervisor. Now you have to show to the examiner that you are intelligent. In spite of being a cardiac surgeon, you are intelligent and you know how to arrive at the diagnosis. Understand? So this is a, sir disappeared. So this is a very common thing I find. Students say something, but they don't know why they have said that or what does it mean. Okay? So otherwise, all 3 of you presented very well. Let us give them a big hand.
Thank you so much, sir. All of you kindly be seated for the inauguration ceremony, which will happen shortly.
X-axis, you have got the weight, 5 kilos, 10 kilos, 15, 20, 25, 30, 35, 40, like this. And we, all of us, have the habit of going to the y-axis and x-axis. No. If you look at the chart minutely, you will find that the measured pulmonary annulus is graphed, it is put in charts like this. If the measured pulmonary annulus is 17 millimeters and the body weight is 35, you have to extrapolate these two. And from here you go to the y-axis, the Z score is given here, minus or plus. It is not x and y-axis, but x-axis, that is the weight which you have. The measured annulus, whatever you are getting on your echo, if you extrapolate from here, on the y-axis, you will get the Z value. Okay, please open your book and read. This diagram is given in all your textbooks. But the problem is that we don't read the legend below it. So the body surface area or the body weight, the measured annulus, you extrapolate to the y-axis, you will get the score.
Sorry? Patient's diameter minus ideal divided by standard deviation. So if the patient is small, then the ideal, the numerator will be minus. So the product of numerator by the denominator will be minus Z score. Okay? Chalo. CPB for tetralogy of Fallow. So you have got my book, e-book. Huh? So now tomorrow that pen drive, you keep it under your pillow. So conduction will take place and it will enter your brain. So how do you describe CPB of any patient, any disease? First is body volume. So do tetrads have more body volume or less body volume? Normal body volume. They are never in failure. Okay? So they are normal. They are not on diuretics also. So their body volume is normal. Number two, what from CPB point of view, number two is hemoglobin. So what will you tell about tetralogy Fallow? They already have polycythemia. Hemoglobin is high. So what is wrong in operating with normal hemoglobin or high hemoglobin? What is wrong? What is the problem? Anybody? Sorry? So, clotting. Clotting is by RBCs. Then? No. Madam is cardiac anesthetist. She is accomplished cardiac anesthetist. So she correctly answered high viscosity. So what is the relation of viscosity and temperature? Lower the temperature, higher the viscosity. But this relation is not linear. This relation is like a Is this the pen working? Okay. So this is viscosity and this is temperature. And this is decreasing temperature. Okay? So this is 37, 35, 25, 15, like that. So viscosity initially rises and at a critical temperature it rises exponential manner. So this is the critical time. So when you are going to cool the patient, viscosity will out of proportion increase. And what is the relation of viscosity and resistance? More viscous, more resistance. All your capillary perfusion will not take place. So we want purposefully, intentionally bring down the viscosity by bringing down the hemoglobin. So we do purposefully planned hemodilution. So why not just dilute the patient with, say, ringer chloride, or isolite, plasma light? Why not do like that? You are all students. You are also cardiac surgery students. You are cardiac surgery student? You are from which institute? Madurai Medical. Who is your teacher? Amrutraj. So please tell what will happen if you just put more plasma light or electrolyte solution. Anything? Anybody? You are going to dilute proteins also. Understand? So this hemodilution should be taking into account oncotic pressure. So what is the plasma volume in tetrads? More or less? Or more or less? Less. Because PCV is more. So these patients should be diluted ideally with plasma. Okay? People have tried in the past variety of Hemexil and whatnot, Lomodex, all varieties of things were done. They all give rise to bleeding problems. So ideally this hemodilution, either you do with plasma or with albumin. So you put plasmolyte and you put albumin. Third problem of CPB is perfusion pressure. So what is the perfusion pressure in tetralogy? The students are sitting there also. Last bench. They are not students. They are just. Okay. They are not also not students. Huh? They are on my blind spot. That's why I'm asking. You called him student and you are student? He's accomplished student. Acha. That's why he's sitting on that side. Okay. Perfusion pressure. What is the perfusion pressure in tetralogy fellow? Low or high? Low. Because of massive number of collaterals. And number two, sudden decrease in viscosity. So you have to bring up this perfusion pressure. Let us welcome the dignitaries.
Invoking blessings of the Almighty, offering our collective respects to our revered founder, Sadhguru Sri Madhusudan Sai, esteemed guests, national and international faculty, residents and delegates seated here and all those participating online, Namaste and a very good morning. Welcome to SMSIMSR Score 2026 here at Sri Madhusudan Sai Institute of Medical Sciences and Research. At the outset, we welcome the dignitaries on the dais. Our chief guest today, Padma Shri awardee Dr. Mylswamy Annadurai, renowned scientist at ISRO and former director, U.R. Rao Satellite Center. Known as the Moon Man of India, he served as a project director for the Mars Orbiter mission and missions Chandrayaan 1 and 2. We are honored to have you here, sir, with us. Our guests of honor, who could not be here with us due to some important and sudden engagements, Dr. Satyajit Bose, Chairman, Mission Hospital, Durgapur. He served as the 56th President of the Indian Association of Cardiovascular Thoracic Surgeons. Shri Prasad Gundumogula, Founder, Chairman and CEO, Gamma Group of Companies, Texas, USA. We also have with us here Dr. Sitaram Bhatt, Chairman of SCORE, Retired Professor and Head of Department, Sri Jayadeva Institute of Cardiovascular Sciences and Research, Bangalore. Hearty welcome to you, sir. From Sri Madhusudan Sai Institute of Medical Sciences and Research, we have Dr. Satish Babu, Director, Academics, and Dr. C.S. Hiremat, Chief Cardiac Surgeon, Director, Heart Valve Bank and Academics. We will commence the inaugural session with Vedic invocation by girl students pursuing undergraduate programs in nursing and paramedical courses at our medical college. They will chant verses from Shishyanushāsanam, Taittiriya Upanishad.
Shri Guru Bhyo Namaha Harihi Om Vedamanuchyacharyo Hante Vasina Manushasti Satyam Vada Dharmanchara Swadhyaya Anma Pramadaha Acharyaya Priyandhanamaritya Prajatantum Ma Vyavachetsi Satyanna Pramaditavyam धर्मान्न प्रमदितव्यम् कुशलान्न प्रमदितव्यम् भूत्यैन प्रमदितव्यम् स्वाध्याय प्रवचनाभ्यान्न प्रमदितव्यम् देवपितृकार्याभ्यान्न प्रमदितव्यम् मातृदेवो भव पितृदेवो भव आचार्यदेवो भव अतिथिदेवो भव यान्यनवद्यानि कर्माणि तानि सेवितव्यानि नो इतराणि यान्यस्माकं सुचरितानि तानि त्वयोपास्यानि नो इतराणि एके चास्मश्रेया पुंसो ब्राह्मणाः तेषां त्वयासनेन प्रश्वसितव्यम् श्रद्धया देयम् अश्रद्धया देयम् श्रिया देयम् ह्रिया देयम् भिया देयम् संविदा देयम् अथ यदि ते कर्म विचिकित्सा वा वृत्तविचिकित्सा वा स्यात् ये तत्र ब्राह्मणा आसम्मर्षिणः युक्ता आयुक्ताः अलुक्षा धर्मकामा स्युः यथा ते तत्र वर्तेरन् तथा तत्र वर्तेताः अथाभ्या आख्यातेषु ये तत्र ब्राह्मणा आसम्मर्षिणः युक्ता आयुक्ताः अलुक्षा धर्मकामा स्युः यथा ते तेषु वर्तेरन् तथा तेषु वर्तेताः एष आदेशः एष उपदेशः एषा वेदोपनिषत् एतदनुशासनम् एवमुपासितव्यम् एवमुचैतदुपास्यम् ॐ शान्ति शान्ति शान्तिः हरिः ॐ तत्सत् श्री साईश्वरार्पणमस्तु.
Thank you, girls. SCORE, which expands to Sri Satya Sai Comprehensive Orientation and Rapid Revision for Examination Program, is a 2-day academic program for orientation and review, particularly for exam-going residents in cardiothoracic and thoracic surgical programs. The primary objective is to provide pearls of success with didactic resources and presentations for excellence in examination process and certification avenues. This boot camp brings together under one roof inquisitive young minds and renowned faculty in cardiothoracic surgery with a passion for teaching and training to bridge gaps in knowledge and strengthen concepts. This is the 12th edition of the program, and like before, this year's event too is in a hybrid format for the convenience of all residents and interested candidates. Highlights of this program include interactive sessions with experts on crucial topics, simulation of problems in cardiopulmonary bypass circuit, instrumentation and tools, problem-based decision-making, interpreting cath studies, case presentations, and very interestingly, AI for the modern cardiac surgeon. Dr. C.S. Hiremat, organizing secretary and the visionary behind this program, will now deliver the welcome address and introductory remarks. It is his immense and infectious passion to not just heal and save lives, but to train and pass on his skills is what shaped and drives this program every year. Dr. Hiremat, please.
Offering my reverential pranams at the divine lotus feet of Bhagwan Sri Satya Sai Baba and our Sadguru Sri Madhusudan Sai. Sai Ram and good morning. At the outset, I would like to welcome our chief guest, Dr. M. Annadurai, the renowned ISRO scientist and Padma Shri awardee, former director of the E.N. Rao Satellite Center. I happened to meet him just about 3 weeks back in one of the conferences in Delhi. And seeing the amount of innovations which he has been doing in ISRO and in turn getting connected to the medical field, I approached him immediately with this thought of these ideas to visit our institute, and he readily agreed. There is not a lot more to learn with him. In fact, He is a visionary by himself. I welcome you, sir, to our institute. Today evening, we have a very special session which was curated just a few days back. And I want all our team members, both online and offline, not to miss this session. It is something that the art of setbacks to comebacks. That's where we are looking at. I welcome the chairman of this core program, my teacher and mentor, Dr. Sitaram Bhatt, who is here with us for the next 48 hours. I also welcome our Director of Academics, the senior endocrinologist of our country, Dr. Satish Babu, and all the dignitaries, my senior teachers who are here, who has a passion of teaching, and all the administrative team of our institute, and also to all my senior colleagues and residents who are joined online from India and abroad. So just to brief about this core program, we started it 12 years back. And the entire motto of this program was to set standards of uniformity of training in the country. Those days, many residents approached, and they had their own challenges of different varied training program. At the end of 3 years of their MCH courses, or at the end of 6 years of their DNB courses, they were not competent enough to think or do what has to, the way forward was quite challenging. In fact, I know some of the doctors who did their course of 3 years of cardiac surgery, left cardiac surgery, and went into another specialty. That should not happen. That means somewhere in the mentor, there is a problem where we do find there is some gap of a mentor and a mentee relationship. And that is the ice which I took an oath to break this ice in the country. And definitely it has made a difference. Till date, we have crossed around close to 751 residents who have been benefited by this core program, being independent cardiac surgeons in the country and abroad. Not only that, sir, in fact, we have got more than 431 registrations this year for this conference, out of which around 136 have come here physically, and remaining are attending online. Today, how cardiac surgery and the space research organization come hand in hand and take innovation forward. To give a few examples. This is a substance called as pyrolytic carbon, which is used on the outer surface of the rocket. It is anti-corrosive resistant, and also it is heat resistant. So this pyrolytic carbon is used in our heart mechanical valves even today. That's very important, how we correlate that. Not only that, sir, your super senior boss, Dr. Abdul Kalam, worked with one of our senior cardiologists of our country, Dr. Somaraju, and he came out for the first time indigenously built cardiac stent called as Abdul Kalam Somaraju stent, the cheapest stents available in India today. And that was a game changer in the world for coronary artery disease management. Not only that, sir, your professor, Dr. Abdul Kalam, made another innovation. We all use the IV cannulas. If you are all familiar with the IV cannulas, the stillet in that IV cannula was invented by Professor Abdul Kalam. That's how the ISRO and medical team go hand in hand. Sir, the initial struggles we all have undergone, not only in ISRO space organizations, not the same happened in cardiac surgery. If you ask me, 70 years back, there was no cardiac surgery on the globe. Anybody who touches the heart would lose the comradeship of his friends. That was the category where they were looked at. And initially, ISRO was being kept out of the elite club across the globe of space research. Today, similarly, cardiothoracic vascular surgery had the same challenges. Today, where do we stand? Today, we are on top of the world in landing the satellites on the moon with the brainchild of Dr. Annadurai. Similarly, in cardiac surgery, earlier, the VVIPs, or the politicians or the film actors or any VVIPs, we used to go abroad to undergo cardiac surgeries. But today, India has set up a benchmark in medical tourism where the foreign patients, foreign ministers come down and get operated here. The open cardiac surgery is what we are doing. Definitely, sir, this is a landmark in global healthcare tourism. and we are not arrogant of this achievement. Here in this institute, under the leadership of Sadhguru Sri Madhusudan Sai, we are more proud to take it forward as one world, one family, wherein we are catering patients across the globe today. Thank you once again, sir, for being with us. I thank all my senior colleagues and residents and all of you, the administrative team, who have taken the time to come and attend this program. Thank you.
Thank you, sir. The One World, One Family mission is a service organization based on universal values of love, compassion, and brotherhood. Our goal is to better the lives of our fellow men, particularly the marginalized sections of society, by providing them what they lack in the key areas of nutrition, education, healthcare, and social care. Spearheaded by Sadhguru Sri Madhusudan Sai and headquartered here at Satya Sai Grama, the mission today has expanded to serve in 100 countries and counting. Sri Madhusudan Sai Institute of Medical Sciences and Research is a testimony to our philosophy and belief that healthcare is a fundamental right of every human being and therefore must be made accessible and affordable to all. Alongside free healthcare, this institution offers world-class medical education as well in programs of MBBS, nursing, and allied health sciences. I now invite Dr. Satish Babu to take us through the journey of our organization, followed by a video that encapsulates our service projects. An alumnus of this very institution, Dr. Satish went on to specialize in endocrinology and has trained at prestigious hospitals such as Guy's Hospital, London, among others. Dr. Satish Babu, please.
Good morning, and at the outset, I first offer my salutations at the divine lotus feet of our Bhagwan Sri Satya Sai Baba and our Sadguru, distinguished dignitaries on the stage, distinguished faculty for the SCORE program, all our delegates, faculty and administrative people from our institution. It's a great honor to be talking about our institution to one of the greatest institutional builder of our country. We all know how ISRO has put India's map within that elite group of countries, developed countries, what we call within 5 developed countries in the world. And each time a mission was conceptualized and guided and executed by eminent personalities like Annadurai, Dr. Annadurai. We all, almost 1.4 billion people, had a missed beat, and we all fell in love with the institution, fell in love with the feat they achieved. And today we have such a great person with us. It's a great honor, it's a privilege, and I was just thinking, 3 or 4 years back, we had a presentation about our institution, and a coincidence, I showed the slides couple of slides of how ISRO as an institution grew. And I had put up photos of rocket being carried on a bullock cart and assembled in a church which was rented. And that's how they built the first rocket for this country. And there is some similarity of this institution. This institution grew by 10 by 10 feet, water, a well, next to the well there will be a pump house. From there, a person inspired by Bhagwan Baba, inspired by the founder Narayan Bhatt, built this institution. And now, it's an institution which not only stands out in the nation, it's standing out in the world. And as Dr. Sai Lakshmi mentioned, we have activities, service activities, other institutions spread out in 100 or 100 plus countries with one universal phenomena. Probably that's what is, not probably, it is ISRO's objective as well, about taking care of planet Earth and welfare of the welfare of all the human race, all the life on earth. As soon as you talk about planet, all the life on earth, it's not only human beings. And with a similar objective, or with a similar singular objective of one world, one family, sort of practicing the welfare and propagating welfare is what this institution also stands for. Our institution, as you know, is one of those unique hospitals and medical college which has no bill counter. And as we walked in, Dr. Iramet was saying that it's an institution, temple of healing and temple of learning as well. So lot of activities are happening in the vertical of healthcare, in the vertical of education, be it primary education to university PhD education to medical education as well, healthcare education as well. And there is another vertical where children are fed in the government schools, taking care of malnutrition, seeing that malnutrition is eradicated, seeing that they go with not with an empty stomach, so that their capabilities, their faculties are better to learn and excel in life. This is the overall service activities happening in this institution, but spread across all the countries which are sort of emulating these service activities. We are going to see the video. With time being the constraint, I will allow the video to continue to narrate and showcase what we are doing as a selfless. The motto of this institution is selfless service, and all the leadership in the institution have that passion, and they have sort of come to join hands with this institution with that calling of selfless love and service as a motto. Thank you, and all the best for all the delegates. And we are so proud to host this academic learning activity. This is the 12th year, and it's a hard work and passion of Dr. Iramet, which is being converted into a program which is hugely popular, and we look forward to making a very high quality, competent cardiovascular surgeons. And in fact, the Satya Sai higher medical services started with cardiac services. You know, in Puttaparthi Super Speciality Hospital was inaugurated by none other than, first surgery was done by cardiothoracic surgeon, AIMS director, Dr. Venugopal. From then onwards, the Satya Sai movement or Satya Sai mission has kept cardiac services at the forefront, and Sadhguru Madhusudan Sai also continued in that footsteps, what Baba had laid down. We have highly sophisticated niche pediatric cardiac centers all over the world. In fact, in India, 7 centers, 1 in Sri Lanka, 1 in Fiji, and in fact, Sadhguru Madhusudan Sai could not be physically present today because there is a cath lab inauguration of Sri Satya Sai Sanjeevani Hospital in Fiji, catering to almost 300 Pacific islands. It's a very humanly impossible service which is happening, and President and Prime Minister are part of this program. In fact, the land for the hospital is given next to the Parliament of Fiji. So this is the depth and magnanimity of this institution's service activities spread across the world. So with these words, I will end and allow the video to continue to speak about our selfless service. Thank you.
One world, one family is the ethos at the heart of our mission. This ideal comes from an ancient Indian principle which considers the whole world as one global family. And as a family, we believe all our family members deserve care and support. Across the globe, we serve millions through 3 main pillars: nutrition, education, and healthcare, all completely free of charge. The Annapurna Morning Nutrition Program began in 2012, providing breakfast for just 50 children, and has since grown to become India's largest morning nutrition program. Today, millions of school children across India and beyond receive the Sai Shore multi-nutrient supplement, helping them begin each day nourished and ready to learn. At our mission, we believe education is every human being's birthright. With a global presence and multiple campuses throughout India, we provide free education from grade 6 to doctorate studies, ensuring every student receives a well-rounded, values-based education that combines high-quality academics with moral and spiritual values. The Sri Satya Sai University for Human Excellence opens doors previously unimaginable to children from underserved communities. By offering quality higher education to those traditionally overlooked, and with a strong emphasis on empowering women, we're breaking the cycle of educational disparity and promoting gender equality in education. Meanwhile, our Skill Development Center equips rural youth with job-ready skills, and our scholarship program supports education with thousands of rural children. Our commitment to empowerment is also demonstrated by People's Shores, an impact sourcing organization in the United States. We help youth from marginalized communities gain skills for the digital economy. This innovative model delivers high-valued business services while transforming lives and uplifting communities. Our vision for accessible medical education became a reality in 2023 when Prime Minister Shri Narendra Modi inaugurated the Sri Madhusudan Sai Institute of Medical Sciences and Research, India's first free, private, rural medical college. This institution aims to nurture noble-minded healthcare professionals who are dedicated to serving the underserved members of our society. Our healthcare mission goes beyond treating illness. We're pioneering solutions to bridge critical gaps in accessible medical care, and through our network of wellness centers, mobile hospitals, and multi-specialty facilities, we bring free healthcare directly to underserved rural communities. From preventative care to complex surgeries, at our hospitals, there are no billing counters. Since 2016, we've expanded beyond India to serve communities across the globe with the singular goal of leaving no person behind. Exemplifying this idea, our Sri Satya Sai Sanjeevani centers form the world's largest chain of free pediatric cardiac hospitals, giving new life to children with heart defects. Continually growing needs worldwide, we're expanding our healthcare facilities with the world's largest free hospital, a 600-bed facility that demonstrates our dedication to accessible healthcare for all. Our vision is clear. A society where life's value is measured not in wealth, but in compassionate service to those in need. And this vision only becomes a reality with the contribution and generous support of our global family. After all, we are all one world, one family.
We now request the organizing chairman, Dr. Sitaram Bhatt, to please give us an overview of SCORE 2026.
Dr. Annadurai, Dr. Hiramat, and Dr.
dignitaries on the dais, and my dear students and my dear colleagues. This core program started 12 years back in the old campus. Basically, Hiremat's idea at that point of time was we do not have structured teaching program in many of the institutes which run DNB. And the DNB results were pretty bad. The year I took DNB in 1992, only 2 of us passed out of 19 in the country, me and Richard Saldana. And it was not much different until quite recently. Now, once the score started in 2014, if I'm right, the DNB results definitely have improved because there are so many other score programs happening throughout the country. In fact, when he started the score program in 2014, he used to lock the hospital gate so that the students won't go out and the teachers don't go out, especially the teachers don't go out. But we teachers did not require that locking mechanism, he realized later, and we were a little bit free. This program actually has brought a change, wherein the students were considering, and people used to tell me that they are hearing the questions for the first time in their examination itself, but never in their hospital. So that used to be the work culture in the hospital, wherein you always are busy operating, but never you don't have time for teaching. Though many times we felt here that, and I had expressed it, that Purvajanme Kritam Papam Shishya Rupena Bhadayate. We look at the answers given by the students and realize that this is the result of my last birth's karma. And over a period of time that has changed, now we are seeing good number of students answering very well, who actually, come the next time and then answering better. There is a saying in Sanskrit that Shishya Madhyate Gurubhyaha Padam Swamedaya Padam Sabrahmacharibhyaha Padam Kalakramenacha. 25% of the knowledge you get by studying, 25% of the knowledge you by listening to your teachers, 25% of the knowledge you get by discussing with your peers and colleagues, and 25% of the knowledge you get over a period of time, that is the wisdom. But after coming here, and I'm a teacher at Jayadeva, and I have realized that the last part of the wisdom, which comes over the period of years, actually comes from Shishya. So, it is not Pada Madhyate Kalakramenacha, it is Shishya Shishyabhyaha. You get knowledge by what your students talk. Students provoke you, students ask you question, you prepare, and especially I'm a retired person, it makes me to be updated with the current knowledge. Thank you very much, Hiremat. You are same as what you were 12 years back, but more passionate and trying to bring in now artificial intelligence also, if I am right, and I don't know where he is going to reach. Thank you very much. Thank you, Annadurai, for coming. Thanks a lot.
Thank you, sir, for that insightful and witty talk. Dr. Hiremat has over the years collected all the must-know information for a CTVS student into systematic modules condensed to a study material book titled Sri Sathya Sai Notes. Today, the 12th edition of the book will be released, and I request Dr. Annadurai to do the honors, please. The book has been compiled and edited by Dr. Hiremat and Aditya Dodmane. Thank you, gentlemen. The next launch marks a revolutionary milestone in cardiac care. We are today honored and proud to present the AI avatar of Dr. C.S. Hiremat. May we have the digital launch video, please?
ನಮಸ್ಕಾರ, ನಾನು ಡಾಕ್ಟರ್ ಹಿರೇಮಠ್, ನಿಮ್ಮ ಕಾರ್ಡಿಯಾಕ್ ಸರ್ಜನ್.
This digital twin is not just an avatar, it is a sophisticated clinical co-pilot that works alongside the doctor, learning in real time from his unique work style, diagnosis patterns, and specific medication protocols. By building a personalized cardiac surgery knowledge base, this twin works 24/7 to answer patient queries in the doctor's cloned voice and style. It ensures that his world-class expertise is always accessible, providing constant support when patients need it most. Most importantly, this is a doctor-in-the-loop system. The AI is here to scale the doctor's reach and not to replace his expertise, ensuring that every diagnosis and critical decision remains firmly in the hands of the physician. We are once again grateful to the team from Pranic AI, our partners in this path-breaking project. I once again invite Dr. Hiremat, who will present an interactive demonstration of this application.
Thank you. This is something new which we are being implementing across the globe, with starting from Sri Madhusudan Sai Institute of Medical Sciences and Research. This is creating a digital twin or an avatar. Like, for example, Dr. Annadurai is there, we can create a digital and Dr. Annadurai, or an avatar of Dr. Annadurai. Why this concept came? Because I had a lot of challenges. My basic, I do not know, as many people know, my basic problem, what I find is the speed at work. I just can't control, and the amount of activities happen had a challenge. This in my previous institute, sir, at Sai Institute, where we had 4 theatres, we ended up operating 8 to 12, at least minimum 8 cases per day. And the OPD was so long, the waiting list went up to 10 years, which was very difficult for us to cater. So, to see an angiogram or to discuss a patient, from morning till night, we cardiac surgeons spend most of the times in the operating rooms. And invariably, we do not see the sun, and we end up getting vitamin D deficiencies and B12 deficiencies, all these things, and we keep injecting ourselves also. So, the patients wait and they become so restless. If they want to see me or any of the senior cardiac surgeons, they are not ready to see a junior cardiac surgeon at the OPD, because that's how they get satisfied. Even we are doing the world-class health care free of cost, they would like to see the senior surgeons. So there I had implemented a camera and a TV in the OPD and a camera and a TV in the operating room. As I am operating, I was clearing the OPD patients so that they see me, and finally that was how it was going on initially. But here I found other logistic challenges, and this came into picture where Gamma group of companies from United States of America have come forward, and they gave me this thought, and immediately I ventured in, wherein by the time, if you are operating surgeon and patient has come, this digital avatar of mine will be sitting in front of the OPD and they see me. In fact, some more photos and all to be taken. This is the initial first phase we are implementing. And you talk to them. For example, he comes down as if he sees me there, he or she sees me there, take some questions, and I keep on answering them questions. And by the end of the day, when I come down to the OPD after finishing my surgeries, or immediately we cannot come down. We as cardiac surgeons stay back in the OT, in the ICU for some time. During that time, this digital avatar will make a total history of the patient, what is there, and comes to a diagnosis and also a plan of treatment for that particular patient. And when I come down and see the patient, I can spend quality time with that patient. That makes a huge breakthrough in clinical care. AI will not replace a cardiac surgeon or any cardiologist in this world. It only supports. It's not artificial intelligence, it is assisting intelligence. If you are intelligent, you still require assistance. So that's where I am looking at this factor, and we have implemented this, sir. And I don't think there was any such platform in the presence of Moon Man of India. So for such an innovation, the country is implementing this. This is a groundbreaking, in fact, activities. We really miss our founder, Sadhguru Sri Madhusudan Sai. Everything has been updated, and because of his prior commitments, he is not here. Can I have a test run, please? And this can come in any language. Any language, that's any advantage. Not only this, we do, sir, valve surgeries. That's like putting a valve in one patient is like, I always teach what my teachers told, putting in one disease, taking out another disease. That's how it is, because they require blood thinners. The pyrolytic carbon requires blood thinners, and that has to be monitored continuously. We make an error, they end up having hemorrhage at different places, and we end up losing them. And if the blood is not completely thin, what is required, the valve chokes and the patient dies. So these are challenges where at their own place, on their mobile, we can always communicate with our digital avatar and guide them continuously. Is it ready? Now you have option of choosing a language. There are different Telugu, Malayalam and all. I'll speak English. Yeah, here only thing is it's my digital avatar where I am the patient, I am the cardiac surgeon or the treating doctor.
Hello, I am Dr. Haraman, your cardiac surgeon. To get started, could I have your name, please?
Yeah, I am CSC Remat.
Okay, and your age, please?
I am 56-year-old.
And your gender?
I am male.
Thank you, Mr. Haramat. Please tell me what brings you here today.
I've been getting chest pain.
In your own words.
I've been getting chest pain for the last 48 hours.
Acha. And what does this pain feel like? Is it a pressure, a sharpness, or something else?
I feel it's a pricking type of pain what I am noticing the last 48 hours.
I see. Does this pricking pain happen all the time, or does it come and go?
No, what I notice is sometimes it comes mainly on exertion.
Okay. So it comes on with exertion. Does it travel anywhere, like your arm, jaw, or back?
So sometimes it does come to the jaw and to the back also.
Got it. Does anything make the pain better, like resting or taking any medication?
Yeah. I do take some rest and it reduces.
And on a scale of 1 to 10, 10 being the worst pain imaginable, how severe does this pricking pain get at its worst?
Yeah, I would grade it as 6.
Okay. Have you noticed any other symptoms when you get chest pain, like breathlessness, sweating, or nausea?
No.
Sir, have you had any history of high blood pressure, diabetes, or high cholesterol?
Yeah, sometimes my blood pressure goes up.
Okay. Have you been diagnosed with high blood pressure, or has a doctor told you that your blood pressure is consistently high?
No, they have told me that I should modify my lifestyles. As of now, I am not on any medications.
I see. Do you smoke?
No,
Have
sir.
you smoked in the past?
No.
Acha. Okay. When you last saw a doctor recently, did they check your blood pressure or pulse?
Yeah,
Do
they
you
did
remember
check.
what it was?
Yeah, it was around 130 by 80. Pulse rate was around 74.
Thank you, Mr. Hiramat. I have completed our diagnostic review. Based on what you've shared, I have noted that you are experiencing pricking chest pain with exertion radiating to your jaw and back, which improves with rest, and you've had some elevated blood pressure readings. I am now preparing your cardiac case sheet for the cardiologist's detailed evaluation. Please wait a moment.
Where's the report? Thank you. Thank you. This gives me a report. Already the report is ready, by the way. Good. Short. And apart from that, in the OPD, if anybody comes down with pain abdomen or some or nausea, vomiting, it helps us to guide, and we see long queues waiting outside our hospital from morning 5 o'clock onwards. And if digital twins and digital AIs are placed at these places, that queue can be reduced and the OPD can be streamlined. It will guide us, go to OBG department, go to ENT department, or go to cardiac surgery department, so that streamlining at the ground level can be done better, where patient care can be managed, quality time can be spent with the patient. Today's country, today's era, the main complaint is the doctor did not spend adequate time with us. And as the doctor grows, as he becomes busy, he keeps running. So this is where the digital avatars make a picture. This is just an initial step. And on this day, with the permission of chairman of Gamma Group of Companies, United States of America, we are also introducing the first masterclass series and online classes, a certified course for AI in heart surgery. I think with this brief introduction to AI, thank you once again.
Thank you, sir. We will now have talks by our guests of honor. First, we have a video message from Sri Prasad Gundumogla. Mr. Prasad is a serial to social entrepreneur who has touched over 1 million lives through innovation, women empowerment, and social initiatives. The first to use AI in the travel industry, subsequently creating a travel unicorn, he chairs multiple public and private corporate boards, accelerating their growth to NASDAQ listings. May we have the video, please?
Good morning, everyone. It is an immense privilege to join you today. To begin, I want to express my deepest gratitude to the pillars of the initiative, the visionary Sadhguru, whose wisdom guides the humanitarian mission, Dr. C.S. Hiramat, whose relentless passion birthed this program, and India's moon man, Dr. Mylswamy Annadurai, who reminds us that human endeavors knows no limits. I thank the administrative team, Dr. Sunny Anand, Dr. Satish Babu, for their vision to continue this program here at Mandanahalli. I also want to take a moment right at the beginning to acknowledge the historic pioneers and senior faculty who laid the foundation for this excellence. We owe a profound debt of gratitude to luminaries like Dr. K.M. Cherian, Dr. Veliathan, Dr. Anil Tendulkar, Dr. Prasanna Simha, and many more international faculty from London, USA, Malaysia, and rest of the world. Because of you, the fourth and fifth generation of trainers in India now carry forward an incredible legacy. At its core, the SCORE program is an initiative for the residents, by the residents. It's incredibly heartening to know that over 400 registrations have happened and 130 are attending. This level of dedication is exactly what our healthcare system needs. We gather today to celebrate this excellence, but also confront a crisis. India currently bears about 60% of the global burden of coronary artery disease. You all know that. While our infrastructure performs 80,000 heart surgeries annually, the actual need is closer to 5 million. More critically, against the requirement of 8,500 cardio surgeons, our nation currently has just 2,400. This staggering gap between the need for care and the capacity to provide it demands innovative and scalable solutions. We must train more experts and empower them with the best tools available. We are an AI native conglomerate called Gamma Group, building the future across multiple industries. From our travel companies, Tabby, Mirai, Abhi, to our core healthcare and educational missions. We built Pranik, our healthcare company, to completely democratize the healthcare ecosystem, connecting patients, doctors, hospitals, and the whole marketplace. We built Arna, our other flagship company, to empower and create modern creatorpreneurs. It's actually entrepreneurs, we call them as creatorpreneurs. And through REDT, our dedicated e-learning program, we are democratizing learning itself to bring world-class knowledge to anyone, anywhere. This vision of scale and democratization aligns perfectly with the SCORE program. The vision of scale and democratization aligns perfectly with the SCORE program, as I said. As we look to the future of SCORE, we see artificial intelligence as the greatest enabler of learning. Let me be clear, at Gamma Group, we do not view AI as artificial intelligence meant to replace human beings. View it as assisting intelligence. AI is here to process data, simulate complex surgeries, and personalize learning curves. It is here to support you, ensuring that your clinical judgment, your empathy, and your expert hands remain at the absolute center of patient care. This shared mission to scale knowledge and bridge critical healthcare gaps is exactly why the Gamma Group is absolutely thrilled to sponsor and partner with the SCORE program today. Through Pranik Reddy, we are deeply committed to providing the tailored content and technological infrastructure necessary to ensure your teachings impact more lives than ever before. To the residents and faculty here today, your work is nothing short of heroic. We are honored to stand beside you on this journey. I wish you all a highly successful and transformative SCORE program. Thank you so much. Namaste.
The next message is from Dr. Satyajit Bose, Chairman, Mission Hospital, Durgapur. He served as the 56th President of the Indian Association of Cardiovascular Thoracic Surgeons. The message, please.
Very good morning and welcome to the SCORE program. The SCORE program has been effective for the last 12 years under the leadership of Dr. C.S. Hiramat and under the blessings of Satya Sai, Madhusudan Sai. And this is an extremely good program for young aspiring cardiac surgeons who are pursuing the MCH and DRNB courses in cardiothoracic and vascular surgery, where all the faculty from all over the world has actually congregated offline as well as online and taking classes for students and also doing practical courses and brushing up their skills. And it is going to be an extremely, an example of where teacher, student, guru and shishya interaction is going to take place. Similar programs have been also started by the Indian Association of Cardiac Surgeons called the iPrep, in which there is going to be offline as well as online courses. Students can take advantage of those courses as well. And the next offline course is going to happen in Durgapur in the Mission Hospital in the end of June. And please, all of you are welcome to come and join us as well over here. And Indian Association of Cardiac Surgeons understands and realizes that one thing is that just being good cardiac surgeons and good academicians is not enough. You have to know the badass management cadre people who control the cardiac surgeons. So therefore, in an endeavor to understand the nuances of cardiac surgery, we have started a course with the Indian Institute of Management, IMC, Calcutta in Joka, wherein we are going to train cardiac surgeons, whether young cardiac surgeons, mid-career cardiac surgeons or senior cardiac surgeons, to understand the nuances of finances and managerial skills that are associated with this business of cardiac surgery. So this is also one thing that we are doing now. And the other things is that is very important is that don't undersell yourself when you become cardiac surgeons. There must be a minimum salary that you should pray for. You should fall for. Nowadays there is a tendency to take cardiac surgeons and give them a salary so little that it is not possible to, even run the family. So therefore, my intention is to democratize the cardiac surgeons from all over the country, and we should get young cardiac surgeons must get a salary that is equivalent that any other MCH or DNB from any other disciplines can demand. So having said a few words, have a great learning experience from the best in the world. And I congratulated Dr. Hiramat for taking this course on head on, and I think you will have many other courses to come, and we all pray to God so that you have a successful program and heart valve and everything on that you're doing in this beautiful center of Mudunali. Thank you.
It is now my privilege to request our chief guest to address us. Padma Shri awardee Dr. Mylswamy Annadurai is a distinguished space scientist of international repute. He served at ISRO for 36 years and has contributed for 60 satellites made in India, notable among them being Chandrayaan-1 and Mangalyaan as a project and program director. During his tenure as director at ISRO Satellite Center, he led more than 3,000 scientists and engineers to build and launch 30 state-of-the-art satellites. With the rest of our country, we are immensely proud and grateful to you, sir, for your contributions. Dr. Annadurai, has led many international forums and committees on space science and technology, such as Chairman, United Nations Committee for Peaceful Use of Outer Space, and co-chair, Asia Pacific Space Forum, among others. He holds leadership roles in public and private sector organizations, startups, and charities. Bestowed with the Padma Shri Award in 2016 for Science and Technology from the Government of India, he also received the Rajotsava Prashasti Award for Science in 2008 from the Government of Karnataka, among his other accolades. He has authored more than 150 research papers and 7 award-winning books in Tamil. Post-superannuation, Dr. Annadurai currently mentors and guides engineering science students and young entrepreneurs in innovative projects of social relevance. Dr. Annadurai, please.
Dr. Hemad, Dr. Sitaram Bhatt, Dr. Satish Babu, and the senior surgeons, and the young and energetic upcoming surgeons for the DNB school point of view. I'm really happy to be here today, Sri Madhusudan Sai Institute of Medical Science and Research, and the view of the SCORE 2076 program. It's somehow I could see nearly, as Dr. Hilmat has told, he met me on an international conference 2 weeks back in Delhi. And when he asked me for this date, I was a bit hesitant because 2 weeks ahead it looks very difficult like that. But luckily today's date was fixed for my personal thing. I think that is how today I am standing here. Tomorrow onwards, I think it's stretching up. But then again, not only the time and date aligned, when I am sitting here last 20-25 minutes, I could see that some sort of alignment, because though I belong to engineering science, how the medical science, what you are talking about, and what I am trying to do here, more or less it's trying to do. That is, once upon a time, people used to tell, something is difficult, it's not rocket science. That is the word nominally it goes. And today you look at here, my students make the rockets time and again. They have not gone outside India, and they have not claimed to be elite schools of that. But still they make the rockets much simplified version, for which even the Western country envies of how these people are able to make repeatedly a successful and economical mission. Like that. Look at here, our PSLV carried more American satellites than our Indian satellites. Okay, that's how things are happening. So that is basically some sort of a mentorship. As rightly told about, we started a very, very basic, very, very humble beginning in the something similar to what Stiva was telling about how this institution started versus ISRO has started. But beyond all these things, beyond whatever the budget is given, beyond all these things, it is a mentorship again across the team. Talking from Sarabhai and Dr. Kalam, things like that, it keep happening there. And that is the one which enabled, because this is the technology, nominally it's very difficult to people hand over. I think in spite of that, I think ISRO has come like that. And that means there is some personal touch, but legacy is there. When I am going around this, before coming here in this campus also, I could see that when we're talking about the healing and learning, and as well as the overall life learning also happening, when the small kids to all the way, you're talking about the postgraduate students or the surgeons, all put together. This place looks like that it's an island of excellence among this area. If you come over there, it is a very, very rural bed area. In spite of that, such a thing is keep happening there. That means when you mind it, you can make it. I think that is the basic sense it's happening there. Mind alone is not enough, heart also required. Heart talks about compassion. Okay, it's more than the currency, it's the compassion it makes. And I like the word you told, there is no bill counter in this place. This is world-class education you are giving, world-class healthcare is given there. And both are money spending thing across the world, both are. But there is no bill counter. That shows it is beyond the currency, it is a compassion. Okay, I think that is the thing. Compassion individually one can have, but compassion making this thing. And Dr. Hirmat was telling about recently you celebrated when 100th birth anniversary of Sri Satya Sai when you're celebrating. 100th country, nation also, your presence being felt there. That means humanity, the humanness, making it the presence felt across that is the need of the hour today. And that's happening as the heart of the system is concerned is really, really good. And beyond that score, we're talking about 2026, again you are trying to connect the Guru Shishya thing in a modern era. I think something similar because when Dr. Sitaram was telling about 12 years back what was the thing there versus today is simple that maybe the book with the questionnaires and this book we are giving that fills the gap. Okay, that fills the gap instead of being surprised in the exam. You are prepared for that exam. I think that is the another thing it's happening. And beyond all these things, you look at here, number of people have registered, number of people attending, and what way in which you lay down this today's program, all looks very, very interesting. That means next level you are getting ready, especially when you're talking about the technology. Now you look at here, it's not only convergence of the people, that is elders versus younger mind, elders' wisdom connecting with the youngers' dynamism, is across every region is called for. That's why it's still that, whether engineering science or medical science. And beyond that, the convergence of medical science and engineering science also is the need of the hour. Okay, and when we talk about artificial, whether it's artificial intelligence or we talk about artificial assistance, something, intelligent assistance, something like that you are telling about that. These are all you look at here. Then it was coming to my mind, our intelligence, somebody to assist means our intelligence getting subdued. Okay, but our intelligence has to still improve. That means I thought, is it whether assisting for innovation? Okay, assisting for innovation is still you are holding your intelligence with you. You use your intelligence, how you make use of, whether you are junior or you are a digital gadget or whatever it is, you try to innovate through that. Okay, that means what all you are doing will remain same but will get improved. That means Dr. Harmat is there in operation theatre, the operation is going on, the OPD, somebody is waiting there. His presence also made, as an avatar is being felt there. You are trying to use an innovative approach of that without losing your intelligence. Okay, nobody is coming for your intelligence assistance, somebody is coming for, yeah. Somebody is coming to help you to innovate. I think this is what we thought about, because this is how nearly 15-20 years back we built, because I myself built a system called expert system. Okay, that expert system, I think that was coming also in those days, even before generative AI. Expert system, I have seen the many places when we go for a diagnostic, I have seen some of the places, doctors read the questions from the screen and that's filling it up. Basically what you look at here, for example, one of your junior, you have trained him and he will take care of this diagnostic thing. And when you are ready, he's already, you are the things here ready. I think something similar mode. It is known questions were put there and patients' answers are giving there. I think something similar even for the satellites also. Satellites you make here you will get here. Once upon a time, every satellite needs a personal care, like a baby care. Okay, you launched it from here, you have to keep controlling. For that, your expertise called for. Second satellite, third satellite, fourth satellites keep going. Mother should take care of every child is born. But doesn't mean in engineering thing also, when you have hundreds of satellites you are launching, all 100 satellites you want to keep in your control and your monitoring, not possible. There, something similar came, wherein either you trained your juniors to take care of that, or gave a system something similar to that. When some signatures are going this way, then he will keep trying before calling you. Okay, that means every 100 satellites we are operating, and daily it's like your ICU, whatever it's happening there, first sort of screening takes place and coming to you. So what I'm trying to release now, this sort of things, what's happening elsewhere, it's also coming to the medical science. That for that, you are part and parcel of that. Is really an innovative thing happening there. And towards thing and whatever we talked about, number of cardio surgeons requirement versus what you are available is a big gap. Okay, that big gap, one way trying to increase the number of surgeons, another way is like this. You innovate, that means Avdar of Kirmat. Now he told, given time, one only he can do. Why one only? Why can't be 100? Okay, I think that is the thing. If you are able to do that, not only positioned in India, other places also it can happen. So that's what, that way is it multiple to have the multiplying factor of Dr. Kirmat. Okay, that it is not only assisting for him, it is not only, it will be able to innovate in a much better way, and that possibility is there. Because initially I told, when we used to launch satellite once in 4 years on satellite. But when we retired, once in 4 weeks we launched the satellites. Okay, but still all the satellites also need same care as what we have done previously. So that it calls for a multiplying factor of how to do it, I think something similar also may be called for here. So that way, I see there is a lot of thought process have gone when you are making the handbook, when you are talking about your Avdar. So these are all the things when it's coming, and the young surgeons are looking there. Definitely that goes how future can keep moving forward, and while doing it, yes, another thing is your Avdar, and anyway we also discussed about the conference, teleprompting, how we can do, telesurgery, what we are enabling, and while doing telesurgery also, how AI can help you to ease your routine way of doing. The normal stitches, whether you can simply command it that we can do it elsewhere, and not touching any blood vein, and so that your blood loss you are able to minimize as minimal as possible, such that the patient after the surgery he gets back at the early. So very many things. That means more and more these assistants coming to more and more, so that we can do the things better, so that beyond all these things, see, one way is number of surgeons you can increase, another way is the sort of assistants you can increase, another way is the longevity of the surgeon can be increased. Okay, up to 80, 85. Why surgeon cannot? His wisdom is much better than a new surgeon. He may be energetic, but his wisdom is much better than anybody else. So this assistance will help to ensure the longevity of the surgeon in a better way. So you multiply Dr. Khidmat, you multiply longevity of Dr. Khidmat, you multiply even every one of them, like Sita Rambat or Satish Babu. So these numbers we keep increasing is another way. Okay, this is the innovative way of making. Avdars were taken previously, but today modern Avdars are required something similar. But while doing it here, yes, the day will come, even doing a surgery in the moon, also day is not far. Okay, and Indian surgeons making their presence felt, sitting here. Okay, of course, if you want to go to the moon, you can go to the moon and do the surgery. But beyond that, sitting here itself, doing a surgery there on the moon also is a very finite possibility. And many things are happening. Actually, that conference we talked about possibility of your presence in the war front. You need not go to the war front, but still your presence can be felt there remotely. Connecting the technology will able to enable you to that way. So that way, today you look at here, need is coming, and the convergence of the technologies, whether in terms of the artificial intelligence or in terms of the connectivity anywhere to anywhere in the world, all these things putting together, I think it can make our life easier and make multiplying effect better and make the required patient's care done much better way. All the things is very much feasible, it looks. And beyond all these things, I am really happy today. I am there in this campus, and this campus has given me some sort of an alignment and a thing like that. So more and more medical science is happening. I think day is not far. Already you have shown the convergence of engineering and this also. I think it also can happen. So that way I am really happy to be part and parcel of that. I think once again, my second avatar will come in the evening. So yes, of now I limit it there. Then I'll come back with our interactive session, Dr. Hirmat, what we asked. Then we can talk about what does this convergence mean. Okay, when something happened, setback happened, it is not that everything is success. Okay, it's not everything is green there. But to make it green, something you have to do that. While doing something is called for. And end of the day, everything may be okay, but the days need not be as smooth as we think. Okay, as simple as we think. And it may be, it gives us some hardships, but the hardships only makes you to understand who you are. I think that is the revelation you will feel with the hardships it come. Probably let us share that at the evening. So until then, my best wishes for the 2 days score 2026 do well. And my best wishes once again. My appreciation for the organizers to making this thing happen here. Thank you, thank you, thank you very much. Thank you.
Thank you very much, sir, for your esteemed presence today and for sharing your profound insights with us. We extend a token of our gratitude to Dr. Mylswamy Annadurai. And we very much look forward to your next avatar as well, sir, this evening. We are also grateful to Dr. Sitaram Bhatt for his presence and participation and for facilitating this event. We also take this opportunity to extend our gratitude to all the distinguished faculty members who will lend their expertise over the 2 days. As I call out names, we request you to kindly come forward and receive a token of our appreciation. First to Dr. Anil G. Tendulkar, retired professor and HOD, Sion Hospital, Mumbai. Dr. Vinayak Shukla, retired professor and HOD, CMC Vellore. Dr. Prasanna Simha Mohan Rao, professor of cardiac anesthesia, Sri Jayadeva Institute, Bangalore.
Professor of cardiac anesthesia is his wife. She is here with us. He is my teacher and professor of Jayadeva Institute.
Dr. Parimala Prasanna Simha, professor of cardiac anesthesia, Sri Jayadeva Institute, Bangalore. Dr. Rakesh Nayak, Associate Professor of CTVS, Sri Jayadeva Institute, Bangalore. Thank you, gentlemen. You can resume your seats, please. Please resume your seats. Sadhguru Sri Madhusudan Sai is a global humanitarian and spiritual leader. Continuing the legacy of revered Master Bhagwan Sri Satya Sai Baba, Sadhguru today leads various initiatives under the One World, One Family mission in over 100 countries. Last year, we were blessed with his presence and guidance, but he's unable to join us this year owing to his travels. Nevertheless, he has conveyed his best wishes and blessings through a special video message for this occasion. May we have the video, please?
Namaste and Sai Ram to everyone, and welcome to the SCORE program for 2026. I'm very happy that we are able to continue this year after year, and now as a part of the medical college, which is very helpful for the residents. And as it is mentioned, it is by the residents and for the residents. And I'm very thankful to the organizing committee led by Dr. Hiramat, who has been championing this for several years and has been attracting faculty both internationally and nationally and from across the board to contribute their knowledge and make it easy for the residents to understand and assimilate the knowledge through their vast experience and their ability to convey their knowledge in the best possible way. I also want to acknowledge the chief guest, very reputed Dr. Mylswamy Annadurai, for his presence and for his guidance to this, and also the guests of honors and all the faculty, both international and national faculty, for being a part of this. It is said in our scriptures, Annadanam Mahadanam Vidyadanam Atah Param Annena Kshanika Triptihi Yavat Jivam Cha Vidyaya, which means the greatest of all the charities is to give food, Annadana. But greater than that is Vidyadana, giving knowledge. Because food can satisfy you for a moment, for then, but knowledge remains with you and satisfies you for the whole life. So when you share knowledge, it multiplies. That is the only wealth when we share, it multiplies, says our scriptures. Vyate vardhate nityam shayamayati sanchayat, which means it grows when you share and it diminishes when you try to hoard it. So as people of knowledge, as people of skills, as people of certain abilities, the best service that one can do is to share that with others. And that is how it can multiply and it can reach more and more people. And in an environment like this, where everything is free, because it is dana. Dana means it has to be given as a gift. It is not to be given as a business by charging people. And that is the other most beautiful part of this program, is that just like all the education in our institutions, the healthcare, nutrition, and all the programs are given free of charge to the beneficiaries, so also this program is the same legacy, continuing by sharing it free with all the recipients. What is the most beautiful part of this program is that the best of the minds come together to share their knowledge with the upcoming doctors, surgeons, scientists, and innovators. And I'm very grateful for all the support that we receive from various organizations towards it so that it can be given free to the recipients. I think as India or even as a world, this is a great idea to share knowledge, to spread knowledge, to give knowledge, not charge or sell or commercialize them. That is what Bhagwan Shri Sathya Sai Baba stood for. He made healthcare and education free for all. And that is exactly what we are doing at our institute. When we built Sri Madhusudan Sai Institute of Medical Sciences and Research, which is under the Sri Sathya Sai University for Human Excellence, we were committed to the idea of giving the knowledge free to all the students. It was an idea that met with a lot of apprehension, a lot of doubts and suspicion. Many people, our well-wishers, advised us against it, saying it is not going to be easy. Governments struggle to run free medical colleges that are subsidized, not even totally free. And in the private sector, we don't even hear of something like that. But we stood firm, our ground, we stuck to our guns, we stayed committed to our path of sharing knowledge, even if it's so-called expensive affair like that of a medical education. And that is how thousands of students now are studying in these schools, university, in the medical college, in nursing and the allied health sciences programs. And they're all going to be future healthcare professionals, leaders, and teachers like you who will share and spread this knowledge to many more people, not only in our country but around the world. Sarve bhavantu sukhinah, sarve santu niramaya, sarve bhadrani pashyantu, ma kaschid dukkam apnuyat. This is the call of the Indians of this ancient land of our great ancestors who said, let everybody be happy. May everybody be healthy. May no one see any sorrow. May all see happiness and goodness everywhere. But to make it happen, all that is needed is to go out of one's way to share what one has with others. And as I said, of all the things that one can share with the world, knowledge is the best because it spreads, it grows, it multiplies, and it becomes infinite. It reaches more people and benefits more people. So thank you once again and welcome to Sathya Sai Grama, to our Society Institute of Medical Sciences and Research, to the SCORE 2026 program. And I once again want to convey my heartiest appreciation and congratulations to the entire team and all the best to the residents who will be taking up their exams thereafter. May they do well and may they use this knowledge to help so many more people. And again, when their turn comes, they should teach it to many more. With these words and thanking everyone, I conclude. Sai Ram.
Once again, we extend our gratitude to Sadhguru, to Dr. Annadurai, our guests of honor, and the esteemed faculty and delegates, those present here and everyone joining us online. We can assure you that the next 2 days will definitely be an enriching experience for all, those learning as well as those teaching. Extending our best wishes, we conclude this session. I request all to kindly rise for the national anthem, please.
Dr. Krishna S. Iyer to share his insights on the art of presenting cases of patients with acyanotic congenital heart disease. Dr. Krishna Subramani Iyer is the chairman of Pediatric and Congenital Heart Surgery at Fortis Escorts Heart Institute in New Delhi. He is among the senior-most pediatric cardiac surgeons of our country. Sir is joining us online. Over to you, sir.
Well, good afternoon, everybody. Sai Ram, and thank you very much for this invitation to the SCORE program. Going on with the session, since we're already running late, I'll be talking briefly about how to present a case of acyanotic congenital heart disease. Essentially, before we actually present any case, since at your level of examinations, you'd already have some idea of what sort of case you will be getting, and assume that your patient will be a cardiac case, and if it's a child, it's most likely to be a congenital heart disease. So it's important that you have a good idea of what is the nature of general congenital heart disease, as well as what are the types of congenital heart disease, and we will focus on acyanotic congenital heart disease, since I think the cyanotic congenital heart disease has already been covered in the morning session. So briefly, as you know, that congenital heart disease occurs in about 8 to 10 out of 1,000 live births, excluding bicuspid aortic valve and mitral valve prolapse, which are relatively asymptomatic in many patients. But 1/3 of these children would have critical lesions, which will not allow them to survive beyond infancy unless they have some sort of intervention or surgical treatment. And there are many simple lesions like a small VSD, which may not be picked up in childhood and may actually present much later in life. So when you're faced with a patient with congenital heart disease, you have to answer yourself some 5 basic questions. Is it a acyanotic or a cyanotic congenital heart disease, which is basically dependent on the oxygen saturation? Is it a situation which has normal pulmonary blood flow, or increased pulmonary blood flow, or decreased pulmonary blood flow? And we are not going to be talking of decreased pulmonary blood flow because those patients are generally cyanotic. Does the problem originate in the right heart or the left side of the heart? And is there a problem with the dominance of the ventricles? And lastly, if it's a shunt lesion, is there presence of pulmonary hypertension or not? Because all this, in addition to the diagnosis, will affect the outcome of the patient in terms of the clinical management. So broadly, this is the sort of differential diagnosis tree. So congenital heart disease can be acyanotic and cyanotic. And in both of these, you can have situations of increased pulmonary blood flow. In acyanotic heart disease, you generally don't have decreased pulmonary blood flow, except in rare situations. So it's usually either normal or increased pulmonary blood flow. And if it's increased pulmonary blood flow, it's usually the shunt lesions, ASD, VSD, or patent ductus arteriosus. We'll come in more detail later. And if it's a normal or decreased pulmonary blood flow, it is usually related to obstructive lesions in the absence of any other shunt. Acyanotic congenital heart disease comprises of a vast array of conditions, but you can broadly subdivide them into either shunt lesions, which are the most common. There can be obstructive lesions, which could be either on the left side or the right side. And there are some others which are a mixture of the two, or combination lesions. Talking about the shunt lesions, the commonest shunt lesions are either the atrial level or the ventricular level. So we subclassify them into pre-tricuspid shunts and post-tricuspid shunts. So pre-tricuspid shunts are those which occur prior to the tricuspid valve. So the commonest is at the atrial level, which causes volume overload of the right side of the heart. Atrial septal defect is the commonest shunt lesion in this group, ostium secundum being the commonest in this group. Then you have others like the ostium primum defect or sinus venosus defects. You can also have a partial anomalous pulmonary venous drainage, because this remains acyanotic. A total anomalous pulmonary venous connection, on the other hand, is a cyanotic congenital heart disease. And if it's a right lower pulmonary vein draining to the IVC, it presents as a specific syndrome called scimitar syndrome. Then the other uncommon lesion like rupture signs of valsalva or coronary artery venous fistula to the right atrium. So these can be a pre-tricuspid shunt. The second level of shunt is the ventricular level shunt. The ventricular septal defect is the most common congenital heart disease, occurring in about 30% of patients with congenital heart disease. The perimembranous variety occurs in up to 80%. The other varieties of ventricular septal defect are either the trabecular or muscular, subpulmonic or infundibulous septal, and the inlet septal variety. So these are four broad categories of ventricular septal defect, perimembranous being the commonest. The VSD with LVRA shunt, that is a shunt which is occurring through the membranous septum from the left ventricle to the RA, is a specific type which is known as the Gerbode's defect. Post-tricuspid shunt lesions continuing forwards at the arterial level. So the ventricular septal defect is the first group of post-tricuspid shunt. The second group is at the level of the great arteries. So you have aortopulmonary shunts, which the commonest is the patent ductus arteriosus, or aortopulmonary window, which is somewhat less common. And then if you have shunts at more than one level, atrial level, ventricular level, which is represented by the common AV septal defect or atrioventricular septal defect, where you can have an ostium primum defect, an inlet septal defect, and possibly additional patent ductus arteriosus. Some of the rare shunt lesions occurring between the aortic root and the right heart, as I mentioned one already, RSOV into the RA, but you can also have a rupture sinus or valsalva aneurysm into the right ventricle, generally into the right ventricular outflow tract, or you can have coronary arterial venous fistulae occurring from the coronary artery to the right ventricle or occasionally to the pulmonary artery. The second group of acyanotic congenital heart disease is the obstructive lesions. Then these can be on the left side. So if there is left ventricular outflow obstructions, it can occur at the level of the aortic valve, which is a valvular aortic stenosis, which is a fairly common congenital heart disease. The bicuspid aortic valve is the commonest in this. It may remain relatively asymptomatic for long periods of time or non-obstructive, but very often it can be obstructive even in the early neonatal period. So that's the most common. Then you can also have variants of unicuspid aortic valve or tricuspid aortic valve with aortic stenosis. The second group is the obstruction below the level of the valve, which is a subvalvular. It can be either in the form of a discrete membrane or it can be a diffuse narrowing of the left ventricular outflow tract, or even a condition called the hypertrophic obstructive cardiomyopathy or HOCM. Then you can have obstruction at supravalvular level, usually presents as a hourglass narrowing. And then going beyond along the aorta, the commonest lesion is coarctation of the aorta, which generally occurs just beyond the isthmic region at the site where the ductus arteriosus inserts into the descending aorta. Left-sided inflow obstructions are even lesser common, represented mainly by mitral stenosis, which can be basically as an abnormal development of the mitral valve. So you can have a mitral valve with short chordae, reduced intracaudal space, parachute mitral valve, hammock valve, supramitral ring, double orifice mitral valve. So the host of pathological conditions which effectively physiologically result in a mitral stenosis. You can have a membrane within the left atrium, which can be muscular or fibrous, resulting in a cord triatriatum. And rarely you can have instances where the pulmonary vein stenosis of either one or multiple. And usually this generally accompanies total anomalous pulmonary venous connection, but very often can occur in isolation or in association with other shunt lesions like ASD or VSD. On the right side again, you get obstructive lesions, mainly in the right ventricular outflow. You can get valvular pulmonary stenosis, which is the commonest in this group, but usually it remains relatively asymptomatic in early childhood or adolescence and can permit survival into the adult. Infundibular lesions, infundibular stenosis again is commonly associated with the ventricular septal defect in the form of tetralogy as we know, but isolated infundibular obstruction with or without a very small restrictive VSD is also common and will present as an acyanotic heart disease. Double chamber right ventricle is one of the common varieties of this form of infundibular narrowing. And then you can have patients with peripheral pulmonary stenosis beyond the level of the branch pulmonary arteries, can also be intrapulmonary. And these patients are a difficult subset, but they'll again present as acyanotic congenital heart disease. Then you have the regurgitant lesions. On the left side, this is mainly mitral regurgitation or aortic valve regurgitation. And again, as I mentioned, the commonest association is with atrioventricular septal defect or endocardial cushion defects. But as I mentioned, all the other lesions which I mentioned earlier, which can produce stenosis, can also produce mitral regurgitation depending upon the type of deformity that the mitral valve has undergone. The specific condition, that is the congenitally corrected transposition of great vessels, here is a situation which is acyanotic if there is no pulmonary stenosis, but very often this is associated with epstenoid malformation of the left AV valve, and because the left AV valve is attached to a systemic right ventricle, this valve often becomes regurgitant. Aortic regurgitation can occur in isolation or in association with other intracardiac shunt lesions. In isolation, it can occur with a bicuspid aortic valve or a unicuspid aortic valve. Very often, aortic regurgitation can follow a balloon dilatation of valvular aortic stenosis. So that will become an iatrogenic aortic regurgitation. A rare entity is called an atrioaortic ventricular tunnel. A subalveolar aortic stenosis and subpulmonic or subaortic VSDs, these can cause secondary aortic regurgitation. So, subaortic membrane over course of time, if not treated, the jet effect on the aortic valve can result in aortic regurgitation. Likewise, subpulmonic VSD or a doubly committed VSD can result in aortic valve prolapse and present as aortic regurgitation. Then at the tricuspid valve, Epstein's anomaly of the tricuspid valve producing regurgitation is not an uncommon condition. Now, it's acyanotic if there is no atrial septal defect, but if there is an ASD, then these patients can present with cyanotic congenital heart disease. And then there are other tricuspid valve abnormalities causing TR, which like dysplasia or tricuspid valve prolapse. Congenital pulmonary valve regurgitation also can lead to idiopathic dilatation of the pulmonary artery. These are extremely rare conditions, but you need to know this as part of the various conditions which can present as acyanotic congenital heart disease. So as I mentioned, other uncommon defects, I already mentioned CCTGA, congenital absence of the pericardium, systemic venous abnormality like LSVC or interrupted IVC, coronary anomalies. An important one is Al-Kappa, that is anomalous left coronary artery arising from the pulmonary artery. These patients present with severe left ventricular dysfunction and heart failure in infancy, but they are acyanotic. Congenital heart block is another condition which is again acyanotic, but can present in the neonatal period or early infancy. Combined lesion, as I mentioned, very often these lesions can occur together, and ASD can occur with mild to moderate valvular pulmonary stenosis. ASD can present with mitral stenosis, also known as Lutembacher syndrome. VSD can present with mild PS, VSD can present with aortic regurgitation. And then there's a specific entity called Schoen's complex, where the majority of the left heart structures have problems, starting with the mitral valve. You can have a supramitral ring or a parachute mitral valve, there's subaortic stenosis and coarctation. So these are all the acyanotic congenital heart diseases that you should be aware of. You should be aware at which time frame these conditions can occur. What are the subsequent pathologies or physiological changes they produce, because that will actually show in what way they'll symptomatically present to you. So each condition has a particular set of symptoms which will give you an idea of what particular acyanotic heart disease that you're going to be dealing with. So when you're eliciting your history and your examination, you'd already be able to form in your mind what sort of lesion is this? Is it a left heart lesion, right heart lesion? Is it a shunt lesion or it's an obstructive lesion? And accordingly, then your subsequent examination and then investigative modalities will follow. So let's look at what are the common clinical presentations of acyanotic congenital heart disease. Now, if they are small shunt lesions or minor obstructive lesions, they may be totally asymptomatic during early life and may actually become symptomatic only when they become significant in later life in adolescence or adulthood. But this is not the case in all patients. If there are larger shunt lesions, then they can present with heart failure as early as the neonatal period. And usually when shunt lesions present, they present at 4 to 8 weeks of age when there is a drop in the pulmonary vascular resistance. And so there is a sudden increase in the pulmonary blood flow, which results in the symptoms of heart failure. So when a patient presents or when the baby presents to you with this sort of symptomatology, then you know that you're probably dealing with a shunt level at the post-tricuspid level. So just a quick review of what are the conditions which present depending upon the age. Now it's important to realize that most of the acyanotic congenital heart disease do not present as critical congenital heart disease except for a couple of conditions, that is in the first panel you see critical aortic stenosis or critical pulmonary stenosis. So the majority of the critical heart disease which presents in the first week of life are duct-dependent lesions, and they are mainly cyanotic congenital heart disease, pulmonary atresia, aortic atresia, hypoplastic left heart syndrome. Those which present in the first to 4 week of life are again, majority of them are cyanotic congenital heart disease because they are also duct-dependent lesions and they present usually when the duct starts closing. It's the conditions which present generally at 4 to 6 weeks of life. These are the ones which are the acyanotic variety, and these are largely, as I mentioned, the shunt lesions. So the shunt lesions start manifesting themselves when the pulmonary vascular resistance comes down, pulmonary blood flow increases, and these patients present with symptoms of heart failure or respiratory distress. And then we move on to the ones which are relatively pathologically not very significant, and so they present much later. They are asymptomatic and may be detected incidentally when the patient undergoes a medical checkup for some reason or the other. So in the large shunts, especially notably the ventricular septal defect, patent ductus arteriosus, or the atrioventricular septal defect, these are all post-tricuspid shunts. It's important to realize that the pre-tricuspid shunt, that is the ASD, do not present during infancy because although it's a shunt lesion, it doesn't affect the pulmonary vascular resistance to a significant level. The shunt is a low pressure shunt, and so the clinical manifestation is only during late. So presentation of heart failure during infancy is usually indicative of a post-tricuspid shunt, and these babies cannot give you symptoms. So you have to elicit what is the mother observing. So is the baby having feeding difficulties, which will be the most? The mother will say that the baby is not able to complete the feed, has to take a break in between. So during the feed, after a couple of minutes, the baby will stop feeding, rest for a while, and tachypnea, the mother may notice that the baby is breathing fast, there is indrawing of the ribs, and also sweating while feeding. So sweating over the forehead is a common presentation of these patients who are on heart failure. And then lastly, most importantly, despite the fact that there is adequate feeding, these patients are not gaining weight. So that's an important presentation in patients with a large shunt at the post-tricuspid level. In slightly older patients, recurrent respiratory infections, that's more than 3 lower respiratory tract infections. It's important to know that common cold doesn't form part of this. It has to be lower respiratory, which either bronchopneumonia or pneumonia, which would be characteristic of left-right shunt, the post-tricuspid level. So likewise, VSD with heart failure is the most commonest cause of heart failure in infancy. And if untreated, 10% of these patients will succumb. Symptoms very often may improve by 1 year of age if they are not treated, and this can occur because of 3 reasons. One is either spontaneous closure or decrease in the size of the ventricular septal defect. but more importantly, development of pulmonary vascular disease. Now, this is a dangerous situation because these patients still have a large ventricular septal defect, but because pulmonary vascular resistance is increasing, they are relatively protected. But if left at this stage, the PVRI will become irreversible and these patients will progress to Eisenmenger syndrome, and we don't want that. So these patients should be treated before this stage occurs. Development of right ventricular outflow tract obstruction, sometimes a pulmonary stenosis can develop, usually at the infundibular level, and that can protect the lungs, and this is also known as a Gasul syndrome. When they are obstructive lesions, then they don't present with signs of tachypnea or they don't have increased pulmonary blood flow. But they can present with signs of heart failure because of left ventricular heart failure. And patients with critical aortic stenosis or severe coarctation of the aorta can present with heart failure in early neonatal period. And this can get exaggerated as soon as the duct closes, because if there is critical coarctation of the aorta or critical AS, the duct is actually supplying the systemic circulation. And when the duct closes, there is an acute drop in systemic circulation, and these patients can present cardiovascular collapse. There's another uncommon condition, but it's important to recognize this because these patients can be salvaged by timely surgery, but if not picked up, they can be very easily lost, and that is Alcapa or anomalous left coronary artery from pulmonary artery. And these patients develop very severe heart failure in early infancy because the left heart is not receiving blood from the aorta, they are receiving blood through collaterals because the left coronary artery is draining into the pulmonary artery. And as soon as the pulmonary vascular resistance drops, there is a steal from the left coronary artery, and these patients get multiple attacks of left ventricular infarction, and they get into very severe left ventricular dysfunction. The asymptomatic patients with small ASDs, small VSDs, or mild pulmonary stenosis can be picked up when they are examined for some other purpose and a murmur is picked up, or an ECG is done and there's subabnormalities in the ECG, or an X-ray and picks up some abnormalities of chest X-ray. Rarely, such patients can present the first time with infective endocarditis, and this is usually common with a small VSD or a patent ductus arteriosus or a bicuspid aortic valve. So patient presents with recurrent fever, embolic phenomena, heart failure. They're not known to have a heart disease earlier, but that can be the presenting symptom. Arrhythmias can another way that these conditions can present. Heart failure in later life. And of course, unfortunately, if patients with large VSD PD are left untreated, then they can present with severe pulmonary hypertension or Eisenmenger syndrome in later life. So the systematic approach to a cyanotic congenital heart disease, you need to have a good history, which includes an antenatal and a postnatal history, followed by a good physical examination. An ECG and chest X-ray are the usual basic investigation one does, followed by the gold standard for all congenital heart disease, that is echocardiography, both two-dimensional echocardiography, color Doppler. After echocardiography, the majority of the cases, the diagnosis can be made. Subsequently, for surgical planning, one may need additional imaging like CT, angio, or cardiac MRI in select cases, or occasionally cardiac catheterization, especially in patients who have pulmonary hypertension and you need to assess their operability. But we'll confine ourselves to the history and physical examination because all the subsequent things will be probably covered in later sessions. So when you're taking the history, as I mentioned, we already have now some idea of what are the various types of acyanotic congenital heart disease, what is the time frame that those congenital heart diseases present, and what specific questions, therefore, that you need to be asking while taking the history. Now, demographic details are common for all patients. When you go on to chief complaints and history of the present illness, depending upon the size of the patient or the age of the patient, you will be either asking the patient directly if he's an older child who can answer questions or adolescent. But if it's a baby, a neonate, or an infant, then these questions will be directed at the mother. So you'll be asking basically looking at whether this is a shunt lesion or an obstructive lesion. So you'll be asking questions regarding symptoms of heart failure. So in an older child, you can ask for history of fatigue, breathlessness during activity or excessive sweating, especially in the forehead. So in an infant, as I mentioned, that there will be a suck rest cycle, sweating during feeding, and mothers who are relatively intelligent can also notice that when the baby is feeding, the heartbeat goes up, the chest is pounding much faster. And these children can often have recurrent respiratory issues. As again mentioned, there could be repeated admissions for pneumonia or bronchopneumonia, and very often these lesions are picked up when they are admitted the first time with a respiratory tract infection. Growth concerns, then you also have to keep track. Is the baby gaining weight? Is the weight appropriate to the age? And this is a common sign of left to right shunts, that they are that they fail to gain weight, or what we call as failure to thrive. Then important questions of negative, because you want to exclude cyanotic congenital heart disease, so you'll specifically ask whether there is bluish discoloration of the lips or the fingernails, especially during crying or any other exertion. So sometimes this may not be evident when the child is at rest, but presents itself when the child is active or crying. And so when you see this symptom, then automatically this patient is obviously not an acyanotic congenital heart disease. It will be grouped into cyanotic congenital heart disease. So you'll be looking at other conditions causing cyanotic congenital heart disease. It's important also to pick out relevant past history and family history, especially the birth history, whether it was cesarean or normal, whether it was term baby or preterm. Have there been previous admissions, especially for respiratory tract infections? And importantly, is there a family history of heart defects? Because you know that there is an increased incidence when there is a sibling with a congenital heart disease or a parent with congenital heart disease. In the antenatal history, it's important to know history of consanguinity, because that contributes to an increased incidence of congenital heart disease. Any maternal illness during pregnancy, rubella, diabetes mellitus, SLE, because these also affect the baby, and a higher incidence of congenital heart disease. Metal nerve intake, specific drugs, especially phenobarbital or anti-epileptic drugs, can cause an increase. And as I mentioned, also CHD in the family. Older kids, you would ask them specifically directly, so the history of palpitations, fatigue, or dyspnea on exertion. This will indicate a volume overload of the heart. And if there is exertional chest pain, and dyspnea and giddiness, this would suggest an obstructive lesion, especially obstructive lesion of the left side, like an aortic stenosis, that can cause angina or decrease in cardiac output during exercise, leading to giddiness or syncopal attacks. Should also be aware that about 18% of these patients would have some form of syndrome or the other. And I've listed the various syndromes here. You can read up about these, but each one of these has an association with a particular type of congenital heart disease. For example, trisomy 21 or Down syndrome is associated most commonly with endocardial cushion defects. Turner's is associated with coarctation and pulmonary and aortic stenosis. Noonan's is associated with dysplastic pulmonary valve or pulmonary stenosis. Congenital rubella is associated with PD and peripheral stenosis. Holt or RAM, importantly, is associated with the familial ASD. Marfan's associated with aortic aneurysm. So you can go through the textbook, but you must be aware of all these syndromes and the associated congenital heart defects. Just a few pictures. This is what Holt or RAM syndrome looks like. They have defects of the upper limb, the upper limb deformities, including deformities of the fingers. This is a picture of Ellis-Van syndrome, short stature, and associated with multiple abnormalities of the digits, there's polydactyly, and orofacial abnormalities. Going on to the examination, you're again looking at different types of pulses. You look at the pulse and the blood pressure. So if you have a bounding pulse, then you're looking at a regurgitant lesion in the left side, which or a leaky lesion from the aorta, which can be aortic regurgitation, a PDA, AP window, or a rupture signs of Valsalva. If it's a slow rising, low volume, then that indicates an obstruction to the left ventricular outflow, usually a severe aortic stenosis. And if it's a slow pulse rate, then it could be a congenital heart block related to either idiopathic or CCTGA situation. It's important to check both the radial pulse as well as the femoral pulse, and because if there's a radiofemoral delay, that is an excellent clinical indicator of the presence of coarctation, which many physicians often miss, because if this test is done in the newborn period, then one can pick up a lot of coarctations which are otherwise missed. Then blood pressure of both upper limb and lower limb needs to be checked, and if there's a difference, that again indicates coarctation. If there is a difference between the two upper limbs, then there are other conditions like a supravalvular AS extending into the right innominate artery, or coarctation with a left subclavian artery distal to the coarctation. So these are conditions which can be picked up just by a simple blood pressure measurement. When you look at JVP, then again certain other conditions can be picked up. Prominent A wave indicates right atrial hypertension, which can be because of severe PS or pulmonary hypertension. A prominent V wave would indicate a regurgitant lesion of the tricuspid valve. If they both A and V wave are equal, means equalization of the pressures within the RA and R. So that would indicate a large Cannon waves are common in congenital heart block because occasionally the RA will contract when the tricuspid valve is closed. And when you look at the precordium, a precordial bulge with hyperdynamic precordium indicates a large post-tricuspid shunt like a VSD or a patent ductus arteriosus. A displaced or hyperdynamic left ventricular apical impulse would indicate again either a regurgitant lesion like a severe AR or severe MR, usually indicates a large dilated left ventricle. So again, going on to the precordium, a left parasternal pulsations would indicate right ventricular volume overload, indicates a large atrial septal defect, or even an Epstein's anomaly. A left parasternal heave indicates a RV pressure overload, like in a severe pulmonary stenosis or pulmonary hypertension. Left second space pulsations would indicate a pulmonary artery pulsation, indicative again of a large left-right shunt. So there are very many of these. I will not go into extensive details of this. Going on to the heart sounds, you're looking at S1 and S2. The wide split with a loud T1 component in S1 indicates an Epstein's anomaly or a left bundle branch block. Absent T1 component occurs in tricuspid atresia. Again, this is a cyanotic congenital heart disease, so we won't get into that. Second heart sound is important because the wide fixed split is seen in atrial septal defects. A wide variable split would be seen in a partial anomalous pulmonary venous defect, severe mitral regurgitation because of an early A2, a moderate to large VSD with normal pulmonary vascular resistance because of a large shunt and delayed closure of the pulmonary valve, and in an Epstein's anomaly with right bundle branch block. But a normal split can occur when the VSD is small or the shunt lesion is small. Again, in pulmonary stenosis, the PSS2 split increases with increasing severity, so this can be used generally as a marker for follow-up in these patients. In a severe aortic stenosis, the S2 may be single because the A2 may be muffled, or it can be paradoxically split. Then there are other heart sounds, again, which at your level are probably not. This is more for the cardiologist to pick up, but it's important that you're aware of these, to please do read up about these other heart sounds, S3 and S4, and also about clicks in different situations. It's important. Some of the conditions in a bicuspid aortic valve, you can get an opening click. In a valvular PS, again, you can get an opening click. And likewise, in a severe pulmonary hypertension. So these are sounds which are in addition to the normal heart sounds that you hear. But this can sometimes an examiner may ask you about these questions. So it's good to be aware of these. Again, lastly, going on to the murmurs. When there are systolic murmurs, the commonest, the pansystolic murmur in the apex, which will generally indicate a mitral regurgitation. So you have to be knowing what is the difference between a pansystolic murmur, systolic murmur, a holosystolic murmur. I will not go into the details of that, but it's important to know what type of murmur is associated with what type of lesions. So in the apex, it's usually associated with regurgitation of the mitral valve. In the parasternal border, it's associated with a small to mitral ventricular septal defect. An early systolic murmur in VSD would indicate a small muscular VSD or a large non-restrictive VSD. In a non-restrictive VSD, you may not get a pansystolic murmur because it's a large shunt. Uh, Pansystolic murmur in the tricuspid area indicates a tricuspid regurgitation, and this importantly increases during inspiration because right ventricular volume increases during inspiration and the TR increases. An early systolic murmur in the tricuspid area indicates an abstinence anomaly, and a late systolic murmur preceded by a click in the apex indicates a mitral valve prolapse syndrome. Again, ejection systolic murmur, as akin to a pansystolic murmur, occur during the ejection phase of systole, and these are indications of valvus stenosis. So, if on the left parasternal border, it's an aortic stenosis, on the right, a pulmonary stenosis, longer, louder, and late peaking with increasing severity. And in IAS, the carotid, the murmur generally the carotids, more specifically so in valvular aortic stenosis. In pulmonary stenosis, the murmur is kite-shaped because it peaks during mid-systole. Ejection systolic murmur in the pulmonary area. A soft ejection systolic murmur usually indicates an increased flow situation like an ASD or a partial pulmonary venous drainage, or a harsh systolic murmur indicates a subpulmonic ventricular septal defects. Diastolic murmurs, on the other hand, while diastolic murmur in the apex, a flow murmur usually indicates large shunt, which is more than 2:1. So a VSD PDA with a large shunt can give rise to a diastolic flow murmur. A congenital mitral stenosis, of course, will be a flow murmur, diastolic rumble. Again, often can have an opening click. A mid-diastolic rumble in the tricuspid area, again indicative of an ASD with a large left-right shunt. This is a pre-tricuspid shunt, so you'll get the murmur in the tricuspid area, unlike a post-tricuspid shunt where the mid-diastolic murmur will be in the left heart of the mitral valve. A continuous murmur is important now because a continuous murmur is characteristic of a patent ductus arteriosus. It typically is heard in the left infraclavicular region. The murmur peaks around S2, and there are multiple eddy sounds in addition to the continuous murmur. So it's a very characteristic murmur which you all may be familiar with. But once the patient develops pulmonary hypertension, then you won't hear a continuous murmur and you can only hear a systolic murmur. And when it develops Eisenmenger, you will not hear any murmur at all. A large AP window generally does not give a murmur, but if it's a restrictive AP window, you can hear a continuous murmur. Other causes of continuous murmur are a rupture sinus of valva into the RA or right ventricle, continuous AV fistula to the right-sided chambers, coarctation with collateral, and these murmurs are usually heard at the back because they are intercostal arteries which feed into as collateral vessels, and rarely peripheral pulmonary stenosis can give a continuous murmur, again heard in the periphery of the lung areas. When you have to and fro murmurs, when you have a combination lesion of AS with AR, you can both systolic and diastolic, likewise PS with PR. And then you get systole or diastolic murmurs very characteristically when there's a ventricular septal defect with aortic regurgitation. So just a cartoon to show which are the four normal areas that we auscultate: aortic, pulmonary, tricuspid, and mitral. And in each you get systolic murmurs and diastolic murmurs, and in each has a differential diagnosis along with that murmur. So to summarize, most often correct inferences about the nature of acyanotic congenital heart disease can be drawn from an accurate history and careful examination. The degree of shunt, the severity of obstruction can be fairly assessed by a proper examination, and your clinical evaluation then compounds the subsequent diagnostic investigation. So when they are put together all together, then you can properly establish a diagnosis and chart out a treatment plan for the patient. Thank you very much for your attention.
Thank you so much, sir, for the overview. We shall now move on.
Questions? Any questions from the audience? Sir, is there alive? Any questions from the students? Sir, any special tips you would like to give for the students, sir? To conclude a few tips from your side.
Well, as Dr. Tendulkar said in the previous session, it's very important that when you are presenting your history and presenting a case, each sentence that you say should have a specific meaning intended towards your ultimate diagnosis. So do not stray from that. So the idea of giving you these list of the important acyanotic congenital heart conditions and what are the clinical features they present with. So when you are eliciting or examining your patient, putting the history and the examination together, you already have an idea of what sort of lesion you're dealing with. So your presentation should focus on those type of symptoms and present those specific symptoms after you have obtained those in your history taking, and then also focus the same on your presentation. When you're doing your examination, the heart sounds, first heart sound, the type of murmur, etc., they should not clash with your assumed diagnosis. So if you're talking about a condition, say if your patient has a valvular aortic stenosis, then you do not say that the patient has a pansystolic murmur, because then your diagnosis is totally wrong. So if it's an aortic stenosis, then you have to say that the patient has an ejection systolic murmur in the aortic area. So you must make sure that your findings correlate with what your final diagnosis is, what you're going to present. Otherwise,
Thank you, sir. Thank you so much. We shall now move on to our second clinical case presentation. The case presentation shall be that of case of acyanotic congenital heart disease. I request our examiners to join us. I would request on dais Dr. Bhatt to join us, Dr. Rakesh Naik and Dr. Prasanna Simha from Jaydeva. Thank you, sir. And online we have Professor Bairam Iron, former Dean and retired Professor and Head of Department of CTS from All India Institute of Medical Sciences, New Delhi, joining us online. Dr. Krishna Iyer will be again with us. Dr. Smriti Ranjan Mohanty, Senior Consultant Pediatric Cardiac Surgeon from Kokila Bain Ambani Hospital, Mumbai, will also be online with us. I also request Dr. Ganapati Subramaniam, Senior Consultant Pediatric Cardiac Surgeon from Hyderabad, to join us. We have two residents presenting the case. The time allotted is half an hour. And the first resident will present the history clinical examination component, while the second resident will present the investigation and the operative management aspects. Both will thereafter contribute to the discussion on management of complications. Thank you.
In MCH examination, generally, this will be a short case. In the DNB examination, if another case has taken a long time, this will be treated like a small case, okay, short case, which will be over within 15-20 minutes, not more than that, because the other case would have taken a long time. So in a short case, the first thing that is asked by the examiner is, what is your diagnosis? So what is your diagnosis?
It's a congenital cyanotic heart disease, sir. Post-tricuspid lesions, probably a ventricular septal defect.
Increased pulmonary blood flow, not in failure, and no.
So your diagnosis is acyanotic congenital heart disease, post-tricuspid shunt, VSD, and?
Not in failure, and.
Not in failure. Can you qualify that VSD? Whether it is a large, small, or moderate sized?
Yes, sir.
Small to moderate size, sir.
You cannot say small to moderate, medium, big, and big, medium, and small.
Small.
This is how the echo reports also were there. How much is the AR, sir? Mild to moderate to severe, sir. So that should not happen.
No. There is only one thing. All lesions, mild, moderate, severe. Mild, moderate, severe. That's it. No severely mild and mild.
Mild plus, moderate minus, no.
So what is it?
Moderate VSD, sir.
Moderate size VSD.
VSD. And next, what did you say? VSD, amele en helidri.
With increased pulmonary blood flow, sir.
Mild, moderate, severe.
Severe?
Moderate.
Moderate.
Moderate pH, okay. Then you said, not in failure.
Not in failure, and no signs of any infective endocarditis.
Okay. Why did you say that what are the signs of infective endocarditis you looked for?
Fever, sir.
Okay.
History of fever patient will be giving.
Fever of 104 degrees for 1 day.
Recurrent fevers.
Recurrent spiking.
Low grade fevers, sir.
Low grade, there's some words you see, trigger words. What is the trigger word for infected? What is the fever called? See, everything there is a trigger word. You hear the trigger word, the examiner will move forward. What is the type of fever in endocarditis called as? Indolent fever. It is indolent fever. That is, it is not so high. That's why it goes on for days together. Not so bad to make him run to the hospital on day one.
So what are the other signs of endocarditis you look for? We have come to the diagnosis. The clinical examination is over. So you said no endocarditis. So one, you said no history of fever. Okay. 2. What are the other features of endocarditis?
Patient does not have any oscillar nodules.
Can you tell me one cardiac condition, acyanotic cardiac condition, wherein there is clubbing? Acyanotic congenital heart disease with clubbing. Say that.
Infective endocarditis.
Infective endocarditis. Okay, then what else you look for? In a patient wherein you are suspecting endocarditis, what else you will have? Splenomegaly. Okay, this in the clinical examination you will be seeing. When you say endocarditis, no endocarditis, these are the definite questions that are there. Okay, then what did you say? Moderate pulmonary hypertension. Why did you say moderate pulmonary hypertension?
Systolic, there is no palpable P2, but an auscultation loud P2 is present, sir.
What is the meaning of loud P2?
It is heard in all the areas of auscultations.
Normal P2 will be heard where?
In pulmonary area.
Okay, if the pulmonary P2 is heard in other areas, it is
loud.
It is a loud P2.
One thing, when you're saying P2 is only heard and not palpable, it is mild. If you can palpate the thing, but if it is
Severe.
as loud as this thing with the heave, it is severe.
Okay.
You should prepare what is mild, what is moderate, what is severe. What you are saying is actually mild. I can only ask the thing, but
I cannot palpate, yes.
Okay. So that is the only thing? Anything else?
Post-tricuspid post-tricuspid shunt.
Why?
Because the patient gives history of recurrent respiratory tract infection. So
Post-tricuspid means why? ASD, VSD, PDA all have recurrent respiratory.
yes, sir.
You use it.
ASD.
Post-tricuspid, you use the term. See, what sir told. If you tell a term, you must be able to explain the term. So you said post-tricuspid. Post-tricuspid has got nothing to do with the recurrent respiratory. ASD has, VSD has, PDA has. So it's not specific to. So it's not specific to it. So what is the specific thing to tell post-tricuspid in all your clinical examination, everything together? Pre-tricuspid, what do you say? If there is something.
Fatigability, easy fatigability.
Pre-tricuspid, to say for sure, pre-tricuspid, aortic stenosis also will have fatigability. Pre-tricuspid, if this is there, it is pre-tricuspid.
RA enlargement.
Something sir has been telling, I can hear it, you can't hear the answer. Sir gave the answer.
Murmurs.
What murmur? See, this is what in the exam, no? If you tell murmur, what murmur? A systolic murmur, sir, or a mid-diastolic murmur, sir. Where means here. That is all one question. And you say in the exam, he asked me 20 questions, but he failed me. I answered 20 questions, but it was for only to answer one question. So what is the murmur?
Post-tricuspid, usually it will be pansystolic murmur, sir.
Post-tricuspid, where?
Pansystolic murmur.
Really?
It can be ejection systolic also.
No.
Early systolic also.
No. How do you say a shunt is, how do you say a VSD is more than 1.5:1? I am trying to give in another way.
In a small, yes sir, small VSDs will have early systolic and large VSD will have, large VSD will have early systolic and small will have pansystolic.
I didn't say VSD, I said a post-tricuspid shunt is having a shunt more than 1.5:1. I didn't say VSD or PDA. What will you hear?
Flow.
Where?
The apex we will hear.
What apex?
Mid-diast.
Across what valve?
Mitral valve, sir.
That is what you have to tell.
Mitral valve, the apex.
And that is exactly what we are trying to say, that the MDM across a mitral valve means that there is more flow
across the mitral valve.
Mitral valve, which cannot happen in a
pre-tricuspid.
Pre-tricuspid. Where will the flow be there? Where will the flow in a pre-tricuspid shunt be?
Tricuspid valve.
Dr. Iyer is asking how to connect to him.
Sir, we can't hear you.
We are not able to hear you.
What is the difference between pulmonary arterial hypertension and pulmonary vascular resistance?
The question is, what is the difference between pulmonary vascular resistance and pulmonary hypertension? Are they same or different, one related to the other?
Pulmonary arterial hypertension, pulmonary vascular resistance will be at the distal level.
Sir asked a very specific question.
When you said VSD with moderate pulmonary arterial hypertension,
Yes, sir.
does that mean that the patient has normal pulmonary vascular resistance or elevated pulmonary vascular resistance?
So it's elevated.
Are they both the same?
Are they the same? Sir is asking.
No, sir.
What is hydraulic equivalent of Ohm's law? Huh? Somebody tell please. Hydraulic equivalent of Ohm's law.
I think, Prasanna, you are asking too much from them.
V is equal to IR. If the mean arterial pressure is equal to flow into resistance.
Yes, sir.
First day, first show in your class, I have taken no high BP,
Inversely,
which is high need not be good because systemic vascular resistance can be very high and the patient can be cold and clamped, and he can have a low pressure but excellent perfusion, right?
Yes, sir.
So in that context, sir is asking.
There is a increased resistance and there will be decreased.
Pulmonary artery pressure may be high with low PVR and high PVR.
That's all. That's
Yes,
all.
sir. Answer.
Pulmonary hypertension may be associated with low vascular resistance. If the pulmonary vascular resistance is,
High.
if it is high, pulmonary flow may be less.
Less.
Okay. And you were talking about the Ohm's law, LA pressure, PA pressure, difference divided by the flow is the resistance.
So do not confuse the terms.
Don't
So when you
confuse the
say
terms.
large VSD with pulmonary arterial hypertension, can you have a large VSD without pulmonary arterial hypertension?
Yes, sir.
Yes, sir.
You can have a large VSD without
Yes,
with
sir. Yes, sir.
normal
Yes, sir.
pulmonary artery pressures?
Yes, sir.
In what situation?
Where there will be gazulization happening and decrease in pulmonary blood flow across because
In
of
the absence
narrowing
of
the
that,
RVOTO.
If there is no RVOTO, can you have a large VSD with normal pulmonary artery pressures?
Yes, sir.
You can have that.
Yes, sir.
In what situation? Don't get trapped.
If the
If
PA
there is a
pressure
large VSD, can the PA pressure be normal in the absence of a right ventricular obstruction?
if the aorta is literally pumping into the PA,
No, sir.
So large VSD always has to have pulmonary arterial hypertension.
Yes, sir.
But does every large VSD have to have increased PVRI, pulmonary
No,
vascular
sir.
resistance?
No, sir.
Yeah. So that is why it's essential to understand the difference between pulmonary hypertension and pulmonary vascular resistance. Every patient with a large VSD will have pulmonary arterial hypertension. But only long-standing untreated large VSD will develop increased pulmonary vascular resistance.
Yes, sir.
So increased pulmonary vascular resistance will always have pulmonary hypertension.
Yes, sir.
But all pulmonary hypertension does not mean increased pulmonary vascular resistance.
Okay.
Because
I think we have taken them off the track.
Yeah.
Okay, why did you say that it is a BSD?
Because of because of history of recurrent respiratory tract infection, and also patient gives history of failure to thrive. Failure to thrive, sir.
Okay.
and
There is no history of suck
Well, not only history, entire thing.
everything is there.
Everything is there.
No, you've given the diagnosis. Why do you say
Why
so?
you
Then
say
there
so?
is a pansystolic murmur along with systolic thrill present in the second and third intercostal, left side of the second and third intercostal space, and there is a flow murmur present across the mitral valve.
Okay.
What about P2? You have forgotten the basics completely. What about the heart sounds? Heart sounds.
S1 was normal, sir. S2 was wide variable split, sir.
What else in the S2?
And loud P2, sir.
Yes, loud P2 to justify your saying that pulmonary arterial hypertension.
Yes,
What is the age of the patient?
3 years, sir.
And age of presentation?
7 months.
7 months onwards. Okay.
Yes.
So what do you expect in this case at the age of 3 years? If it is pulmonary arterial hypertension with VSD,
Yes, sir. There can.
There will be RVOT obstruction also.
Why are you keeping on talking of RVOT obstruction? Did you find a RVOT murmur? Yes, no. Yes or no?
Yes, sir.
You found a RVOT murmur. You didn't mention that. Did you find an RVOT murmur? Yes.
Yes, sir. Yes, sir.
Yes.
Yes, sir.
Then your
Then your diagnosis is not VSD.
You should have said VSD.
You said moderate pulmonary hypertension.
Yes, sir.
How can you say moderate pulmonary hypertension and see? Let us be clear. You can either have PS or PH. We are not going to semantics or some other thing. But in the exam, high flow, low flow. You said increased flow, moderately increased flow causing pulmonary hypertension. Now how can you evoke RVOTO?
No, there is a VSD plus a RVOT also.
Then the
Clinically,
diagnosis is not VSD.
There is no systolic thrill also, sir.
Then how did you diagnose RVOTO?
There is systolic thrill. Sir.
There is systolic thrill, sir.
Is there a palpable systolic thrill?
No, sir, not palpable.
What does that mean? I'll tell that it is a flow murmur.
On
Don't
oscil,
yourselves. I told you, make sure that your findings fit in with your final diagnosis.
yes, sir.
You cannot have pulmonary hypertension with right ventricular outflow obstruction.
Who was the expert in Satyasai? You gave the case, no? And you looked into the diagnosis and you are retrofitting the diagnosis and running into trouble. If there is RVOTO in the final diagnosis, you have committed the cardinal expert misleading going on. Because if there is there RVOTO in the echo? That is how you fell into the trap. You are trying to now fit the diagnosis. You should have given your findings.
There was no palpable P2, sir. There was systolic thrill
You
present.
told us no palpable P2.
No palpable
Okay.
P2. On auscultation, loud P2 and systolic thrill present, sir. And second and
I
third
will
left.
say it's a flow murmur. That ejection systolic murmur is just a non-palpable ejection systolic murmur, means it is non-organic PS, which is due to high flow, not PS, functional PS due to a high flow.
But it is grade 3/6, sir.
So it's not palpable. 3/6, sir.
It's not palpable, sir.
That's what I'm saying. Once it is palpable, it is organic.
Yes,
no?
sir.
We are telling it's a non-organic murmur.
Yes, sir.
So I'll say it's a flow murmur across the pulmonary valve. See, please, that is what you don't try to fit the diagnosis backwards. You are getting inconsistencies here. They didn't understand.
What is the age of the patient?
3 years old, sir.
3 years. And diagnosed to have a cardiac problem when?
7 months of age.
7 months. What happened between 7 months and 3 years?
Patient was lost to follow-up. He was just given supplements to gain. He was just given oral supplements, and then the patient had recurrent respiratory tract infections over the last 1 year. So he's again come for follow-up, where they were advised for surgery.
A patient has come at the age of 7 months who was symptomatic at that point of time, and over a period of time, his symptoms came down. Causes.
Could be that first the VSD which was present has been closed, spontaneous closure. Second could be that there is development of pulmonary vascular occlusive disease, because of which the symptoms have improved, or
will you like to specify about your obstructive part of it? Is it pulmonary vascular obstructive disease or is it RVOTO?
Sir, pulmonary vascular occlusive disease, sir, or progress over time. Sir.
Pulmonary vascular occlusive disease, then will he get the recurrent chest infection now?
What is the natural history?
Iron sir, the question
First
was, symptomatic patient on follow-up over a period of time his symptoms disappear.
Disappear.
What are the causes?
No, but now he says that again patient has got symptoms.
No, sir. This was not what he had. Sir, he's asking if the respiratory tract infection symptoms come down, what are the possible causes?
So once he said the spontaneous closure of the VST, maybe size has come down. Second, that is what I was asking her. Is it development of the pulmonary vascular obstruction, pulmonary vascular obstruction, or is it the RVOT obstruction?
Pulmonary vascular occlusive disease, sir.
Okay, and
Pulmonary
also
vascular
acquired RVOT.
RVOT over time.
So what he was trying to say is a
Both.
fixed pulmonary hypertension,
Yes,
from reactive to fixed.
Yes,
Okay.
What are the other possibilities? Any other way of shunt coming down without the spontaneous closure?
Development of AR, sir, causing
Good.
collapse.
Good development. Did you auscultate for that specific sign?
Yes, sir.
AR. Okay.
What's the natural history of a VSD?
So what is the mechanism of closure of VST? Spontaneous?
Sir?
What is the mechanism of spontaneous closure?
Septal tricuspid leaflet can close the VSD, sir. Or
One.
Fibrosis
Other
of the
is
margins.
fibrosis of the ventricular margins, or there can be aortic leaflet which can also try to close the VSD, sir. And
That is not spontaneous closure.
no, sir.
Okay.
Because
So,
of the
endocardial thickening, caudal fusion, septal leaflets, aneurysm formation.
yes,
Yeah, the
Why
mechanism.
does the AR occur in VST?
because of Venturi effect, sir.
Venturi effect will be where? When there is small VST or a large VST?
Larger VSD, sir.
Hey,
Sorry,
now
small.
we can say smaller. If not big, it is small. Venturi is high flow, so it
High
has to
flow.
be small.
Sucked, it will be sucked in because of the.
In the morning, you listen to that. Don't say Venturi effect for an AR associated with
Tetralogy.
tetralogy because the VSD is large.
Large, yes, sir.
Small VSDs
Small.
will produce a Venturi effect.
Yes, sir.
Okay, so now the diagnosis is complete. What do you want to do?
I would like to investigate the patient, get chest X-ray, routine investigations to assess the general condition, chest X-ray, ECG, and plan surgery, plan management according to the findings.
Echocardiogram?
And echocardiogram.
Okay, tell me about the echocardiogram report. Where is the echo report?
You ask for the chest X-ray first.
Chest X-ray.
We are little bit
We are
hurrying up,
running
Iron sir.
Yeah.
Yeah, so we are.
Okay, I'll ask. With that X-ray, since we are asking one question, is this patient operable or not? You just tell me.
Yes, sir, operable, sir.
Why?
Dilated LA, dilated LV is present. Left
And-
side heart is dilated.
and large heart and-
Cardiomegaly and
And
increased pulmonary blood flow. Pulmonary plethora is present, sir.
is there anything on the ECG which says that you can operate the case?
Sir, ECG, LV, V5, V6, Q waves are present, suggestive of a left ventricular overload.
Okay.
Which chamber of the heart regresses the last, the development of Eisenmengerization?
In fact, LA, it never regresses. Even in Eisenmenger, you will see a large LA, which is a hint that it is because of a post-tricuspid shunt. Okay.
Okay, so echo.
Can you summarize the echo? Oh, it's there.
Interatrial septum is intact, sir. That is dilated LA, LV.
What happened?
Anomalous muscle bundle is present in the right ventricle, subinfundibular, causing moderate subpulmonary valvular stenosis with gradient of 44. Non-obstructive subaortic membrane adherent to the RCC and restricting RCC mobility. Mild AR presence, sir.
No pH?
No pH, sir.
Okay. What next? Should we operate or not operate?
We should operate the patient.
Why should we operate?
First, patient is 3 years old. Patient had history. Patient was symptomatic, and
Was
Not now. Now it is
At present, patient is asymptomatic but had history of symptoms, and there is a good saturation. Saturation is 99%. Dilated only left side of the heart.
What did you say?
Only left side of the heart chambers are dilated, sir.
Okay, okay.
And saturation is 99%.
Should we, see, this patient doesn't have large shunt.
Yes, sir.
So why are
PA
you?
pressure is normal.
If you do not,
PA pressure is normal.
Yes, sir.
Patient asymptomatic. That is 4
Why
mm
trouble?
VSD.
4 mm VSD.
Which may close also. Some few percentage closes even after 4 years. Should we operate or not?
yes, sir. This
Why should we
patient has AR present.
Thank you. Thank
So
you.
we have to
That is
Thank
the
you.
answer.
Thank you. Okay. So,
Yes, sir.
okay. Because the patient has got an AR, you have to operate.
Why?
Yes, sir.
Why?
Logic. If you do not operate, then it will progress. AR will progress and it will increase over time.
Increase in what? What happens?
Dysplastic and infective
Dysplastic
No,
what?
what if AR, this thing, you're changing the life history of the patient.
Yes, sir. We will have to.
A potentially curable
curable
problem,
disease is
you
become-
have introduced a disease called aortic valve
Regurgitation.
leaking,
Yes.
which you may repair, which can recur, you end up with a replacement and all those things, is it not? So potentially, so in what sort of a VSD you advise surgery, not waiting for a spontaneous closure?
Failure, sir.
What is the type
Type
of
of the
VSD?
VSD.
See, he asked a very specific question. Type of VSD, you will advise, you look at the echo report and say, close this VSD.
Subarterial VSD.
One subarterial VSD.
The subpulmonic
Subpulmonic.
VSD.
Subpulmonic. Then
Inlet VSDs also.
inlet VSD. So inlet and outlet. The other
Yes, sir. They
may
can.
close.
They may close spontaneously, sir.
Okay, now how shall we? How shall
Draw the VSD. You want draw the VSD and its margins. And what are all of the ways you can damage the draw VSD. Surgeon's point of view, draw the VSD.
Echo has shown that the VSD is a small VSD.
Okay.
Can't see the board. Okay.
She has drawn a circle and then she has drawn the septal
She has-
leaflet,
she
she has
has-
drawn the bundle and a coronary sinus.
Septal leaflet, she has drawn the baby's bottom of the aortic valve.
What has she forgotten in this diagram? What have you forgotten in this diagram? Who can tell us? What has she missed? Don't make
Don't keep making it bigger and bigger and bigger.
What has she forgotten, boys? The attachment of muscle of Francis. Draw that. Yes.
And please remember, coronary sinus is not at down there, it is this side. A little bit this side. It's more inferior, no? IVC, it's near the IVC. No. It is, you must remember that the medial lip of the, the lateral lip of the coronary sinus and the medial lip of the eustachian valve joined together, and that becomes the tendon of Todaro. So it is low down.
Why the coronary sinus and the muscle of Francis are so important?
Where is the bundle?
Where is the bundle? Hey!
Draw it. Where do you think the bundle will run?
No, that was septal leaflet, sir.
Okay.
No, just draw it. Tell
Draw
me
the
which are the
bundle.
margins of the VSD, which is anterior, posterior, inferior.
Hey, that way, Hey. Is the
Kahan
bundle on the
ja raha
right ventricular side or on the left ventricular side? Bundle, is it on the RV side or on the LV side?
LV side, sir.
LV side. So how can you draw on the side? And where is it near the, which,
Where is muscle of Francis?
Actually, she's made the VSD very large, so that's why it's all
See, don't, it's
Your
papillary muscle of Lance's is not a dot, it is a structure, medial most papillary muscle. Now, sir is asking, you know this point and that point. If it has to course, can it course here? It has to course along the base of the septal leaflet. And then what happens to it afterwards? It diverts away and divides. Now,
How do you avoid injury to the bundle? So bundle is related to the posterior, inferior margin. So draw in that inferior margin, posterior margin, anterior and superior in that figure. Okay, anterior, superior, yeah, posterior. Okay, fine. Okay. How do you avoid injury to the bundle?
During VSD closure, we will stay 3 to 4 mm away from the VSD margin and we will take superficial bites.
Horizontal sutures.
and then
Sometimes we can make a slit and take sutures.
Slit is not for that.
That's for cardiac.
You take sutures through the base of the tricuspid septal leaflet and onto the RV side of the, take the bites on the RV side of the septum. Those two things you say. And do you expect any problem post-operative with this patient?
What are the problems that can happen in a patient in a VSD closure? These are all the same.
This patient had a normal PA pressure,
Yes, sir.
small VSD.
Yes, sir.
You have closed it without causing any complete heart block.
Yes, sir.
Can this patient have a pulmonary hypertension, hypertensive crisis?
No, sir. Yes.
Why? If you say no, why? If
Why?
you say yes, no.
The PA pressure while coming off, if it is less than 1/3, then the patient has no PA pressure. There is no pulmonary hypertension after OT also, sir. So there are less likely that the patient will develop pulmonary hypertensive crisis after.
Can a
surgery.
patient who has a normal PA pressure develop post-operatively pulmonary hypertensive crisis? What is the reason for a pulmonary hypertensive crisis?
Something must have happened. Why does the pH transiently go up?
Sudden increase.
Why does it sudden increase occur? Huh? What is the caveat? See, that's why, for example, a truncus is operated in the neonatal period versus truncus operated at 1 year of age. The Zameen Asman ke andar post-op management. I'm giving you a clue. Something has happened. If I keep banging your head, you will do something.
Sudden, the pulmonary.
You will resist the banging. So what will happen to the musculature around the vessel?
Decrease, sir.
It will increase. So without muscularization, over-muscularization is what causes the thing to react to surgical stress, whatever.
What is the patch material you use?
For this patient, I will like to use Gore-Tex patch, sir.
Okay. Continuous suture, interrupted.
I will prefer interrupted sutures,
Why?
sir. Because I am a beginner and if one of the sutures will cut through, then it will cause post-operative complication and intraoperative prolonged cross-clamp time.
When this baby goes home, mother asks, is it a cure for my baby? What will be your answer?
Yes, sir. The
When will you say that it is a cure? In any shunt lesion?
Which are the shunt lesions which you can say that you have given a cure and specify that?
It is never a cure.
It is not.
It is never a cure.
It is only when you operate in infancy.
Why did I say that?
You say cure only when there is no residual shunt
yes, sir.
and there is normal PA pressure which remains normal over a period of time.
And it's always
And there is no probability of any complications later on.
Okay.
See, once you cross 1 year, it has been shown, this is there in your Kirkland only, that once you cross 1 year and you close the VSD, LV dysfunction can be a recurrent long-term problem. Whereas if it is operated before 1 year, there are only two lesions, a PDA operated before pulmonary hypertension, fully closed, and a VSD operated in infancy with no heart block and no progressive pulmonary hypertension. All the others are non-curative.
So patient's mother asks,
What will you give for the long-term follow-up? Is there anything specific will you tell the mother to be careful about, which needs to be looked at in this particular patient?
In this patient,
And then progression of the, it should not happen, but then the progression of the aortic regurgitation, sir.
Yes. So you cannot say it's a cure.
what happened? Can
You have to
Yes,
tell parents that
two, you had
it's likely that you are not
RVOTO, so recurrent RVOTO, increase in gradient.
recurrent RVU.
Yes, sir.
How, where will you think the bundle will be? The bundle, obstructive bundle will be? In this case?
Above the muscle of Lance's.
Above the muscle, okay, there.
Yes, sir.
Above the moderator.
Moderator.
So what is transition suture? How do you take that?
Sorry, sir.
When you're closing.
Transition suture. What is the transition suture and where do you take it? Where is the transition?
It will be present at the septal.
There are 2 points. Where are the 2 points where a transition suture? Time and again we show that. One is at the anteroseptal commissure and one is at between the septal commissure plane to the
Muscle of Francis.
to the muscle. Those are the 2 points where you take a bite here, a double bite in and back so that it avoids leak because they are the commonest sites where leak
Can
occurs.
After 2 months after the surgery, baby has got carious tooth. Okay. Okay. Okay, last question. Okay. Do you advise endocarditis prophylaxis or not?
We have closed if there is no residual.
Yeah.
2 months.
2 months.
Caries still.
And patient has got infection.
If there is no residual VSD, then we will not require infective.
What are the guidelines say? The patient has to have endocarditis prophylaxis till that gets endothelialized. So when does that get endothelialized? The patch gets endothelialized.
Gore-Tex will not endothelialize.
Guidelines tells for 6 weeks. 6 months patient requires endocarditis prophylaxis. Last question. This patient, the mother asks, what is the chance of my another baby having a VSD and this baby having a VSD?
So, in siblings, there is 3 times chances of having VSD.
It's too much. Too less. Too less.
One baby already having the second baby.
Repetition in a sibling, repetition in the next generation.
So what will you advise the mother who is expecting now again? What will you advise the mother? She is expecting again.
To
Can it be detected by the fetal echocardiogram? Anything?
fetal
Yes,
ectogram
we
also
advise
it can
fetal
be.
echocardiogram.
Yes, sir.
Prenatal scan.
Fetal echocardiogram says that the patient, that baby has got a TOF. What will be your advice?
Continue pregnancy, sir, and after delivery, then we will have to follow up and plan for surgery.
Supposing that baby has got a hypoplastic left heart syndrome, what will you advise? And that's the last question.
It's not compatible with the life, sir.
No, sir. It can lead to VSD will be high pressure area, so it will be aneurysmal. So we should not give pericardium.
There is a gold medal. Okay, thank you very much.
Thanks.
Discussion on.
Sir, Balram Iron and Professor.
Pardon?
Yes, sir.
How do you grade these candidates?
Well, you didn't give them the chance to answer properly.
Okay.
The questions were too fast for them.
Okay.
But I think this girl answered quite nicely.
Yeah, yeah.
And
We also felt that.
boy, of course, didn't get the time to answer.
Thank you. Thank you. We'll close.
Thank you, sir.
Repair, what will happen? And any other problem of AR, you as a surgeon will face.
What are the problems of having grade 1 or 2 AR on table?
He has given all the hints. On table, delivery of cardioplegia. Okay. Why you are choosing PTFE graft?
Because it is this VSD margin is very close to a valve. If we use Savage patch, there can be fibrosis and there can be possibility
So
of...
there are so many VSD patches VSDs are close to valve. All perimembranous VSDs are 1 or 2 stitches go through the aortic annulus.
Yes, sir.
I think the answer, if at all, is that AR, I don't want it to hit a fibrous tissue and produce hemolysis.
But the other side of the story is that with vortex patch, a higher chance of residual VSD persisting compared to...
Yes.
So there are pros and cons of everything.
If you have to repair the valve, you'll repair the valve and then close the VSD, or close the VSD and repair the valve?
First close the VSD, assess, and then decide about it.
Then repair the valve.
Vice versa.
You get only one chance.
Go up bypass and again on bypass.
No, sir.
So you open the aorta, repair the, then close the VSD through the aortic opening only, sir.
They have seen me doing that through everything through the aorta. That's one option.
Yes.
But most many people will close the VSD through the RA route and this. But if you tell transaortic closure, you should know the steps of transaortic closure.
See, if I was in the exam, I will not say transaortic closure because that is taken as a left-sided closure, so it will not be agreeable for you. Dr. Prasanna can do, but not you.
Thank you so much, faculty, online and offline. It was a wonderful presentation.
Any art requires a continuous practice. So remember, case presentation by attending one or two meetings, you won't learn the art of case presentation. Okay? So my job is to tell the science behind case presentation. Now, case presentation you do in practical exams, and by the way, my eyesight is very sharp, so the gentleman on the last bench, excuse me sir, can you keep your mobile off? Yes. Unless, see, you should tell, I am writing your notes by typing in the mobile. I will tell you the answers to be given. So what you should say? Sir, I am typing your notes into the mobile. Huh? So first and foremost, you must remember that practical exam is not oral theory. Nobody wants you to give those 223 causes of a problem. No. They want quick, practical view answer to a question. So remember, always answer with respect to probability. If you are asked complications in a complete diagnosis of tetralogy of Fallot, last is complications. So that shows your maturity. If you tell no history of CCF first, that tells you that this candidate is just doing what we call in Marathi popat panchi, the parrot way of talking. So tetralogy Fallot complication order is not the same of a mitral stenosis complication order, where congestive cardiac failure, thromboembolic episodes will come higher up and infective endocarditis will be at the bottom. Number 2, answer promptly. In theory, MCQ, you can take your own sweet time. Out of 3 hours, you can 2 hours, 59 minutes, you can keep on thinking and tick A at the end of it. You can tick A because of a toss of a coin. You can tick A because the previous answer was D. In theory, in practical, you have to be prompt and answer. You may answer correctly after 5 minutes. That doesn't give you any credit. And answer precisely. Previously, one girl, I think one of the two said, and Prasanna immediately, so don't say stone. Say immediately gall stone. So otherwise you say stone. From where? Bladder. Which bladder? Gallbladder. So then you say, array, 3 questions were asked, I answered all 3. No, you answered just 1 question after too much of prompting. So answering in practical requires probability, promptness, and preciseness. And most important, you should be right for right reason. In theory, in MCQ, you may circle A for a variety of reasons. If that is the correct answer, you get full marks, but not so in practical. So what was told to you in the morning by Dr. Hiremat, presenting case is telling a scientific story. So it involves three: telling, scientific, and story. So what is telling as against reading? In reading, you talk in a monotonous manner. In reading, you don't look into the eyes of the listener. While presenting a case to an examiner, look into the eyes of the examiners. Look at the examiners and talk. Show some expression on your face and talk. Shows you are scared, doesn't matter, but show some expression on your face. Modulate your voice. That will help you a lot. Number two, scientific. The information which you talk should have relevance from point of view. These are the components of a diagnosis. So it should be relevance to etiology, mechanical problem, severity of mechanical problem, rhythm, pH, complications, LV function, NOHS status, and management plan. If your story is not fitting into this, please don't tell that part of the story. No point in telling this person is a Saraswat Brahmin coming from, no point. Are you going to change your plan, your diagnosis, your etiology? If yes, please. Last Sunday, I was conducting a workshop for army at Pune. So the place is Pune, and the person said the patient comes from Parabani district, which is around 350 kilometers from Pune. So my immediate question was, why are you telling me Parabani? So he had no answer. So simple answer could be, patient comes from far away from the referral center. In a valve disease, that to a young patient, where you are going to implant a mechanical valve, that's very important to tell that person comes from a center which is 350 kilometers from the referral center. Okay? So whatever you talk should have a reference. Every word you talk should have relevance, and you should be knowing the relevance. That girl, Rajashri, na? Kya Bhagyashri, who presented tetralogy? Janvi, sorry. So all girlfriends' names, they come to my mind. Very sorry. So Janvi, she said 11-year-old patient, and she was immediately asked, what is the relevance of telling me 11-year-old? So she should be able to tell. She said, 7 months, since the age of 7 months, patient has got complaints. So what is the relevance? So don't talk as if it is just kuch bolne ka hai, isliye bolne ka. Okay? No one from Tamil Nadu? Huh? Hindi Thirium? Ella ke Hindi Thirium? Tiriade? Itrundave Tiriada? Konji Thirium. Good. You are all impressed, na? I know Tamil. Very good. That was the idea. Next is, when it comes to diagnosis of a case presentation, diagnosis according to finding. And the previous presentation was a classic example of not presenting according to the findings, presenting according to the echo. And you should be able to tell why you call this as ASD, why you call pre-tricuspid shunt, why you call this as this. Yes, few weeks back, a patient the person heard on auscultation a murmur in left second intercostal space for aortic stenosis. So don't try to be Raja Harishchandra. You know Raja Harishchandra? Satyavadi. He will always speak the truth. So don't speak so much of truth. Understand? Previous case, Dr. Iyer was telling that you should be able to tell the difference between ejection systolic murmur and pan-systolic murmur. If you think this is the case of VSD, blatantly say this is a pan-systolic murmur. Don't try to say, Arey, I don't think this is. So unnecessarily you are creating trouble for yourself. And remember, your findings on inspection, palpation, percussion, auscultation should be correlating. If you say the patient has got very severe PH, left parasternal activity should be felt, should be seen, P2 should be loud, so all should be correlating. Saying no parasternal activity and suddenly saying P2 loud will not absolutely concurrent with what you are told. Another thing, you should be knowing the unrelated findings also. Okay? Then comes the case presentation diagnosis. Since morning, many of them have said, Dr. Hiremat nicely put it, rare diagnosis, what? Rarely you pass. Rarely correct. So remember, if you are asked the blackbird on the window, the first diagnosis is crow, second crow, third crow. 99 times you should say crow. And say crow quickly. Then duck-billed platypus and spoon-billed this, that should come last if at all examiners ask you. So remember, common things first. Answer quickly 2-3 causes. Don't try to tell 23 causes. And most important, always follow a pro forma. And prepare a pro forma of your own, rather than following somebody else's pro forma. Why this X-ray is tetralogy of Fallot? You must have a pro forma, starting with CT ratio, aortic knuckle, pulmonary segment, ventricular contour, right heart border, LA, like that. So you have your own pro forma, just follow the pro forma. And remember, every time examiner asks you, examiner is asking you in that 11-year-old tetralogy of Fallot who had complaints since the age of 7 months. So all your answers should be with that reference. Don't give a generalized answer that this is also possible, that is also possible. In management, always tell what you do at your center. Don't be ashamed to tell, I operate tetralogy only after the age of 2 years. 10 kilo, 2 years. Nothing wrong. Let Dr. Rao and Dr. Iyer do at the age of 3 months. Are you doing at the age of 3 months? Don't be worried. Tell, we do it at the age of, they accept. Examiners know you are puppet of your boss. They know. So please tell what you do at your center. Most important, don't give pleasing replies. I was examiner in Delhi. I know Delhi people, they always, hanji, हाँ करेंगे जी, हाँ जी. So they are always trying to please. Their whole Delhi culture, I'm sorry if anybody from Delhi is here, I'm worried, I'm sorry. They are always in a pleasing mood. Don't, that person, because I implant Chitrawal, that person say, sir, I will implant Chitrawal. I said, very good. He thinks I don't know. All these hair have become white by listening to students' answers. So I just asked him, Chitrawal? Why Chitrawal? So everybody got up and said, sir, you only implant Chitrawal. Why are you asking me a question? Even if you answer correct, I am going to ask you why. Even if you answer wrong, I am going to answer why. Simple. Kya problem? Acha. And this girl started doing like this. So I was wondering, who is that lucky boy? So I am looking, I see only girls. So please, if you are implanting a particular type of valve, don't be ashamed. Tell that valve. But though I am not implanting, Konsa, which is the latest valve? Kiska bhi naam le lo. I don't know the latest valve. Miltonia. Sir's valve, Miltonia. There is one my valve also. Okay, Miltonia. I am going to ask you, tell me about Miltonia. So you should be able to tell the opening angle. You should be able to tell what is the ID-OD ratio. What are the gradients across? Whether what type of hinge, open hinge, close hinge. And the moment I started asking question, they said, Tendulkar doesn't like Miltonia. His trip to Europe was not sponsored by Miltonia. So Tendulkar is anti-Miltonia. And I answered Miltonia. That's why I was failed. No, you were failed because you said Miltonia and you did not know 4 words about Miltonia. Whether it is pyrolytic carbon or non-pyrolytic carbon. Whether it is steel are impregnated, not impregnated. Sewing rim made up of what? You did not know. Understand? So please remember. Another question is asked, which is very, very relevant, particularly to examiners like Prasanna and Shuklaji. If a student says, I am going to close ASD by right axillary 2.1 centimeter long incision, will you fail that student for answering that, or you will pass the student? I will tell you, I will pass the student. But I will fail the student if the student fails to tell me technicalities of that operation. I am going to ask him, how are you going to put your SVC cannula? How are you going to put your IVC cannula? How are you going to put your aortic cannula? How are you going to give cardioplegia? How are you going to do cross-clamping? Which margin you start first? How are you going to improve your illumination? Suppose the return comes, what will you do? And if you don't answer, then what should I do? Fail. But then what they say? Tendulkar is anti-minimal invasive. He's an old man. He wants sternotomy. That's why he failed me. He didn't. You were not failed because of that. You were failed because you did not know the technicalities. Similarly, another Delhi student in those days at KEM, we used to do a lot of open mitral valvotomies. So to please me, that same Delhi student, not same student, same Delhi. Same Delhi student told me, sir, open mitral valvotomy. I said, very good, tell me the steps. How do you improve the exposure of mitral valve? So everybody got up, sir, you do OMV, no? So why do you ask questioning? I said, I got all right to question to make sure that you are right for the right reason. How will you test the mitral valve in OMC? What will you do first? Remove clot first or OMC first? I am going to ask you. Commissioner not seen. What will you do? I am going to ask you. So remember, you better.
I say that is Teri Gali mein main chali in the immortal words of Shilpa Shetty.
Sir's favorite actress. Most important, examiners know that you have been told about this case. All exams, at all level, except perhaps Chitra. Chitra is very strict and very sincere and very genuinely. If I praise somebody, people think it's a taunt. If I abuse somebody, people think it's a trick. No. Chitra, genuinely sincere people. Otherwise, you are being told about the case. So you should tell the examiner, how did you arrive at the diagnosis? The destination is not important. Arrival at the destination is important. And the worst people in this entire exam are the supervisors. Believe me. Supervisors are the worst. Examiner is very friendly. He's trying to pass you. He puts into your mouth. Arey, pre-tricuspid shunt. So what is volume overloaded? He's telling you everything. Understand? So please remember that. Appearance is a performance. And remember, Sachin Tendulkar can also get out on 0. Understand? So case presentation is not a test of your knowledge. It is performance. So how do you appear? Well shaven or not? Hair properly combed or not? What kind of shirt you are wearing? If you are wearing a collarless shirt, open sleeves to show your biceps. So all this is counted. The way you come, the way you stand, the way you talk, what language you use. Believe me, you may already might have diagnosed. I did all my schooling in Marathi. Chemistry, physics, mathematics, botany, everything in Marathi. So just by sheerly reading English newspaper, I learned English. So my English is not Shakespeare, Bernard Shaw, or Sashi Tharoor. Please, my English is simple, grammatically correct English. So please speak grammatically correct English. And best way of mastering a language is to keep on speaking. If I learned bit of Tamil, so my problem was I speak to any Tamilian. We have a lot of Tamilians in KEM. So you speak to Tamilians, Bala, Sapadka Polama, no, not now. So that used to be the conversation. I speaking with him in Tamil and he speaking with me in English. Some people say, don't murder is murder. Don't murder our language. So we are not, you are trying to speak case presentation, talking with each other, talking to the boss, presenting the case, everything should be done in English. Whether you like it or dislike it, examination is conducted in English, so you better know English, speak English. So what Amitabh Bachchan says, English is a funny language, it be, so finally you have to master it. Another very important about case presentation is talking sense under tension and not talking shit. Moment you talk shit, you know that game, what we call in Marathi, sap, shidi, ladder and snake. So moment you talk shit, that snake sitting at 95 or 96 brings you down to 1 or 2. For example, I have given this shit talks. Once I asked a student, patient has a very, perfusionist is complaining of a very high cardioplegia delivery pressure. So what is the cause? And the student said after thinking, aortic stenosis. So many of you think it's correct? Huh? None of you seem to be shocked. Huh? That all I check in a lunch food is the sweet dish. And today that gulab jam with ice cream, I realize that this is next to clonazepam is that. Another student had tetralogy of Fallot. I just told him another problem of bypass in tetralogy of Fallot is a high LA return, high left heart return. So I asked him what is the cause. He said ASD is the cause of high LA return. So these are shit talks. If you are not understood that these are shit, then you better know that these are shit. Another thing all of you must know, not reporting and reporting absent, these are two things, two different things. If you tell categorically to the student examiner, so opening snap is absent, that means you look for it and it is absent. Rather than not talking about, sir, second heart sound is loud and there is a mid-diastolic murmur, grade 3/6 in mitral area, that means you are not talked about opening snap. So these two things are different. So remember, if you say something, you should be able to tell what is the relevance. And classic is left parasternal activity. If you say it is present, you should be able to tell what grade it is and what it means. And while answering, always answer from most specific to the least specific. What's your name, dear? ASD wali ladki? Tejas. Tejas, you were asked why this is ASD. Correct? Why this is VSD. The stress was on VSD. And you said what? Failure to thrive. Am I right? That was something similar you said second. These are not the signs of why VSD. So if I am asked why this is mitral stenosis, why this is planned cusp, you should start with opening snap. Why this is tight mitral stenosis, most specific is S2-OS interval. So you can start from most specific to least specific. That saves time. That cools the examiner. Examiner is restless to hear S2OS interval. So that cools the examiner. Excuse me, you are sitting like this, you are, no, I am also feel like, samat karo na. So it looks like as if, kya sala baat kar raha hai, ye kab khatam ho jayega, and constantly looking at the watch and checking whether it is working or not. Aisa, matlab, please. Another way of answering is what the patient presented, general demography, age, from where the patient is. Next is symptoms. Next is general examination. But that takes a long time. Examiner may not be in a state to listen to all that. That is okay for long case. For short case, start with most specific to least specific. So how to develop this art of case presentation? One, write detailed ward notes and operation notes. One of my registrar, when I was a houseman, many people think that registrar means I'm boss and that person is registrar. No. He used to tell me, Tendu, that is my popular shortened name, Tendu, operating once is writing operation note twice, is reading from the textbook 4 times, that is assisting 8 times. So that is how it goes. So if you write operation notes, it is reliving the operation. With diagrams, wonderful. Today you drew beautiful diagram. According to me, coronary sinus was properly drawn. Just because he objected, I kept quiet. You require guts to object to Prasanna. Always present case, be on the forefront to present case on the ward rounds. Even if it is a fast round, present the case as much. That gives you a good habit of presenting in a concise, precise, shortened manner. Whether it is X-ray, case, ECG, echo, cath, CT, present in a format. Believe me, that only helps you in presenting properly and have your own format. We had one student who prepared her own tetralogy of fallow case and she by-hearted the case. Very interesting. And in the exam, she presented that by-hearted case. She got some marks. The problem was with the next candidate who actually examined the tetralogy of fallow. And he started saying, history of cyanotic spells. They said, oh, is it? Last case told us no cyanotic spell. Then he said, squatting, oh, is it? So it was totally. So it's a good habit to have a sham case, some false virtual case, and keep on rehearsing that case in that orderly manner. While presenting the case, please do write the entire findings on your papers. It helps you a lot. If you have forgotten, you can always show, sir, I had examined this. But while talking, just glance at your paper. Don't just stare at your paper and talk. As I told you, there's a difference between telling and reading. So keep on looking at the examiner, into the examiner's eyes, eye to eye contact, modulating your voice and talk, but just glance at. Thank you very much. Wish you all the best. And one immediate observation since morning, that all of you require to read hemodynamics of every disease. If you do that, that will really help you in understanding symptoms, sign, auscultation findings, cath, echo, and everything. Small PDA, moderate PDA, PDA without pH, what happens to murmur, PDA with pH, what happens to the flow. So if you know that hemodynamics, it will help you a lot in your all aspects of case presentation. Thank you very much.
Thank you so much, sir. I think nobody slept our post-lunch session. So we shall now move on to our third case, clinical case presentation, that's valvular heart disease. I request our examiners to join us. Dr. Sampath Kumar from AIMS will join us online. And Professor Prasanna Simha sir will join us here on the dais. And Dr. Anand Agarwal, our head of department of CTVS in Sri Madhusudan Sai institution, will also join us on dais. So we have two residents presenting this case. The time allotted for this session is 50 minutes. The first resident will present the history clinical examination components, while the second resident will present the investigation and operative management aspects, and both will thereafter contribute to the discussion on management of complications. Please note, a buzzer will be sounded at 20 minutes, 40 minutes, and 50 minutes. Faculty present offline have been provided with a scorecard. Thank you. All the best.
So now, one of the things that Dr. Tendulkar was telling is that if you tell something, you must know the meaning. So in classic music, there is what is called as ragam, talam and pallavi, where one raga, the other puts tala. So now I want one student to be doing the raga, that is you tell a statement. He will tell the hemodynamic consequence or what is the meaning, which chamber is big, small, obstructed, everything. You will tell the hemodynamic consequence or the anatomical consequence. So one of you come here, one of you talk. So she says something, what is the meaning of that thing? He says something, what is the meaning of that? It has to continuously go on.
No, this is not the case. No, ma'am. Here
Or
it is
they are
okay,
all
ma'am.
from
There.
there.
Patient is not.
So every time you make a statement, you are going to tell what is the meaning of that statement. As far as the heart is concerned, as the lung is concerned. Okay? Go ahead, start.
Yes. A very pleasant afternoon to every one of you. We both are from Jayadeva. We are here to present valvular heart disease.
Incidentally, in DNB exam, we are not expected to ask you where you are from and all. In fact, it is frowned. Okay, you can continue.
33 years old male patient who has come from Karnataka has come with the complaints of dyspnea on exertion for the past 3 months. The symptom.
Why did you say that? Huh? Why did you say that? There are three statements. 33-year-old male, and you said dyspnea. Okay. 33-year-old male means what to you? We all know that it is valvular heart disease. 33-year-old male coming with dyspnea.
32-year-old male is a young patient, sir. We can decide which valve to put, mechanical or that way. Or
we want an diagnosis.
Sir,
33 male.
etiology will be able to know from the
more of the etiology. Whether
What
it
would
is
be the most likelihood diagnosis in India?
rheumatic heart disease.
Okay. In India. Okay. Then next, we said dyspnea.
Dyspnea on exertion.
Means what?
Dyspnea, sir, there is enlargement of LA.
LA hypertension.
Hypertension.
Okay, next.
Hypertension.
LA
Sir.
hypertension.
Pressure increases.
That's why I use the word LA hypertension. It's a simple way of saying, or LA pressure overload. Okay, then next.
So patient was completely normal 3 months before, after which he developed dyspnea on exertion, which was first of NIVHA class 2, which progressed to class 3. After
Sudden onset of dyspnea in a patient.
Sir,
This patient. What are the possibilities?
I have no idea what is class 1, class 2, class 3. Please explain.
Yes. New York Heart Association has classified the symptoms. The symptoms will be fatigability, palpitation, and dyspnea. They are considered
Angina.
in this classification, and angina also, and they are considered in this classification. Here we quantify the patient's status depending upon these symptoms, how they are progressing, sir. In class 1, the patient is in a known case of heart disease. A patient is has no restriction of physical activity. In class 2, there is slight limitation of physical activity. In class 3, there is moderate limitation of physical activity. In class 4, he is having all the symptoms at rest.
I don't think you use the word slight. It is not slight. It is the
keyword there is accustomed. More than accustomed, accustomed.
The complaints are not NYHA classification.
Are not NYHA.
The human being, the patient is NYHA class.
Okay.
Perhaps Sampath sir wanted to ask you that.
Okay.
The complaints are grade 1, grade 2, grade 3, grade 4. And the word for the complaints is unaccustomed, accustomed, unaccustomed, indoor, and at rest.
Why? What is the thing? What is the importance of knowing whether the patient is 1 or 2 and 3 and 4?
Sir, we will know the severity, how it's been progressed or not, sir.
No. I'm saying between 1 and 2 and 3 and 4,
Okay,
how does it matter to you as a as far as
It
clinical
has something to do with your decision to do
decision making?
patient. How do you want to treat a class 1 patient?
So class
What
2 we can
class 4
offer
patient?
medical management. In class 2 and 3,
See, this is
class
where
1.
you have to be very careful because we are running out of time. 1 and 2 is technically asymptomatic because he can do accustomed exertion. 3 and 4 are symptomatic.
We have to offer
So, no, again, the question arises is 3 and 4 we are operating for what reason? Dr. Bhatt's favorite question. Why do you operate any patient?
Sir, to give them a symptomatic relief. And to
Any patient,
quantity and the quality of
piles,
life.
why do you operate a patient with piles? Like that, any operation, why do you operate? There are only 2 ways.
Quantity and the quality of
Quantity or quality of life. Now in 3 and 4, what is the goal?
to improve their quality, sir.
Quality and probably quantity. What are you operating for 1 and 2 if you want to operate?
The quantity.
Only for quantity of life. So what are the reasons for you want to intervene any cardiac surgery in 1 and 2 to improve the quantity of life? What is the commonest reason? If I want to operate asymptomatic AS, I want to operate asymptomatic AR, I want to operate asymptomatic MR. What is the reason for operating such a case? He has no problems in life, but you are operating on him. Try to increase quantity of life. What is that thing that abrogates the life?
Disease progression, sir.
Not disease progression. Huh? Sudden cardiac death, okay, we will give that to you in a way. Increased incidence of sudden cardiac, we will give that. But more important, what is the commonest thing? MR, asymptomatic MR or asymptomatic AR. Why are you operating? Complication means yes, symptoms. Disease, everybody progresses in life.
LV protection.
Ventricular dysfunction. He is getting progressively ventricle this thing. He will have a damaged ventricle which will abrogate his life. Therefore, you should know, because today Eugene Braunwald died day before yesterday, so you should be knowing because he has done pioneering work on this. Okay, then?
Sir, he is also having symptoms of chest pain for the past 2 months, which
Chest
is
pain
on and off, insidious in onset, and which is relieved at rest, and which is not radiating, sir.
30-year-old patient with chest pain. Causes.
So most commonly, first thing which I will think about is an ischemic heart disease, sir.
30-year-old.
Since he is
Boy next to you. क्या रे? 30-year-old male. Okay, 30-year-old female. Chest pain with valve disease.
Sir, aortic stenosis.
Pericarditis, excellent one. Okay, then you said something?
Aortic stenosis, sir.
Then? See, you should have these things there. If it is a mitral valve disease with chest pain, what are the possibilities? Aortic valve disease with chest pain. I'll give you. Every lesion is MS, MR, MAS, AR. All 4 lesions you tell me. MS with chest pain. At 10 minutes you tell me, we'll stop history, then we'll go, otherwise we'll never reach surgery. MS with chest pain. Very, very, very standard question. MS patient coming with chest pain. One you gave exact thing. If it is a 12-year-old boy with chest pain with MS, 12 or 15-year-old boy or girl, Carditis, one, okay. 30-year-old person could still get it, but okay. Then second, chest pain. He walks and has chest pain. Or it can be sudden onset chest pain and then followed by hemoptysis. Different types of chest pain. Pulmonary arterial hypertension. So vascular angina and RVH. RV angina or vascular angina of pulmonary artery. There's a whole chapter on HERS called as vascular angina. Then sudden catching pain, chest pain. Patient's heart rate was irregular.
Embolization, sir.
Where?
Because of the MR palpitation.
To the brain, yes, chest pain.
Pleurisy.
Huh?
Pulmonary
infarction can occur. Okay, then now he doesn't have pulmonary infarction and has got cough with productive rusty brown sputum. See, I am talking, you are not talking.
Hemoptysis.
You already told pulmonary infarction. I am telling now rusty brown sputum and he is having cough, chest pain. You gave the answer actually. Pleuritis. Like that, see, there are multiple causes of chest pain in a MS. MR patient with chest pain. 30-year-old high-strung female, sudden onset of breathlessness, had been saying from the past 10 weeks that she's been having chest pain. Somebody gave her nitrate and it worsened. My first surgery in Jaideva of a particular operation which I do a lot of was this case. 30-year-old lady, every time she comes to the OPD, even a nitrate and the chest pain worsens. I've given you enough of a clue. Yeah, it is MVP MR patients are typically can have chest pain, which is non-anginal in nature, non-ischemic in nature, though there is, will not go into the controversies, which is worsened actually by nitrates. Then again MR, carditis, this thing, you will go on. Then aortic stenosis. What is that? Just tell, due to?
Fixed cardiac output.
Not due to fixed cardiac output. It is due to
supplied
mismatch. See, that what is there? There are always trigger words. Examiner is waiting for the word. If you give the word, he will go to the next question. Then AR patient, let us say, chest pain. We just discussed for pulmonary hypertension like that. What can be there? Vascular this thing. Then again low diastolic. See, you have to answer. See, what is happening is Prasanna Simha is not the examiner, is not the student. You have to talk. Okay, chest pain. Okay, we'll move to the next step. Sir, anything else you want to ask, sir? Okay, continue. I think his screen is frozen, I think. Oh, continue.
No history of hemoptysis, no history of any embolic events, stroke or syncope, no history of pedal edema, facial puffiness or abdominal distension.
Meaning of each. Chuck. Hemoptysis. What are the causes? Fat.
Sir, pulmonary apoplexy, winter bronchitis or pulmonary infraction.
All these are signs of LA, hypertension and pulmonary hypertension. Okay. Then next, what was the next word you used?
Sir, no pedal edema, facial puffiness and abdominal distension, sir.
Okay.
Signs
it means what?
RV failure.
No right heart failure.
No right heart failure.
So we have competent there. Then next.
Orthopnea or PND you mentioned?
No, sir. No history of any orthopnea or PND, sir.
Okay.
Which shows there is no LV failure.
You say he has dyspnea?
Sir?
He has dyspnea?
He has dyspnea, sir.
Big. Then?
Sir, no other signs of infective endocarditis, fever, chills, or osseous nodes, hot spots.
No signs?
No.
No signs of.
Sorry. No signs of.
From the history, can you make a diagnosis now?
So 33 years old, a hotel worker from
Diagnosis. Sir has
Sir is
asked
asking
diagnosis.
a valvular heart disease.
There are 4 valves.
Most
See, same thing just now I told you. Be specific.
Yes, sir. Valvular heart disease, most probably
Not most probably.
mitral valvular.
Any other possibility?
It can be aortic also because of the chest pain, sir.
Thank you. By the way, you wrote down RV normal. What aspect of RV is normal?
There is no dysfunction.
Means what? Pressure point of view, what is normal?
There is no pulmonary.
Diastolic pressure
is normal.
No failure means RV, write down.
Right there.
RV EDP normal.
EDP normal, not
RV systolic may be raised.
Okay.
Thank you.
So as a consequence, what about RA?
It will be normal.
Write it. See, we are building the picture of the heart. Now the only chamber we really don't know, which is the decider chamber now to the diagnosis. The decider chamber. We have got 3 chambers, we have got an idea of it from just the history. Now the decider chamber in the next part is going to be what chamber?
Left ventricle.
Now how will you decide?
So history wise, there is no orthopnea or dyspnea or PND also, sir.
Is that going to help you tell that it is, if
the
orthopnea,
LV
PND, no,
Okay,
please listen to my question. The clincher is going to be the LV. Now I will ask you, if it is aortic valve disease, how did it change? If it is mitral valve disease, how did it change? With this much amount of information you give.
Sir, if it's in aortic valve disease,
Aortic valve disease with this situation and mitral valve disease with this situation, how will it differ?
Sir, in mitral valve disease, LV is the last chamber, or it is never affected chamber, sir.
Okay.
And in the aortic valve disease, the first chamber to be affected will always be
Yes. So if we are having all this, what does it mean?
LV will be normal.
No. I am saying this is aortic stenosis or aortic regurgitation and LA plus RV, EDP normal, RA normal. What is it? What is your conclusion?
There will be a mitral lesion occurred with the AS.
If there is no mitral lesion, I am telling no mitral lesion with this. Something like this, something has happened.
If no mitral lesion, why LA pressure has
gone up?
Just now you wrote down normal RVDP, normal RA pressure.
AR can be there.
So LVEDP has gone up.
LV, it's got not AR there. It is LVEDP has gone. It can be AS, it can be AR. Now I am going to ask you, if it is AS, how will you know? AR, how will you know? Because you are going to go to the next step. We have gone to, we finished inspection. We are going to, I am working the reverse way now.
So from history, sir?
From examination,
how
will I know if it is AS or AR?
Sir, if in case of AS, it is a stenotic lesion. The heart will be small. So on inspection and palpation, we will have the apical impulse.
General examination?
Sir?
General examination?
AS patients will be thin-built patients.
So there will be water hammer
pulses. In AR, we will have water hammer pulses.
You can have wide pulse, narrow pulse.
Wide pulse.
We are a country where we diagnose pregnancy from pulse. In all Hindi movies, we diagnose pregnancy. Now you are finding difficulty in diagnosing AS versus AR?
No, sir.
Anything else in general examination?
So blood pressure,
Blood
we will have
pressure,
a wide
blood
pulse pressure. We
What
will have
is Hill sign?
Hill sign will be positive in AR, sir.
So all the peripheral signs of
AR
can be well situated. Whereas in AS you will have a
slow rising pulse.
Slow rising and late peaking.
Okay. Now what did you find?
Sir, in our examination on inspection, the apical impulse is on inspection it is seen
General
over there.
examination.
Yes, sir.
Pulse.
This patient.
So general examination.
Read.
Pulse.
Don't change according to my demands.
Okay, sir. Good afternoon, friends. So the patient, after getting consent, was examined in a well-lit room. On examination, from head to toe, there was no cyanosis or clubbing or.
We are discussing AS versus AR. Please come
there are
down
no,
to quickly to the findings.
There are no peripheral findings, peripheral signs of AR, sir.
Very good. Pulse?
So pulses
Are
are normal.
all the peripheral pulses are palpable?
Yes, sir. All the peripheral pulses are palpable, sir.
And any particular type of pulse?
Sir, no, sir.
Low volume
no,
No,
pulse?
sir.
Low volume, high volume, normal volume.
It was a normal volume pulse, sir.
Okay, I'll ask you to this thing. You are saying it is normal volume. Why did you check for all signs of peripheral, signs of, all pulses? Why did you check for all pulses in this patient? Sir asked, did you feel all pulses?
Yes,
Why?
sir. Sir,
Now I'm going to ask,
we
think
can-
in your mind, think very carefully. Small heart, dyspnea, and having long-standing disease, and is having difference in pulses. Now make it into one diagnosis.
Coarctation of aorta, sir.
One could be coarctation of aorta. Okay, continue. So don't close your mind to different things. Okay, then next.
Sir,
Can coarctation of aorta be associated with aortic stenosis?
yes, sir.
Okay, continue.
Sir, BP is 104/60. It was taken in the right upper limb in the brachial in the supine position, sir. And the JVP, it wasn't elevated, sir. Sir, on CVS, on inspection.
So again, JVP means normal means we are again saying RA normal.
RA is normal, sir.
RV normal. This thing. Okay, then next.
Sir, on inspection, the chest was bilaterally symmetrical. That was normal movements with respiration. The precordium, the apical when impulse was seen in the 6th intercostal space, half an inch lateral to the mid-clavicular line, left mid-clavicular line, sir.
What has happened?
The LV
It
has
is a big
enlarged,
heart.
sir.
Okay, then next.
So LA enlarges, which pressure goes up?
Sir?
LV enlarges, which pressure will be more?
More.
See, 50% chance of coming correct. Because LV has got only two pressures, systolic, diastolic. So look at the examiner's eyebrows and answer. First say systolic, then I am going to raise my eyebrows. Then you say LV, EDP.
Arey Baba, LA is enlarged. Sir is asking. So in essence, he is asking again, LVDP has
increased.
Increase.
Does this have implication for you?
Yes, sir.
See, we have not even examined the case completely. But tell me now, you know LA is enlarged. You are saying it is a patient of AR and the LVDP is raised. What is clicking in your mind as a surgeon?
Sir, we were thinking in terms of mitral, sir. So with the LA enlargement with mitral.
LA
and
normal,
also
I am telling you LA is normal. Mitral valve is normal.
Okay, sir.
You are having a large heart.
Okay, sir.
And what was the BP?
104.
60, sir.
104/60. Okay. That makes things more miserable. But what is the things which are clicking in your mind? What is your reaction to this? Are you surprised with this? I don't know what the final case is. I have zero idea.
Sir, if it is the aortic valve, then the findings are contradictory only, sir.
I am saying that it's a large heart.
AR means there should be, the pulse pressure should be wideless, sir.
I'm telling you, you are having now a large heart with a narrow pulse pressure with the LA enlarged. Means what?
मैंने कब से बोला उसको कि coronary angio बताओ. Regular operative, खाली operative session रखो ना पूरा, एक दिन का.
Means this, if it was aortic stenosis, you are having a large heart means what?
But in long case, unless
LV hypertrophy.
Not LV, now it has crossed the stage of hypertrophy, it is dilating, it is very
Dysfunction.
bad.
Dysfunction.
It has become very dysfunctional. Is this the case you would like to operate as your first case in your hometown? No. Okay, continue.
Sir, one more thing, there was in the drug history, he has been taking medication, sir.
What medication?
He's been taking beta block, sir. Prolomet he is taking. He's taking Prolomet, sir. He's also taking diuretic and tablet Pentid, sir.
Pentates?
Yes, sir.
Okay, so now pentates means you would think rheumatic. But what a beta blocker being present? Would you give beta blocker in an AR? No. Would you give it in MR by choice? No. Why?
DNB there only they give.
Why do you not give a beta blocker in AR or MR? We will not go into controversies, but generally. Why beta blocker is not given in AR, MR, but given in MS and AS?
Sir,
What happens if the rate falls?
the atrial
Dilatation of the
The regurgitation worsens.
Aortic cannulation, venous cannulation, ASD closure, MVR, AVR.
Sir, on palpation, the apical impulse is again felt over the 6th intercostal space, half an inch lateral to the left mid-clavicular line, sir. And there is no parasternal heave. There are no other pulsations. And on percussion, the right heart border corresponds to that of the right sternal border. And on auscultation, we are hearing a soft S1 and a normal S2.
Parasternal heave?
Is not there, sir.
Not there.
No,
So what does that say there? RV, parasternal heave is caused by what?
RV failure, sir.
What are the structures which causes the parasternal heave?
RV and LA, sir.
RV or LA. So we know now that the LA is not giant or the RV pressure is not high.
RV is
Please write it there.
Bye bye.
Then the next one. See, oh sure, bunking. We know, sir, we know you're taking one more class. Okay, so now we've already got so much of information, no? Without echo. Next.
Sir, we are having a soft S1 and a normal S2.
S1 soft means what? You can't just tell me something. You have to tell the consequence of it.
So by the closure.
So what does it mean if
So
S1?
Sir, it is a severe
mitral valve is not closing properly, sir.
It does not
severe mitral pathology.
Means what? Not severe mitral.
Pliability is
No. S1 soft means mitral valve is not closing means what is the lesion?
mitral regurgitation.
Regurgitation is there. Significant regurgitation preventing the thing from there. Okay, next statement.
Sir, S2 is normal. And we are hearing a low-pitched mid-diastolic rumbling murmur over the apex and with a presystolic accentuation, which is best heard with the bell of the stethoscope on the left lateral position with the opening snap just immediately after the S2.
You are really finding all these findings. I would like to auscultate the patient. Supervisor has supervised. Yes. And you are trying to tell me that that is what sir was telling. No, sir is actually bending his head. No, it's not me telling ye mera ladka nahi hai, ladki nahi hai. Sir is only telling me, not even able to look. Ye mera ladki nahi hai.
What does your physical examination, your murmur, etc., that you have found, give you an idea of the lesion? What is the lesion you're thinking of?
Sir, we are thinking in terms of valvular heart disease, which is involving the mitral valve, of rheumatic etiology. Most probably, my stenotic come as well as a regurgitant lesion also, sir.
Is it mitral stenosis prominent, or is it mitral regurgitation, or is it both?
Sir, more of stenotic lesion, sir.
LV size.
Then what could be the reason for a soft S1 in mitral stenosis?
A concomitant MR can be a reason, sir.
You said there is no MR. There
Sir,
is
no,
very
sir.
little MR.
MR is there, but more of stenotic we told, sir.
So why should it be soft?
Why is the LV big?
So because of the MR, the S1 is soft.
What can happen
Volume
in mitral
overload.
stenosis, chronic mitral stenosis?
Sir?
What can happen in chronic mitral stenosis? Sir is asking a very pointed question.
Calcification of the
Yes, that can give rise to a soft S1.
But now you are telling me the LV is big or small?
Sir, The LV is big, sir, because the apical
If the-
apex we are getting.
If the LV is big, how can you say dominant mitral stenosis?
Now there is a possibility.
That you'll have to.
You tell me all the diastolic sounds. Diastolic sounds. You have opening snap.
Yes, sir.
You have
If you don't know the
S3,
answer,
S4.
don't hesitate to say, I don't know. That's acceptable. We are not expecting you to know everything.
And in the exam, sometimes it's wiser to cut the discussion and move to another thing.
So the diastolic sounds are
Opening snap,
opening snap,
S3,
pericardial knock, S3, S4.
S4.
Could you confuse S3, S4
For,
to
for,
opening
for a
snap?
opening snap,
Because
Sir,
that can fit into your...
everything, because you are telling me large heart,
large
it would have been a
you
gallop.
say S1 soft.
Sir, S3.
How to differentiate between opening snap and a S3, S4?
Sir, opening snap will be a high pitched one. S3 will be a low pitched one. And an opening snap, it will the intensity will be more in during inspiration. Expiration. I mean, there will be changes during respiration.
Yep. Now see,
But
the
that-
whole story is that you are having a big LV.
Yes, sir.
So you have to be very careful. Now if you are telling that it is a dominant MS, you should have a small LV. If you are having a dominant MR, you can have a large LV. But then now in MSMR, what is the one chamber which is going to be usually very, very big?
LA, sir.
And which if you had a LA very, very big, what would you have got?
pulmonary artery hypertension.
No. Pulmonary hypertension, yes,
Dyspnea
but
will
something
be-
else. We just discussed it there. What are the liquid oxygen में डुबा लो? I keep telling, no. Oxygen उसको मरने नहीं देता है, liquid उसको जीने नहीं देता है. What lesions produce the biggest LAs?
MS, mitral stenosis.
MSMR.
MS, you have a hypertrophied left atrium, which is small.
Smaller. MR will be, जो अंदर आता है, it will come out. But
MR is
MSMR
what-
जीने नहीं देता है, मरने नहीं देता है. What goes in cannot come out. Hotel California. Okay. So then what would you get? Sir's actually favorite exam question, which we used to ask if Dr. Sampath Kumar is coming, he will ask to demonstrate this sign. What is that sign which you would have seen in a giant LA? He is heaving, looking at you.
Parasternal.
He is heaving
Parasternal.
parasternal heave. The parasternal heave of LA enlargement is this one gave a clue, answers. At least take the clue from the internal, no? Hurstos. It's called Hurstos. That is, it is, whole precardium will be moving forward because the RV is sitting upon the big LA when the regurgitant, it's a systolic push. Okay? You don't have that. Okay, continue.
Diagnosis. Sir, a valvular heart disease, most probably severe mitral stenosis.
How are you again? See, this is what I am telling, no? Even the examiner is literally pushing into
Moderate stenosis with
internal
severe MR.
examiner's corner of our eye is going up here, all four directions, and even external is trying to tell you that the heart is big, the heart is big, the heart is big. How can you keep on again going and telling severe? I don't
Moderate
know what the
MS.
echo is.
Moderate
But what
MS.
you are telling, based on what you told, we are telling that the heart is big.
Moderate MS with the severe MR.
Ah.
With pulmonary hypertension, without any signs of heart failure. Or
Mild,
without any
moderate,
signs
severe
of
pH, mild, moderate, severe MR, mild, moderate, severe MS, mild, moderate, severe pH. Everything has to be quantified. Is the pH severe?
No, sir.
Why?
We don't
Because
have.
you're not having
we
a
don't
heave.
have any
You're having loud
parasternal heave
P2.
or loud P2 illa, sir.
Loud P2 no illa. You said that, no? P2 is loud, you have told that. Then, so at least moderate pulmonary hypertension. Then, MS, is it severe?
Is the patient in normal sinus rhythm?
Yes,
or
sir. Patient is in normal sinus rhythm, sir.
then it cannot happen that he has a large LA.
Ah.
It is atrial fibrillation with mitral stenosis. He can have a large
Large
LA.
LA bites. Okay, next. So now, so you cannot be having significant amount of mitral stenosis because the LV is dilating. The only time the LV dilates in mitral stenosis is if tachycardia myopathy occurs and secondary dilatation occurs. But that is a rare thing. We are in sinus rhythm, you are telling. Okay, then next, what I want to do. Now you have established this. X-ray, ECG, echo, you have got to corroborate. Quickly, because we don't have time. X-ray, please put up the X-ray, please. Can the team put up the X-ray?
No, it is already.
In the meanwhile, what do you expect on the X-ray till they put it? What do you expect, and we'll see what we find.
So since the apical impulse is pushed down and out, we will find.
You tell situs.
Okay, so
So situs will be solid.
Then I told you.
Myocardia.
Cardiothoracic ratio. I am telling you, describe it in total. Then we
Cardiothoracic
will see
ratio
what
will
the
be
X-ray is.
increased.
Huh?
Increased cardiothoracic ratio.
You expect the cardiothoracic ratio to be the same. Then?
LV type of X will be there. LA enlargement.
Aortic knuckle.
Will be small, sir.
MPS. Keep talking.
MPA will be prominent.
RA appendage will be enlarged. LV will be pushed down when out, sir. We can see a double atrial shadow on the right side. And because of pH, we will see pulmonary plethora.
Do you see those things there? Do you see there?
Yes, sir.
One of those people sleeping there, that second boy there who is sleeping there, please come. Yes, next to you, next to you. Aao beta, come. Tamil Tambi. Yes, you. I'm telling you, with specs, next to the girl. Come. Arey, he's not coming only. Third row, get up. He's going. Come. Show me where the LA is in this patient. What's your name?
Can you trace the structures in the left heart border from top to bottom?
Come. Sir asked a question from top to bottom. Show me the structures.
On the left heart border.
Left heart border, from top to bottom. Describe. One pointer is there. First, okay. At the first bump, what is it? Next bump. Third bump. Third. What is that structure? Okay. Speak loudly. Down. Then below that?
LV.
Then now show me where the LA is. Take the pointer, go there and take the pointer and do it. No, you don't show. Right, let him pick it up. That is not the LA. That is the LA. That is the LA. Okay. Anything else? Now looking at this X-ray, what post-operative complication can you potentially have in this patient?
Sir, we are seeing calcified valves.
Okay, one, you are saying calcified valve, I will agree. Two, a calcified valve will not give a post-operative valve. I mean, you can get a stroke and other thing, that's a different thing. But I am telling you, this patient post-operatively, looking at this X-ray, what can you have in the post-operative period? I am asking LA. AF, no, he's in sinus rhythm. Look at that. Can you please see the bronchus? Mark the bronchus. And the right bronchus. What is the difference between the right bronchus? What is the difference between the right bronchus and the rest bronchus, which is classically seen here?
Playing of current.
Playing, but more important,
Narrowing of left.
it is so narrow, it is 1/3 the size of the. So what do you expect to happen in this patient post-operatively? I keep yelling at every student, no, that this you have to watch this, what this. What can happen in a patient who's got chronic compression of a bronchus?
Left lung will be under ventilated.
Can collapse post-operatively, atelectasis, all those things can happen. So, what is the consequence of atelectasis in the immediate postoperative patient, in this patient after operating? Let atelectasis occur. Let me atelectasis before it happens, something goes wrong. I spend 5 minutes making the patient cough. What is the problem that you all have seen if you have a patient with atelectasis, in a patient with mitral valve disease? What happens to the patient then? What ventricle fails? RV will fail. Why? Because there will be hypoxic pulmonary vasoconstriction of the atelectatic pair. PA pressure will rise and RV, which was not failing, will start failing. You have seen that happening, no? Okay, continue.
What are the chances of aortic valve disease in this case on X-ray?
Chances of aortic valve disease.
High, low. Because
Why? Small.
which aorta is small? Aorta is not one dot. For a cardiac surgeon, aorta is
In this patient, you are
root,
seeing
ascending, arch, descending thoracic, descending abdominal.
you really can see the thing here. What can you see here?
Which part is ascending aorta? Upper half of right border.
But you are not seeing the aortic knuckle
Upper
prominent.
half.
Upper half.
Half. Okay? Anything else is small? Knuckle.
Knuckle is small.
See the knuckle? Okay? Hardly anything. Good.
Can you tell me, come here. There is, can you see can you just explain the lung features here? Speak into the mic. There's a hand mic. There is cephalization. What other features are you seeing? Quick, you have to tell it. The faster you say, the faster we'll progress. Otherwise, Dr. Pooja will ring the bell. What increase? There is curly. Okay, you can see curly B lines here. Those are curly line. There is one curly line which I can see. No. That is a curly line. Okay, and you can see peribronchial cuffing. Okay, so now based up next, you have seen intracardiac calcification. How do you say that in mitral valve calcification?
When we draw a line from the cardiophrenic angle to the LA appendage, below it is usually the mitral valve, above it will be the aortic valve.
Okay. Next, ECG. Now predict the ECG finding. Predict the ECG. You have seen the X-ray, you have seen this thing. Now predict the ECG and then we'll put up the ECG. Quickly.
There will be LV strain pattern.
Strain pattern. Na? Left ventricular volume overload. Then what else? See, when you want to prepare it as a rate. What do you expect the rate to be? The rate is his. What's his heart rate?
When we got 60.
60. Rhythm?
Rhythm is regular, sir.
Sinus rhythm.
Sinus rhythm.
Axis, what do you expect?
Left axis deviation on all.
Okay. Then P wave, what do you expect?
Mitral might be there.
P will be, then what do you expect the QRS?
QRS, deep Q waves will be.
Non-infarct Q waves in V5, V6, LVH, man.
Yes, ma'am. Yes,
You will find LVH by voltage criteria.
Yes.
Now, do you expect PVH, R by S in V1, you expect it to be? Actually, the LA is a little big here. Okay, yes. We'll give it to you. Next, continue. Show the ECG. See, predict the ECG, see the ECG. Is it compatible with your diagnosis?
It is a standardized ECG with heart rate of 75 per minute.
No, I asked you the question. Yes. Is it compatible with your diagnosis? Yes,
yes,
no?
Sir.
Yes. Is there LA enlargement?
Yes, sir.
How do you say there is enlargement?
So there, V1, the P wave is the negative, more than one small wave.
Negative
terminal P wave deflection.
See, you have to rattle those things. Yeah, negative terminal deflection, more than 1 millimeter. If you just rattle it, then the examiner knows you know it, so you won't go there.
Yes.
Is there LVH?
Sir, in this ECG, we are not able to get LVH. VS1 and, V6 plus R wave in V6 plus S wave in V1 is coming to 32, sir.
32, but your S wave is more than 7 millimeter. That's an alternate criteria. There is LVA.
Yes.
But you are not, okay. Then, okay, next, echo.
You said no pH.
No
Compatible, not compatible.
Compatible or non-compatible? pH.
Everything you say has to be shown there. You said no pH. Compatible ECG, not compatible ECG. Are look at the ECG.
Look at the
man.
ECG, V1.
Who prevents you from looking at the ECG?
Yes, sir.
Is it compatible?
What, yes, sir?
Correct or wrong?
Compatible.
Huh?
Compatible because
Because
see the R wave in
there's
V1.
no R wave,
No wave,
no
yes,
R
No
wave.
R wave in V1.
No R wave in
No R wave.
Okay. Chalo, echo. Echo for what?
So planning about the surgical management and to
Ha,
confirm the
nice
diagnosis.
sentence. It's a cliche sentence. Planning surgical management. Echo is not for what is obvious. Echo is for what is not obvious. So what is not obvious so far?
So the diagnosis one. if
Severity
there is
of AR and AS. Two
so
LA
for-
clots.
Yes, sir.
LA clots.
LA clots.
LV
if-
function.
Yes, sir. If there is
Okay.
any submitral disease.
So something which is very obvious, you don't require echo.
Yes.
During our times, entire mitral stenosis was on stethoscope, not even X-ray ECG also. Okay? Now you read accordingly.
Sir,
LV dimensions normal.
LV dimensions are normal,
So,
sir.
so
There is
what
no
is ruled out?
dysfunction. LV dysfunction.
AR ruled out.
AR is also.
LV thickness
No hypertrophy.
normal.
It's normal.
What is ruled out?
LV.
AS ruled out. Third, LA
LA size is increased, sir.
increase aneurysmal.
And
64 by 64.
Yes, sir.
Huge.
Big LA, giant LA.
Volume will be 6 cubes.
Yes.
So Sasak 36.
It's given here, LAVI. You know what LAVI is? Have you heard of the term LAVI? Today, everyone talks of LAVI, because we are talking of atrial MR, this thing, that thing, functional MR, atrial MR, organic MR. So LAVI is left atrial volume index. You should be knowing those terms because they ask you about it. Because
Okay, next.
normal aortic valve with mild regurgitation. I want to know what is the importance of this mild regurgitation for you as a surgeon?
Sir, during plegia,
What about
if there is a significant regurgitation, we have to plan accordingly.
if I am unable
To deliver the plagia, we'll have to plan accordingly.
Yeah. Now tell me your management of delivering cardioplegia in this case with this AR.
Sir, I will go with a root plagia, sir.
Correct. Next. What else you will do?
Sir, in case the delivery is not adequate, I'll.
How do you know? How do you know? Not adequate. Heart is going to say, "Hey, I did not
LV will
get
start
cardioplegia.
distending.
मेरा cardioplegia किधर है? ऐसा heart बोलने वाला है.
Immediately the LV will start distending, sir.
How will you know? LV seen?
No, sir, it is
Then?
posterior. The heart will become anteriorly.
Acha, you wait for the heart
For
to
the
come
heart
and
to
And
you
we'll keep the hand
a
below.
tape,
like a balloon.
Keep a tape measure. कितना heart
What
ऊपर
is
आता
the
है?
thing that you see right in front of you, which will tell you that you will see a structure right in front. When you are starting cardioplegia, you don't wait till the LV distend. He gives cardioplegia. What is it that you see?
Your hand should go where?
Posteriorly, below the heart. And
Around the heart.
around the heart, sir.
And feel for the LV.
Yes.
What will happen in this case? This case. If you answer, gold medal. This case, LV will distend, not distend. Patient has got grade 1 AR.
In this case,
LV will not distend.
distend.
Why?
why? Which regurgitation?
Sir, mitral regurgitation.
Mitral regurgitation.
So what will you
So
see?
where will you look?
So where will you be looking at? Actually, you can even feel. I always tell everybody when giving cardioplegia, no hand give, everything is later. When you are giving cardioplegia, what is the one thing that I tell? Pull back, see some structure. In fact, if you want,
LA
palpate
appendix.
the structure.
LA appendage.
Right in front of you, when giving cardioplegia,
Aortic root.
is the root pressure adequate or not? You can put your finger and feel.
And straight away put a vent into LA or stab the LA and allow it to vent by itself. And that will tell you, the jet will tell you the severity of AR. Okay? How do you remove clot from LA? Both these sirs want to have operative discussion. Tell me steps of clot, LA clot removal. We have got time now. तुम्हें बेल बचाता ही नहीं, वो बेल सिर्फ मेरे लिए होती है.
10 minutes for no warning. I didn't know that. Tell
No
the steps of LA clot removal.
Yes, sir.
Where is MR written?
See how they went on to telling severe MS because they had the echo in advance. That is, I would go back and see the thing. There is in fact significant amount of mitral.
Sir, the mitral valve annulus open, or if I say that is 0.7 centimeters.
What I'll ask you, calcified valve with 0.7 area and dilated LV can be false estimation of the mitral valve area because of echogenic blooming of the echocardiographic image. Okay.
Tell me clot removal.
Sir, after
LA open.
Yes, sir.
Coolie retractor put. Patient for mitral valve replacement.
Yes.
What will you do first? Remove clot first or mitral valve first?
Remove clot first.
Why not mitral valve?
Sir,
Patient has come for mitral valve.
pieces of the clot can go into the LV, so
Very
to
good.
prevent it.
Excellent. So mitral valve, particularly stenotic valve, acts like a barrier. 2. Where will you look for clot?
LA appendage.
How do you see LA appendage?
Sir, we'll invert the appendage.
Invert the
Invert
the appendage.
Invert the appendage from outside.
From outside. 1. 2. Clot obviously seen. Now what you do? How do you remove clots?
We'll take a Russian forceps, sir, and
Very good.
spatula
What is so
and-
special about Russia? India has got good relations. Cheap
What is the
oil.
peculiarity of the Russian
Cheap
force?
oil.
So they are broad and spoon shaped, sir, so they will hold the clot and not
No, they don't crush the clot.
crush the clot.
Friable clot can
Like
be
this.
held without.
Like this.
Yes, sir.
Area is increased. Pressure
Okay?
is equal to force
So
by
it's
unit
called,
area.
first step is berry picking
Pick
with
out the
Russian forceps. Any other forceps? Sponge holder you can
shoulder
use.
or a woven force.
Without ratcheting.
Yes, sir.
Without ratcheting. Okay? So again, sponge holder has a large holes.
Yes, sir.
No crushing of clot.
Sir,
Technique number 2.
we'll hold it with the, if it is a
Technique
chronic
number
clot.
2 is peeling.
Yes, sir. We'll
Like
hold it with
banana
the
peel.
forceps and peel with the,
What do you peel and what do you berry pick? What do you peel and what do you berry pick?
Soft clot.
soft clots will
Soft red clot is
berry pick.
berry pick, whereas the
Chronic
organized,
organized
white
clot will
clot, what you call as lines of Zahn, no? So you take the
Old clot.
old
Whitish
clot,
looking.
organized clot.
That
So
will
That you
peel off
create
the-
a plane
Yes.
how
on
do
the
you know the
posterior
plane
LA
is
wall
correct?
and pick it. Third
How do you know
technique.
the plane is correct when you are determining? How do you determine the plane? How do you get the plane?
So with a 15 number blade, we'll,
You take a 15 blade and incise?
no, sir,
No.
we'll make a small nick and
No.
You scratch with
Scratch.
forceps
With
tip.
the forceps, you take a mosquito forceps and don't you
Scratch
see
it.
that? We take
Till
a
you
mosquito
see a
forceps and then
glistening layer.
layer, that will be LS.
Third is shaving. How do you shave? Not you, patient. With a gauze piece.
Yes, sir.
Dry or wet?
Wet gauze piece.
Dry. Dry is rough. Wet is soft.
Softer.
Okay? So wrap the gauze piece on your finger and single stroke. Change the position. Single stroke. Throw the gauze piece. Take another one. Okay? This is third. Fourth technique. Suction. Your external suction should be used to chlorine. And the Tukaram Dhondu who cleans the suction should be standing there.
Yes,
Because invariably one clot will go and block the suction. Fourth, multiple washes.
yes, sir.
Number
where do you
5,
check when you do the washes? Where do you check? specifically for residual clot?
Pulmonary artery, pulmonary vein, sir.
Which pulmonary vein?
Right
Left side pulmonary vein.
Left
Which
pulmonary
left
vein.
side pulmonary vein?
Left
Left inferior pulmonary.
pulmonary.
So your answer should be starting with left inferior pulmonary vein.
Why?
The most dependent.
Fantastic. अच्छा बोल रहा है यार ये लड़का. Very good. Understand? And throughout this, your assistant should be generously using suction.
Yes.
Okay?
Why does this patient not undergo a balloon mitral?
So there is an concomitant MR also, sir.
One
So there is
MR,
submitral
two,
disease
And there is
present.
severe submitral
Submitral
disease.
disease present.
Suppose the MR was mild.
Yes.
When you are taking out the clot, remember to put off the vent.
Yes, sir.
You don't want clots to go through the vent into the oxygenator.
What else can go into the vent? Apart from clot, this case,
Calcium, sir.
this case, अभी तक वाल तक पहुंचा भी नहीं है. Water,
Saline. Yes.
that will result in
Dilutional.
water-
Hemodilution, sir.
hemodilution. What else dilution? One is hemodilution. What else will be diluted? Oncotic pressure,
Yes, sir.
proteins.
Proteins will be diluted.
Understand?
Yes.
So good perfusionist keeps a watch on orders what the surgeon is talking.
Yes.
And moment the surgeon says wash something, immediately
Stop the vent.
vent is stopped. Cold saline or warm saline?
Cold saline.
See the 4 seconds, 5 seconds you took is bad.
Cold saline.
Cold saline. Huh? The practical exam,
Why? Not warm saline.
So the heart is arrested.
very good.
You do not want to rewarm the
Rewarm the
heart.
heart.
Chalo, over. Over.
Yes, sir. I'll go with a mechanical valve, sir, because the age is 33 years. I'll prefer
What band will you use?
TT ke Chitra or Miltonia valve, sir.
What is the opening angle? What's the disc made of?
So the disc is made up of carbon plus,
Chitra valve is made
cobalt plus chromium.
Chitra valve leaflet is made of? What color is it?
Leaflet is white, sir. Polyester.
Not polyester.
Polyethylene, sir. Sorry, polyethylene, sir.
What one?
TT
Chitra
ke
valve,
Chitra.
I must
What
say,
is what?
high,
High molecular weight.
high density, polyethylene,
Yes.
HDPE,
Yes.
ultra high density.
Called ultra high molecular weight poly.
Yes.
And this thing,
Sewing ring is
is made of?
What kind of valve is this? Is this a tilting valve?
tilting valve.
Bi-leaflet?
Tilting was single leaflet valve. Tilting
what-
disc, single leaflet valve.
Yeah, what is the precaution that you will take if you choose a single leaflet valve, tilting disc valve?
Fitted in anti-anatomical position, sir.
What is anatomical position?
So for anatomical position, the opening higher, the wider opening should be towards the LVOT. In the anti-anatomic, it is perpendicular to the.
No, he is telling
Yeah. But you have to tell me before that, are you going to save the subvalvular apparatus? Caudal preservation, how are you going to do it? Are you going to do it at all? What is the practice
We'll
in
try
your
to save
institution?
at least one caudal apparatus if possible, sir.
No. You try to save one caudal apparatus, then you will only protect 1/3 of the ventricle.
Yes. If both is possible, we'll try to protect both of them, sir. If
Yes,
at least
there
one.
are so many methods by which caudal preservation can be done.
Yes.
And it's unethical to do complete caudal resection or even partial caudal resection and leave only the posterior caudate. that will lead to ventricular dysfunction in the long run. You must
Preserve
try and preserve 100% of the chordae. It is possible.
Yes.
Even in calcified patients, it is possible. Now you tell me, what is the advantage of caudal preservation? What is the advantages?
So,
You know or you don't know?
so the LV anatomy shape will be preserved with the powder.
LV geometry.
Geometry will be preserved.
Preserved. One. Then
Something else, reduction of some event.
I'll give you a clue. There are 5 or 6 advantages of total caudal preservation. One, you said LV geometry will be preserved.
Yes, sir.
2,
AV disruption can be preserved, sir.
the
Prevented, sir. Sorry.
rupture, ventricular rupture is prevented.
Yes, sir.
Early mortality is less.
Yes, sir.
Late mortality is also reduced.
Better survival.
There is practically no need for inotropic support post-operatively if you preserve all the chordae.
Yes, sir.
It also preserves the right ventricular function. Remember all these things.
Yes, sir.
Caudal preservation is mandatory. It is unethical to do a valve replacement without caudal preservation. Now, if the chordae are all calcified, then you must produce artificial chordae. It has been demonstrated that calcified subvalvular apparatus, if you have to excise it, then you have to use artificial chordae to preserve the chordopapillary alignment.
Yes.
The key word here is you should be knowing Cobb's untethered loop hypothesis. Understood? If you just vomit that word, 90% of discussion will stop. Cobb's untethered loop hypothesis.
In my experience, caudal preservation can be done in 100% of patients undergoing mitral valve replacement with either mechanical or bioprosthetic valves.
Thank you. You can assessment of the...
Sir, I had a question.
Yes, what is your question?
Sir, like you said, we can make neocordates, sir. What is the minimum neocordates from each side that you prefer, sir?
It depends on what you have excised. If you have excised one part of the anterior chordae, that is the only one that you need to replace. If you have excised all the chordae, then you have to replace all of them. There are 4 or 5 papillary muscles.
Yes, sir.
You have to connect the mitral annulus to all these and keep the distance proper. Measure the distance and correct it.
Yes, sir.
Only thing I will say is, it's not what you talk, it's how you deliver. That's very important.
Yes.
It's how you deliver. So look straight at the examiner, not with adamancy or arrogance, but speak firm and clearly. So it's not what you speak, how you speak, that's important.
Yes.
I think overall you have done well, 37 months.
Thank you, sir.
Thank you, sir.
Thank you so much for this wonderful discussion. Thank you, Sampath sir, Anand sir, and Prasanna sir. Now we will commence the program that was highly anticipated by the residents. It's on the ECG for CT surgery residents. I invite Dr. Anil Tandulkar to deliver this lecture. Thank you, sir.
Good evening, sir.
Good evening.
So I am going to present ECG for residents, and this presentation is with respect to exam preparation. You will be asked ECG in long case, short case, and ICU rounds. I am not going to talk about ICU rounds. I don't know whether you have got spots in DNB. Do you? Do you have spots? ECG spots in DNB? No. Okay? So it is only long case and short case. So there are many methods of reading ECG. Most important, master one method. Can be done, can be done, can be done. No. I do in this manner. So I am going to talk, I am going to do in this manner. Most important, I am a surgeon, not a cardiologist. Looking at a cardiological discussion, many of my friends were asking whether this is cardiology or surgery's exam. So I am not a cardiologist, I am a surgeon, pakka surgeon. My knowledge is limited, relate to case-related ECGs. So I am going to talk things which are extremely common. So ECG reading can be divided into two: general reporting and number two, specific reporting. Specific reporting could be waves and segment-wise reporting. So PR, P, PR, Q, R, S, ST, this is segment-wise reporting. Number two is chamber-wise reporting, which I am going to do. I do it regularly, chamber-wise reporting. And this is the way we ask you questions today. When this is a tetralogy, you are asked whether this is tetrad or not. So you must know which chambers get enlarged. So hemodynamics knowing is very important. So general reporting is rate, rhythm, axis and loop. So let us start with rate. So how do you calculate rate? Count the squares between any R wave. And for regular rhythm, 300 figure divided by number of small squares. This is rate. Small squares is 0.04 second and large square is 0.2 seconds. Number two, everywhere you must be noticing, I am writing down correlate with the case. So if you are given a case and you are asked the ECG about it, immediately say whether this rate correlates with this case or not. For example, patients on beta blocker, aortic stenosis, tetralogy of Fallot should have a slow heart rate. Number two is rhythm. So normal sinus rhythm has a rate of 60 to 100 per minute. It's a regular. Most important, every P wave is followed by a QRS complex, and typically P waves are upright in lead 2 and AVF. The axis of P wave is similar to QRS axis plus 60 degrees. So the leads which are down, lead 2, 3 and F, P wave is always positive in direction. In congenital heart, this P wave axis tells you whether the triggering rhythm is sinus or AV node. If AV node, the axis will be directed from node to atrium, so it gets directed upwards and P will be inverted. Atrial fibrillation, you will see irregular RR interval, absence of P waves, and you always see fibrillatory F waves. These are small chaotic waves are visible on the baseline. Most important, the QRS complex is narrow because after the atrial chaos, the conduction system, the current enters the standard AV node and right and left bundles. So QRS complex has to be narrow. And ventricular rate is often rapid. Then is the axis. These are various ways of calculating QRS axis. I take two axes which are at 90 degrees to each other. So you have got lead 1 which is not plus, 0 to 180 and AVF which is minus 90 plus 90. So on that you have most important geometric summation of QRS. So Q is minus, RS plus, S is minus. So minus plus minus and find out the terminal and decide the axis. There are many combinations of these 90 degrees. So I am not going to confuse you. I never use them. I only use 1 and AVF. Now, I ask in the morning, don't just tell the axis for just, axis is normal or rightward axis. Tell accurately what is the axis. Most important, axis tells you severity of pH. If you have got an old ECG, and old ECG axis was 90 and now it has become 120, it means the pH of this patient has increased. Number 2, diagnosis of VSD, ASD. VSD, till you see the ECG, you can't tell the type of VSD. Moment you get a negative axis on VSD, it is an inlet type of VSD or AV cushion type of VSD. Number 2, as I told you, in tetralogy of Fallot, axis is always plus 135. Extreme right axis deviation is seen in patients of pulmonary valvular stenosis with suprasystemic RV pressure. Negative axis in cyanotic heart disease is common in tricuspid atresia because there is no RV. All the voltages are on the left side. Then is the loop. It is beyond my knowledge to explain you the loop. But if you see Q waves in 2-3 AVF, it is called clockwise loop and is typically seen in perimembranous VSDs. If you see Q waves in 1 and AVL, it is called counterclockwise loop, and this is for the first time in a VSD diagnosis. You see this, first time you realize that this is not a standard perimembranous VSD, but an inlet VSD or AV cushion VSD. Then specific reading should be done according to the diagnosis. I had asked the previous girl that mitral stenosis, how do you diagnose? Tight mitral stenosis with severe PH, with atrial fibrillation, with. So every word you said, you talk with respect to ECG. Mitral stenosis. So you must see this chamber enlarged. So you must know what is the hallmark chamber for every disease. Similarly, there is one chamber, there could be a chamber which never enlarges in that disease. For example, in ASD, you should never see LV. In mitral stenosis, you must never see LV enlarge. So, on ECG, you please ditto, you report that LV is not enlarged. No evidence of LV volume overload. Third is anything which has a chamber which is enlarged, how badly it is enlarged. So that is called strain pattern. For example, left ventricle in aortic stenosis or aortic regurgitation, or right ventricle in patients with severe PH or severe PS can show strain pattern, mismatch between the demand and supply. And peculiar features of a particular disease should be mentioned. For example, incomplete right bundle branch block in ASD should be typically mentioned. So when you do a specific reading of ECG, it comes under 4 headings: hallmark chamber enlargement. Number 2, chambers which should not dilate have not dilated. Number 3, that chamber enlargement, how bad it is, whether it's strain or no strain. This tells you whether need to operate or need to conserve. And last is peculiar features like incomplete right bundle branch block and sudden transition. Dr. Sitaram Bhatt told you in the morning, large VSD and the interventricular septum in tetralogy Fallot is in coronal plane. So LV is totally posterior and you have a large VSD. So when you come to V2 or V3, absolutely no RV forces, suddenly you start reading the LV forces. So sudden transition, these things should be specifically told. Now let us see how do you diagnose each. So how do you diagnose LA? It is P wave. P wave duration and P wave depth. Both are equally important. Just let me ask you, which case P wave duration will be more? Sorry? Regurgitant. MR is regurgitant. LA is large. So duration will be more. Which case P wave voltage will be more? Mitral stenosis. So LA will be thick and generating more voltage. So the duration is measured by the base of P wave more than 120 milliseconds, and the axis, because of LA is enlarged, the terminal axis goes towards the LA in this direction. So this is negative. So if you see a positive and we'll see a negative. Positive is because of whom? RA. Negative because of whom? LA. So if you see only negative P wave, that also shows LA enlargement without pH. So this is how you should constantly correlate your findings on ECG with the diagnosis. And this should be always seen in lead V1. P wave enlargement will be also seen in increased LV-EDP and RV-EDP. So peak P waves you will see in RV-EDP enlargement, and biphasic P wave you will see in LA enlargement. So the two peaks should be separated by at least one small square to call it a P mitral A. Next comes LV by voltage threshold. So this I came to know yesterday only when I prepared this preparation. Sokolov-Leon index. Suffice to say, voltage criteria. There are many criteria. So SV2 plus RV5 more than 35 tells you that this P wave, this LVH is significant. Now, second system I like more because it tells you what are the aspects of LVH. Number one, this includes the 4-point problems of LVH. So one is a voltage. Number two, axis. If LVH is more, axis starts becoming negative. Number three, strain is present or not. And number four, LVDP is increased. If LVDP is increased, LAE will be seen. So in this second system, Romhild S-test score system, you say LVH 3/4 or 4/4 or 1/4. Voltage, strain, axis, and left atrial enlargement if it is seen. So LV strain pattern, it has been shown in that ECG pattern. You have got ST elevation in V1, V3, or ST depression and T wave inversion in lead 1, AVL, V5, V6. These are dedicated leads for the LV. Next is LVVO, typically seen in patients with AR. So tall, pointed, symmetrical T waves, as you see over there in V5, V6, due to increased diastolic wall stress. Deep, narrow QRS Q waves, often present in V5, V6, sometimes called septal Q waves. As LV enlarges, LV interventricular septum starts coming towards patient's right, and instead of sensing it in V6 and beyond, you start sensing it earlier. And of course, increased QRS R wave amplitude, same voltage criterion. Then is RV, common finding. The lead dedicated for RV is V1, Any other lead dedicated to RV? V4R, remember. If V1 is confusing to you, go for V4R. V4R is absolutely Bhakta lead of RV. So if V4R shows no R wave, that means RV is really absent. So RV systolic pressure rises, RV hypertrophy takes place, and axis starts becoming right. And it has a very important, more important to us, prognostication importance. So after surgery, if you are asked what will happen, this R wave, as RV pressure comes down, this RV height also will start decreasing. Then you will start seeing R waves more prominent than S waves. So it's called R by S ratio. Prasanna was talking about it in the mitral stenosis case, which tells you the severity of RV pressure. With rise in RV EDP, P wave will start going up. So you will start seeing a peak P wave height more than 2.5 millimeter. And when there is a strain, typically you will see QR pattern in V1 or RBBB. So similar to LV, you look for axis, number 2, voltage, number 3, strain pattern, okay? And P waves. Now in ventricular septal defects, there is LVVO, and Dr. Iyer was asking you, immediately the baby starts developing PH. So there is RVH also. So there is a biventricular hypertrophy. So how do you diagnose individual hypertrophy? So way of diagnosing is called Kaczmarek phenomenon. All these German words, k, k, sh, you should pronounce. Then it looks German. Looks like you have visited that place. So large, every word is important. Large equiphasic QRS complexes in mid, so that is the intraventricular septum, which sees RV also and it sees LV also. So in V3, V4 position, you must see large equiphasic R and S waves, and the summation should be more than 35. Just R wave 35 has no meaning, or just S wave 35 has no meaning. You must see R and S equal, and the summation is more than 35. That shows Kaczmarek phenomenon. It's a LVVO plus development of pulmonary hypertension. Another peculiar feature of secondum ASD is incomplete bundle branch block. Duration is typically less than 3 small square. So small R wave is the septal depolarization. Then comes S wave and a tall R wave, that is the remaining RV. How do you calculate pH in this case? Not by the small r, by the large R. So if you are writing notes, please, I should have written down. So you must calculate the height of this wave. This wave. This wave will tell you how much is the RV body pressure. This is just a septal depolarization wave. Okay? What happens to RBBB after ASD surgery? Remains the same. So P2 may remain wide split, but it won't be fixed split. Any anesthesia students? No? No anesthesia students? Don't have students, but have students, but not come. You don't have cardiac anesthesia students. Anesthetist should know what happens to all these ECGs after surgery. Because the lady may come for tubectomy or hysterectomy or cesarean section. So they must know from the ECG what changes will continue, what changes will not continue. ECG of tetralogy, since morning we are discussing. So this is more of a revision. Right axis deviation, always almost always present and is almost always typically plus 135 around that value, because RV and LV are equally hypertrophied. RV hypertrophy is always present, and it is the R wave height. In the olden days, cardiologists used to multiply this R wave height by 13. So 13 सत्ता 91. So 91 RV pressure will be if the R wave is 7 millimeter in V1. And if V1 is not showing R wave, where else you will check? Just now I told you, V4R for that. Most important, this is since intrauterine life. It is not just RV hypertrophy, it is RV hyperplasia. So the cells, the blood supply, like a planned city development. Everything has grown. So RV never shows strain. So you should not see QR pattern in V1. Fourth is sudden transition. Number 2, certain chambers should not be seen. So which chamber should not be enlarged in tetralogy of Fallot? LV. LV should not be prominent forces. If present, you must suspect patient has developed aortic regurgitation. Ductus is a compensatory phenomenon in tetralogy. It can never ever give rise to LVVO. And right atrial enlargement is only seen in adults when RV EDP goes up. This may be, RBBB is always seen after surgery. So if you are seeing a tetralogy of Fallot in ICU, you please look for left anterior fascicular block. So in that, you will see RBBB with left axis deviation. This is how I remember. Prolonged PR in AS causes, first thing that comes to your mind, prolonged PR in AS. Obviously, no thought block. Calcification of at the region of AV node, that is which area? RCC, NCC. Don't worry, there are 3 leaflets. So तीनों में से एक तो correct आने वाला ही है. Keep on looking at examiner's eyebrows. Huh? If you say for RCC, then he says, sorry, sir, I mean NCC. So tongue of slip, you can always give an excuse of tongue of slip. And these are the causes of prolonged PR interval. Okay? We don't normally get rheumatic patients with active rheumatic carditis. So, but remember, beta blocker, calcium channel blocker, digoxin, in ICU rounds, hyperkalemia, all can give rise to increased duration of PR interval. ECG of AS may be given to you, and they will ask you, what are the chances of this patient having a permanent heart block or permanent pacemaker after surgery? So please look at the PR interval, which will tell you the needful. Thank you very much. This is a small part. So most important, before reading an ECG, please write it down. Which are the chamber enlargements in the order of chamber enlargement. So mitral stenosis, start with LA, then go to RV. Understand? Don't say RV and then LA. And accordingly, go on following those chambers. Thank you very much.
So much for the wonderful discussion, sir. Now let's go on to echo for CT surgeons. It's my pleasure to invite an expert in intraoperative echocardiography to demystify the reams of echocardiography of for our residents. I invite Dr. Parimala Prasanna Simha, who is a professor and head of Department of Cardiac Anesthesia at Sri Jayadeva Institute of Cardiovascular Sciences, to give this address. Thank you, ma'am.
Relevant to the surgeons, I have no disclosures. I'll be discussing about transesophageal views, transthoracic views, and if time permits, epicardial and epiaortic views. So the TE probe is a phased array transducer, which is a modification of endoscope, which can be inserted in the esophagus. And so we have different rotations available with the probe. We can push it in, it is called advanced or withdrawn, and we can flex it, so anterior and posterior movements are possible. Similarly, lateral movements are also possible with this probe. And we view the heart at various levels, upper esophageal and then mid-esophageal level in this cross section, then transgastric views and deep transgastric views. And based on this, American Society of Echocardiography has given 28 views. And this is how the transducer, it's a phased array transducer which scans the heart. So instead of going through each view, I'll go through views which are relevant for a particular pathology. In aortic valve assessment, we have mid-esophageal views in transesophageal echocardiography, which is similar to the transthoracic parasternal short axis view. The difference is aortic valve right coronary cusp is farther away from esophagus, whereas in transthoracic it is near the probe. This is a case of aortic aneurysm, Marfan syndrome. You can see non-coaptation of leaflets in the aorta, and there is a dissection flap appearing. This is in short axis. Then we use a long axis view, which is called parasternal long axis in transthoracic. This is used for measuring the annulus and ascending aorta at various levels. And also it helps in color interrogation of the aortic valve. See, same picture here, ascending Marfan syndrome with ascending aortic aneurysm and aortic regurgitation. There is a dissection flap also seen. This is a case of ruptured sinus of Valsalva aneurysm from right coronary cusp in mid-esophageal long axis view. You are seeing a sac. That is the sinus of Valsalva aneurysm with AR. This is a case of bicuspid aortic valve in short and long axis views. You can see there is a vegetation seen on the aortic leaflet and severe AR. Next we go through the 5-chamber views, which is called apical 5-chamber in transthoracic. Here the aorta is seen, and this is a zoomed view. Again you can see non-coaptation of leaflets and a dissection flap there. And this is post bioprosthetic valve implantation. There is severe AR. We also make use of deep transgastric long axis view, which aligns the Doppler for spectral and color Doppler interrogation. Then transgastric long axis view is at 110 to 120 degree. Here the aortic valve can be aligned for Doppler again. Then we go to upper esophageal views in long and short axis at ascending aorta, arch and descending aorta. You can see here the dissection flap in the ascending aorta. The blood flow is in true lumen and it communicates with the false lumen. So these are the pictures of ascending aorta in short and long axis. The right pulmonary artery wraps around the ascending aorta. There is an arch view which shows the arch in long and short axis. Here pulmonary artery and valve can also be seen. This is used for assessing dissection flaps and other aortic pathologies. We can also use descending aortic views for aneurysms or atheroma assessment. For mitral valve, we have to make use of the 2D to get a 3D picture. So we make use of different views. This is apical transesophageal view at 4-chamber. then 2 chamber, and at the commissural level and long axis. So here we see A2, P2. Here you can see, and if we go to the 5 chamber view, that is when ascending aorta is visualized, you get A1, P1, and in 90 degree you get P3 and A1, A2, A3, and in commissural view you see P1 on the right hand side, mid is usually A2, then P3 on the left hand side, and again in long axis you see A2, P2. So this view is a 5 chamber view where aorta is also visualized, and you see there is a P1 segment which is prolapsing and a severe AR. So at 0 degree, at various levels, at 5 chamber you see A1, P1, at 4 chamber you see A2, P2, and lower down when you start seeing the tricuspid leaflets, A3, P3 segments are visualized. This is a case of mitral stenosis with thickened restricted leaflets and sluggish blood flow there. And this is a transgastric basal view, which is again showing thickened mitral leaflets. And for mitral regurgitation, we make use of these views. Mid-esophageal long axis, here it's again a rheumatic pathology with thickened leaflets. And this is a commissural view showing the regurgitation again appearing from the P1 and A2, in between P1 A2 segments. This is 2 chamber view for submitral assessment. Here you see the chordae and papillary muscles, so you can assess thickening, tethering or other pathologies in the submitral area. This is a transgastric basal short axis view for congenital heart disease. There is a cleft anterior mitral leaflet. You can make out this is the anterior mitral leaflet, and you can clearly see that there is mitral regurgitation occurring. This is another view where you are seeing a primum ASD with cleft mitral regurgitation. You can see that the blood is flowing here as regurgitation. It's not arising from the orifice, it's because of the cleft you see. We also assess LV function with echo by various views. In mid-esophageal, we make use of 0 degree for anterolateral wall and infraseptal wall. At 90 degree, we see anterior and posterior walls. At 120, it is anteroseptal and inferolateral. So 17 segments, all the 17 segments can be assessed with various views. So the short axis of the LV can be assessed at basal level where mitral leaflets are seen, mid level where papillary muscles are seen, and further down apical level. And transgastric 2 chamber view also helps us to see the anterior and inferior walls. And this is showing the LV function. You can see both functions are good, but RV is dilated and there is pericardial collection. Now tricuspid valve assessment can be done at various levels, and 0 degree mid-esophageal we see the leaflets, and also we can see the color Doppler. This is a case of Epstein's anomaly. Large RA with a clot in RA, you can see sluggish blood flow, bowing of the septum to left, and you are not able to see the leaflets at the usual level, so there is atrialized RV here. So this is another view for tricuspid valve, mid-esophageal RV inflow outflow view. Here we see the tricuspid leaflets RV outflow with pulmonary valves. Pulmonary valves are again visualized in this RV inflow outflow view. In this patient you can see there is a atrial septal defect, large RA, and one second. Okay, so RVOT can be again assessed in the 90 degree where we can see the pulmonary valves. Sometimes we can align Doppler, but Doppler alignment for pulmonary valve is better with upper esophageal aortic short axis view. Another view is bicable view, best for atrial septal defect. Here you can see the bubble contrast, which is showing bubbles entering the RA and some of them escaping towards LA. But otherwise, during surgery, when we are weaning from bypass, we make use of transesophageal echo to rule out air in the left side of the chambers. This is a case of atrial septal defect with the color flow showing left to right shunt. Modified bicable view is used to visualize the tricuspid valve for tricuspid regurgitation assessment, and in this view we see coronary sinus on the left, which helps us in guiding the surgeons for coronary sinus catheter placement for retrograde cardioplegia. Left atrial appendage is imaged at 90 degree and velocities help us to know the risk for clot formation. Pulmonary veins, sir was saying the left lower pulmonary vein, it is seen in the 90 degree in midesophageal. We withdraw the probe and by further posterior probe rotation we can see left lower. Usually upper vein is easily seen, and further posterior probe rotation helps us to see the lower pulmonary vein on the left side. Coronary sinus is seen at 0 degree in the midesophageal by advancing the probe from 4-chamber view. At 120 in the transgastric, by rotation of the probe towards right, we can see RV inflow-outflow view. Here we can assess RVOT, and in tetralogy cases we can see the gradients, and by rotating further to right we can see the IVC hepatic veins also. I'll go through some of the transthoracic images. Here mainly we make use of parasternal, long axis, then short axis, then apical 4-chamber, then subcostal. So there are various maneuvers. In transesophageal we can go from 0 to 180 degree. Here we have to get those images by sliding, rocking of the probe or tilting or by rotation. So there are mainly parasternal long axis we start imaging, and I'll go through some of the images. In parasternal long axis view, usually LV apex is on the left side of the screen. We can see both mitral and aortic valves, and this view is used to assess LV function by E-point septal suppression, that normally E wave and A wave which we measure are due to mitral leaflet motion towards the septum, and this distance is less than 7 millimeter normally. When it is more than 10, there is LV dysfunction. You can see LV dysfunction with the regular short axis view. Here you see that LV is severely dysfunctional, and there is it's a case of non-compaction, and so the contrast study is done to show non-compaction here. This was a case of post-MI free wall rupture. You can see LV dysfunction, and there is pericardial collection, and you see there is a echo dropout, so a suspicion of MI post free wall rupture is made. Parasternal long axis view, also by tilting, cranial long angulation can give us RV inflow view, where you see RA and RV, or RV outflow view by caudal angulation, where you can see RV outflow and you can align the probe. But parasternal short axis view also gives us this RV outflow view, as well as we see the aortic pathologies in this. Then this is a case of bicuspid aortic valve, and these are the structures seen with parasternal short axis. This helps us to, by tilting the probe, we can see whole of the LV at basal, mid and apical level with parasternal short axis view, great vessels at the higher level. This is showing the RVOT where we take the gradients. You can also visualize the coronaries. Then we have apical 4 and 5 chamber views from parasternal long axis. Initially the probe, the pointer is towards the right side. And then for short axis we turn it by 90 degrees towards left shoulder, and then we come down at the same rotation down towards the apex to see 4 chamber and 5 chamber views. The pediatric cardiologists they flip the image so that it looks like our transesophageal echo. Here you are seeing severe tricuspid regurgitation. This is showing you mitral regurgitation. This is apical 4 chamber view. These two images are from a PDA case. In one case, a child had large PDA with LA-LV dilated, but the other patient had RA-RV dilated and dysfunctional. And this patient was in fact Annadurai. You can see D-shaped LV, a small underfilled LV with severe PH. So 5 chamber view will give us aortic visualization where we can align the Doppler to measure the gradients. We also get apical 2 chamber and 3 chamber view by probe manipulation. 2 chamber you see LA and LV, and in 3 chamber you see LA, LV and aorta. This is a case of aortic regurgitation showing dilated, mildly dysfunctional with severe AR and mild MR. TTE, again the different views are used for mitral valve, apical 4 chamber, 2 chamber, parasternal long axis, finished, okay, and short axis views. Then subcostal view for IVC, measurement for filling, which is commonly utilized in the ICUs, and we have suprasternal views for aortic arch. And you can see this patient has aortic regurgitation. There is an additional view, crab view, which gives us all the pulmonary veins in of suprasternal visualization. This is also called PDA view. You can see PDA from descending aorta. Thank you.
Thank you, Parimala ma'am, for that wonderful presentation. Now let's go to the next session, Conduits Patches. I now invite Dr. Debashish Das to deliver his invited lecture on conduit and patches in cardiovascular surgery. Dr. Debashish Das, sir, is a senior consultant cardiovascular surgeon from Narayana Multispeciality Hospital, Kolkata. Over to you, sir.
Well, good afternoon, everybody. First of all, thanks to the organizer, especially Dr. Hiremath, for organizing this important program for so many years. I'm sorry not to be presenting it physically. The topic that I've been given is a broad topic, conduits and patches. I will try and do justice to it in the next few minutes. So, the scope of the presentation as I see it, I think I'll talk about the role of conduits and patches in cardiac surgery. I'm excluding coronary artery conduits because that is a separate topic in itself. We will mainly talk about application in structural heart disease, meaning I'll talk about applications in congenital and acquired heart disease mostly, limiting to congenital because that is the maximum usage. The material types, we will talk about biological and the synthetic options that are available. The key considerations of any artificial material being used in human body would be durability, growth potential, and thrombogenicity. We'll also compare the various options and see how they fare against each other. So that I've based my talk mainly on this particular review article, which I'm happy to share with any of the trainees if they approach me. This was published in Progress in Pediatric Cardiology, and it talks about grafts and patches in detail. It has a separate section on conduits and in patches, and it describes it in detail. and I'll share it with the team at the end of my presentation. So what exactly is a conduit? A conduit is basically, we all know, it's a tube-like structure with or without a valve in it, which is basically establishes a continuity of establishment of blood flow between two structures. So it could be a replacement for a vascular structure, it could be a replacement for any portion of the body where we need continuity with a tube. Patch, on the other hand, is a flat material which is used to either repair a hole in any particular situation. It is also to augment any defect, or it is also to close any defects which are there in a structural heart disease situation, or to augment stenotic vascular segments. The indications that we use the conduits for, we will now talk about conduits and go on to patches in the next half of this presentation. It's mainly to, the most common conduit that is needed is right ventricular outflow tract and also the pulmonary artery. In congenital cardiac surgery, this is where conduits are applied the maximum. Aortic reconstruction in selected cases, Fontan pathways, extracardiac conduit, and vascular continuity restoration in terms of establishment of shunts, vascular repair, and also in congenital cardiac surgery for various perfusion strategies where you cannot directly cannulate. That is also an indication for using of a conduit. So, is there an ideal conduit available? Well, the answer sadly is still no, but there are a lot of research which is going on to create an ideal conduit. The characteristic of an ideal conduit would be, it should be non-thrombogenic, it should be durable, it should be resistant to infection, it should have a growth potential, especially in congenital cardiac surgery. This is of immense value and it should be available easily. Now, if this is a tough call to actually make a conduit like this, so none of the conduits will have all the boxes ticked, but the maximum number which is ticked would be close to an ideal conduit. So what are the types of conduits? They can be biological conduits, as I said, or they can be synthetic man-made conduits. Biological conduits, the most widely used throughout the world, not so much in our part of the world because of availability, is homograft. Now, homograft is a conduit made available from a cadaver after harvesting it in a particular manner, and it would mean either an aortic homograft or a pulmonary homograft. There are some pictures which are put here which will explain what this is, and also xenografts which are commercially available, mostly of either bovine tissue or porcine tissues. Commonest xenograft that we would be using is mainly Contegra, which is widely available in India, and also another conduit that I'll be talking about, which is marketed by AMS Technologies. Synthetic conduits are mostly PTFE based, so expanded tetrafluoroethylene conduits, which is made out of Gore-Tex material, or Dacron conduits, which are slightly thicker, which is also another commonest synthetic conduits which are being used mostly in aortic positions. We would be using Dacron based conduits. So homografts, these are basically cryopreserved human tissue. Advantage of homografts is that they've got excellent hemodynamics, low thrombogenicity. The main problem is limited availability, which is one of the main problems in our part because of absence of homograft valve bank. And in the institute that you're attending this conference, they are planning to open up a big homograft valve bank, of which Dr. Hiramath is a part. So I'm sure it'll see the light of the day someday, and it'll become more available. But they are not free of degeneration and calcification issues over time. So homograft do degenerate, do calcify over a period of time. So they have to be followed up carefully over a period of time to see how they fare off. So they're used for mainly the following procedure. Ross procedure, when you actually do an aortic valve replacement with a autograft, the RVOT is being reconstructed most commonly in the Western world by a homograft, although there are some modifications to that. Rastelli procedure, which is the commonest usage for RVOT conduits in congenital cardiac surgery, and all the variants of biventricular repairs in difficult situations of DTGA, VSDPS. So be it Nikaido, be it a Rev procedure, be it a Rev, although it's a non-conduit based procedure, Rastelli, all variants of Rastelli procedure, they'll be using a RV to PA conduit. In addition to that, Tetralogy with absent pulmonary valve in older children is often treated with a conduit. Truncus arteriosus repair all variants of pulmonary atresia where you do not have the native main pulmonary artery and you need a valve reconstruction of that, or a non-valve reconstruction, you would need some conduit. Where a homograft can come in handy. Norwood reconstruction in the Western world are mostly done with pulmonary homograft to reconstruct the aorta because the material is very suitable for that, and also aortic arch reconstruction, especially in younger children and neonates. So all these procedures actually are ideal for usage of homografts in the pulmonary position, although because of availability issues, we use other alternatives more commonly in India and the part of the world we live in. So this is just a depiction of when it all started. So it all started in the 60s when Ross first used it in the RVOT situation, followed by Rastelli in congenital RVOT reconstructions. Then in the 1970s, the homografts which were used were cryopreserved and irradiated without any mainly anti-calcification measures, and the storage was also primitive. That would mean that they would calcify and restenose very rapidly. That led to formation of synthetic conduits. This is a depiction in 1970s when Hancock valve was made, which is basically a porcine valve in a synthetic conduit. Smaller sizes were available. They got started being used for as small a size of around 12 millimeters. And later on, the storage of antibiotic sterilized homografts became much and much better, so they were of a better quality and started lasting longer. This also led to a development of another conduit called Freestyle, which was basically a porcine valve made with a sewing ring, something like a hybrid between a completely non-stented versus stented conduits. And over a period of time, they've all stood their test of time. Homograft is still one of the commonest used throughout the world. The xenografts have found their usage wherever availability an issue, and these are the two most commonest conduits which are used. Coming to the xenograft, as I said, Contegra, which is a bovine jugular vein. So you can see in this particular, there is a picture of bovine. The apex of the arrow basically shows the direction of blood flow. There is a valve inside that, and this is basically a bovine jugular vein, very commonly available in India. Availability is not an issue. Very good sewing characteristics. Handling is very easy. The main problem is the price. That makes it prohibitive in certain circumstances. Then there is another alternative available these days called Advalve pericardial xenograft. Again, this is made out of bovine tissues, where they have rolled a bovine pericardial tube and made a tri-leaflet valve out of bovine pericardial tissue. So that is the Advalve, marketed by AMS Technologies in India. They are readily available. They have good handling characteristics. However, the main disadvantage of xenografts is risk of restenosis as well as risk of endocarditis. Especially there are some papers in which the risk of endocarditis following a Contegra implant is tad bit higher than other alternatives used, although the evidence is very soft, but these are real problems. Calcification leading to restenosis and endocarditis. So these are some pictures. So you can see on your starting from your left, there is a Contegra conduit in a Rastelli being used here. There is a Contegra in a truncus which has been used. You can see the Contegra being used in a DTG, VSD, PS, in a Nikaido reconstruction. So these are various situations in which we would use a Contegra, mainly because of availability. And it, as I said, the handling characteristics of Contegra is very good, and it comes in widely available sizes of 12 millimeter onwards to around 24. So when we compare them, this is the comparative chart of various type of valve conduits, the homograft valve, the xenograft, as well as the commercially available. This is a Synergraft, which is a decellularized pulmonary allograft. Decellularization basically increases the longevity. So as I said, if we take the main advantage of homograft is excellent hemodynamics and very good medium to long-term outcomes compared to the xenografts. However, the main thing is availability, and also there is an element of antigenicity, although with treatment that reduces, it is still it's the antigenicity is of a minimal nature. That is not so much of a problem. However, the main disadvantage is availability. Xenograft, as I said, the main advantage is availability is very easy. It is available from 12 to 22 sizes. The main disadvantage being risk of thrombosis, higher risk of postoperative infective endocarditis, and also there is no potential for growth. The decellularized pulmonary autograft, mainly because it is an anti-calcification measure when we decellularize, so they last longer. Again, whether the advantage of long-term effect of this decellularized graft is still not very clear, and the availability of decellularized pulmonary autograft is also questionable in countries like India. So our main conduits would still remain homograft and xenograft, in addition to the synthetic conduits, which we will go to the next part. So the synthetic conduits, which are made out of mostly, the most common is PTFE, expanded PTFE, which is used widely in congenital cardiac surgery. Dacron, which is slightly thicker, it will be used mostly in adult cardiac surgery, mostly in aortic surgery. These are durable, but these are all non-growing structures. They all have thrombogenic potential. So that is something we need keep in mind. What are they used in? They're used, you have seen, this is a picture of a BT shunt from midline. So there is a systemic to PA shunt. It can be used for perfusion purposes where you cannot cannulate the arteries directly because of size. It is used in extracardiac fontan to restore continuity from IVC to pulmonary vasculature. RV to PA connections of all sorts can be made with synthetic conduits also. Ascending aorta, aortic root replacements can be done with synthetic conduits. Now, there are some specialized synthetic conduits which are available. This is Miyazaki conduit, which is basically a PTFE based tube with a tri-leaflet valve being made inside it, and they have actually created 3 sinuses to replicate the normal physiology. And that is again a very novel concept. It is widely used in Japan. Availability is an issue, and so is the cost. So they are very good conduits. They have excellent hemodynamic properties and longevity. However, mainly is availability and cost remains an issue. This is another concept where they have used a Gore-Tex conduit and have implanted a pericardial tissue valve in it to create a valved RVOT conduit. It has been used in older children. This is one of the papers from Chicago in which they had successfully used this particular handmade conduit successfully in children also. So these are some pictures of ePTFE conduits. If you start from the right, that is from your left on the top, this particular conduit, this is a perfusion cannula for selective cerebral perfusion. This has been sewn on to the innominate artery. The arch is being repaired under a distal body circulatory arrest and selective cerebral perfusion. So as I said, when innominate arteries are very small or for the convenience of handling, we always sew a PTFE 3.5 to 4 millimeter graft and put the aortic cannula in there for a selective cerebral perfusion. This is a BT shunt that you're seeing from the subclavian artery to the right pulmonary artery on the side of the aorta. This is another slightly unusual case in which there was a myocardic aneurysm of the descending aorta beyond the subclavian in a child, and that's why we didn't want to use a Dacron conduit, and we used a ePTFE graft of around I think it was 60 in size, and replaced the descending aorta. This is an extracardiac fontan. You can see this is a 20 size ePTFE conduit from IVC to the pulmonary vasculature on the right. This is a handmade conduit with a tri-leaflet valve. Again, this is a 0.1 millimeter PTFE membrane which we use to create a tri-leaflet valve, and we house it in a PTFE tube. This is used in a tetralogy pulmonary atresia situation. You can see the same handmade conduit being used here. This is a Norwood stage 1 palliation with an RV to PA ePTFE conduit so like a Sano modification. And it's the same thing, if you can see here, is a bovine pericardial patch to reconstruct the aorta, and we also use the ePTFE tube to perfuse the same selective cerebral perfusion for the brain during Norwood reconstruction. So these are the various usage of ePTFE conduits that are used. As I said, Dacron grafts are mostly used for aortic position. This is a 12-year-old child with an aortic aneurysm. This is a valved composite valve conduit with a Dacron tube in it, and that is being used to create a mental sort of reconstruction. In addition to that, you can have valveless autologous pericardial tube. So that is a Hagar dilator on which a pericardial patch has been sewn into a requisite side of a tube and then used in a tetralogy pulmonary atresia situation. So these are the various types of conduits, from autologous tissues, from synthetic to many handmade conduits as well. Now, when these conduits come, they come with their own set of complications. So they undergo stenosis, they can calcify, they can thrombose. They also have infection risk of endocarditis. And again, because of their non-living tissues, they also have another disadvantage of lack of growth. So redo surgeries is whenever we replace an RVOT reconstruct an RVOT with a conduit, we know that this is a lifetime thing, and the patient might have multiple reoperations over a period of time. Some of the conduits might need, like in a font, especially when they are used in the venous side. So in a Fontan reconstruction, we would always use, even if we have used EPTFE conduit, we would use anticoagulation for 3 months at least. They all need antiplatelets, especially in arterial situations like a VT shunt or something. Antiplatelets are usually sufficient after bridging with heparin for the initial 48 hours, but there is a need for anticoagulation and antiplatelets, which has a theoretical risk of bleeding. So that completes the conduit part of it. Now we'll come to the patches. Now patches are mostly again autologous or synthetic, and we will describe one by one each. So biological patches, autologous pericardium, I think that is one of the most handy things which God has made for us. Whether it is congenital cardiac surgery, whether it is adult cardiac surgery, a pericardium is such a handy structure which is used to reconstruct a myriad of things. You can use it for any purpose. So autologous pericardium, bovine pericardium commercially available is a substitute. Right atrial tissue has been used for various kinds of reconstructions. Synthetic patches, which are mostly EPTFE, Dacron patches. The EPTFE comes in 0.6 millimeter thickness, 0.1 millimeter thickness, and again, Dacron conduits are used for aortic positions. So again, patches are used for VSD closures in terms of, because they are thicker, we would use it in high pressure situations. So as I said, autologous pericardium, bovine pericardial patches, these are the commonest patches being used. However, you do have porcine pericardial patch, which is commercially available. These are not so much available in India. However, this is available in different part of the world. Porcine submucosal patch, which is the core matrix. It is again, availability is an issue. Even equine pericardial patches have been made, which are commercially available, in addition to artificial patches of Dacron based and also Gore-Tex based patches. So this is a comprehensive list of all the patches which are available. Autologous pericardium, as I said, is the most readily available patch. It is excellent biocompatibility because it is the patient's own tissue. Can be treated with 0.6% glutaraldehyde to make it more stiff. However, mostly an untreated pericardium is probably the most supple and the best material. It is again, when we use an autologous pericardium for redo surgeries because of adhesions, we can harvest only a limited size. So that is the main situation where we would use bovine pericardial conduits, bovine pericardial patches. Common usage, as I said, is ASD patches would be mostly autologous pericardium. RVOT patches are autologous pericardium. Certain units use either treated or untreated VSD patches. We don't use it for VSD because of the thin pericardium. We usually use the Dacron patches for VSDs. Handmade conduits can be made out of autologous pericardium. It can be used to do an arterioplasty, arch repairs, valve repairs. The Ozaki procedure, which is basically reconstruction of the entire aortic valve with 3 leaflets with treated pericardium. And also as a hemostatic strip, I think pericardium comes in very handy, especially in aortic surgery. Sometimes it is used to do annuloplasties in valve as well. So these are some of the pictures from patches I just randomly took out from my picture gallery. So this is a transannular patch in a tetralogy with an autologous untreated pericardium. That's a primum ASD patch being used in a complete atrioventricular septal defect. This is a supravalvular aortic stenosis in which an inverted Y pericardial patch has been used like a Doty's reconstruction. This is a this is again a rheumatic valve being repaired in an adolescent girl where we used Gore-Tex cords for the AML, and the PML was very restricted, so it has been detached from the base, and you can see a pericardial patch being sewn in to increase the height of the PML. As I said, in Ozaki procedure, you would use a treated pericardium to recreate the entire 3 leaflets of the aortic valve, which is another use of the passage. Bovine pericardium, I think in redo situations where autologous pericardium is not available to an extent that we would want it to be, that is one of the main usage. However, it is also used because they come in larger sizes. It is also used when you require a large size of a pericardium. It is a commercially available product, so it's like very finished. It has got a uniform thickness, very easy handling characteristic. The risk of calcification is there over a period of time. Again, as I said, it is used widely in redo surgeries as a substitute for autologous pericardium. It is used for creating intracardiac baffles. It is used for creating SVC reconstruction. So this is one such patient in which a Glenn was done as a first stage, and the SVC is being reconstructed as a biventricular conversion with a bovine pericardium rolled into a tube. This again, as I said, a DKS has been done, and an aortic arch reconstruction in an Norwood being done with a bovine pericardial patch. Again, a pulmonary homograft is probably the most ideal material. However, we don't have access to that, so we use bovine pericardium for this. The synthetic patch materials, again, we have 2 main materials, which is PTFE and Dacron. Dacron, as I said, is thicker, stronger, and durable. PTFE is less thrombogenic and also very flexible. The next generation is tissue engineered patches, which are decellularized, so they don't have calcification and they're longer lasting. However, none of these have any growth potential. That is something we have to remember. Again, synthetic patch materials are also used. Some units use Dacron patches or PTFE patches for even ASD closures. So ASD closure, VSD closure, intracardiac baffling, tunnel repairs. In addition to that, RVOT valves, monocusp or bicusp, as the unit preference might be. And also PTFE bands are used for PA banding. So this is a Dacron patch, which is our material of choice for VSD closure with interrupted sutures in a VSD. This is a 0.1 millimeter PTFE membrane being used as a bicuspid pulmonary valve in a tetralogy absent pulmonary valve situation. A 0.6 millimeter PTFE strip is used as a PA band commonly in our unit. That is how we do it. And as I showed you earlier, this is a PTFE tube in which a 0.1 millimeter membrane has been stitched like a tri-leaflet valve as a valved handmade conduit for RVOT reconstructions. So this is again one of the Indian products, which is Synchroscaf. It is a tissue engineered decellularized bovine pericardium. Again, this is a paper by Dr. Nikhil Tiwari, which was published in our journal, and you can see it has been used in all positions like a tetralogy repair, AVSD, more or less truncus arteriosus, and they've used this particular decellularized, commercially available, I think it is called Synchroscaf. It is used for reconstruction in all these situations. So that is another tissue engineered decellularized bovine pericardium. Decellularization adding on to its longevity and anti-calcification measures. So this is one of the widely available patches in India currently. But however, as I said, patches do not come without complications. So patches can undergo aneurysmal changes, especially in the RVOT. Calcification can happen. They are also prone to infection. Residual leaks can develop because of dehiscence of the patch. So these are the complications of patches. So this is another review article which I'm happy to share the full text. This came in a translational medicine journal, and it describes all the kind of patches that are used. So again, broadly they are synthetic that we talked about. They are tissue engineered based. They are biologic. They are color coded according to whatever is there. Some which are commercially available. There are some which are still investigational products. But that is the broad classification of patches being synthetic, biologic, and tissue engineering based. So again, every patch, as I said, I've already gone through this. This is just a depiction of the same thing of advantages and disadvantages of various patches. The ePTFE is very good to handle. It has got non-thrombogenic, minimal thrombogenic capacity. It's good biocompatibility. However, it is again, it can become stiff in situations to use. Dacron, as I said, is durable and thick. Mainly we use it for VSD closure. Xenograft pericardium, mainly bovine, is used in redo situations. And then there are tissue engineered grafts also available, which can be used in various situations. So the current trend is development. There's a lot of research going on in tissue engineered conduits to make them longer lasting, to also to avoid calcification. Then again, decellularized homografts are another main focus of research these days. Bioengineered products. Mainly everybody is wanting to develop a product which can last longer, and also if there is a product which can have a growth potential. So regenerative medicine based on stem cell scaffolds, where you can actually grow a conduit on a stem cell scaffold. Personalized conduits based on patient CT scan or based on 3D printing. These are the future directions in which all the research for valves and conduits are going. So to conclude, ladies and gentlemen, I think thank you for your patience. The key takeaway was there is no ideal conduit or patch which exists. Everything has a disadvantage and an advantage. The choice depends mainly on patient age, the pathology, the position that you're using, and the availability. Biological materials are always preferred in pediatrics, and a long-term follow-up is always essential whenever we used a conduit or a patch, because these are all artificial materials which we are putting into our heart, and we should keep an eye as to how they fare.
Thank you, sir, for the wonderful talk. Requirements with high stakes and need for precision by not letting failure bog us down. It is our honor to have you amidst us, sir. Over to you.
Thank you. Once again, we welcome Dr. Mylswamy Annadurai for his second avatar for today's evening session. And here, sir, we have a mix of cardiac surgeons. We have young budding doctors who are there in their final year medical education from our institute, and also many being joined online, many senior professors. So this session, as we plan together to have a cause which we together move in the same direction. That's what finally it ends to. I have a set of questions which, through your rich experience, helps us cardiac surgeons or budding doctors how innovation and science and technology move together in healthcare. Sir, you have led missions like Chandrayaan-1, Mangalyaan, where zero error execution is critical. What parallels do you see between mission critical space systems and cardiac surgery, where a surgeon also has no room for error?
Yeah, now you look at here time and again, we used to tell, especially the missions like Chandrayaan, Mangalyaan, we are talking about that. One term which will, time and again, I used to tell my colleagues is, we used to have a surgical precision. Okay, that means there should not be a room for an error. If we make an error, whatever happens, and that you look at there, when America failed 5 attempts, first 5 attempts, Russia failed first 9 attempts, and China had to succeed, Japan had to succeed. In this, we made our mission, because what called for is a precision is called for the planetary body motions, and where you start and how you embark your speed, which direction you have to. So direction, time, and the velocities should be so precise such that it matches after 9 months of travel. When you go over there, Mars is supposed to be there. Yes. If the precision is not there in any one of the parameters, you are not reaching there. So, so that talks about volumes. When we talk about surgical precision, what does that mean?
Yes.
Okay. There's nothing called second chance in that.
Yes.
So is the case for you.
Correct, sir. Yes.
Okay. I think that's the parallel I feel there.
Sir, ISRO is known for its frugal innovations, doing world-class science at 1/10 of the global cost. What lessons can cardiac surgery programs in India take from ISRO's cost-effective innovation models?
Yeah, again, you look at here, the Indian model for the aerospace is concerned is more close to the your field, whatever I told here, because there is no second chance when I tell. Similarly, nominally elsewhere they will make before making a flight model which is goes to the thing, 2 or 3 models they will make and they test it and they will correct it and they launch. But that is one of the reasons why it will be costlier elsewhere. Time is there, manpower is there, materials cost, all the things are there. But here, again, the parallel.
Yes, sir.
Okay, you cannot operate 2, 3 patient and go for the patient. Correct, no? So you have to operate there. So say is the case here. We told the first time itself is to be correct. I think that is the thing we told. But when we do like that, definitely it has the benefit of you are not going for so many years and so you are not going for so many models. Automatically this is becoming more economical. And you are doing only one, you will do more precise. And that's how it's turned out to be. And beyond all these things, today you told our digital twin.
Yes.
I think almost similar thing we used to do from 80s onwards. You make a digital twin of your satellite, what you are going to fly, and you iterate it, the configurations there, and then you push it to the actual hardware. So that is something similar. And now I think it's similar thing is happening where virtual realities and augmented reality is concerned. Before you are operating, you are able to plan it. Today it's coming. I think something similar we have done it there also. But that has the implication of making the cost very contained.
Sir, in space missions, you use extensive simulation and mock drills. SCORE is essentially a mock exam for surgeons. How important is simulation-based training in high-stake fields like yours and ours? I need your thoughts.
Yeah, I think without even knowing this question, I answered to some level extent about digital twin. Digital twin is nothing but a simulating your targeted the satellite and the targeted planetary motion. Okay, so that is the one which will enable you to take. I told you you should take a correct time, you should take correct velocity increment and correct direction. These three to choose properly, we will iterate the simulations. That's how it's happening there. And beyond that, while going also, there is some error comes. Okay, to overcome that error, to correct that error, we will simulate it to understand why that came. Yes. You are getting only telemetry data. You are not seeing the satellite. Using the data parameters, you are supposed to understand what went wrong and how you can correct it. I think you look at here, similar thing it will happen. Your system also now, the evolving systems are concerned. Before really going for the thing and your diagnostic data, what you are seeing, yes. And with the diagnostic data trying to infer what would have been the reason for that particular patient. And then accordingly trying to take your own corrective actions, what you plan. I think more or less something similar. Like your telemetry data is more like your diagnostics data.
Yes.
Okay, then your planning is more like your mission planning, what to do. That's it.
Sir, ISRO has developed lightweight materials like telemetry and miniature electronics for satellites. Do you see potential for these technologies in cardiac devices like pacemakers, ventricular assisted devices, or pediatric valves?
Yeah, I think that's a finite possibility. I know that one of the surgeon is making an attempt even to make a electromechanical valve.
Yes, sir.
In place of the heart itself. Is it possible like that? Because now you look at here, our rockets and satellites, we have many number of valves, yes, being operated in the space environment, and they operate for the years. You look at space station or our Chandrayaan, Mangalyaan missions, living for Mangalyaan lived 10 years. Inside one of this mission, we live 15 years. And they have a lot of valves, electromagnetic valves are there. When that's happening there, why can't we do it here? I think that's sort of a process going on. And now the robotic systems are keep coming. And the robotic systems are able to mimic the whole human being.
Yes.
So that means equivalent one-to-one part, spare parts can come from there. That possibility, definitely it is existing in various forms.
Telemedicine was pioneered by ISRO to reach remote India. Today, we do teleproctoring surgeries. How can space tech further revolutionize remote cardiac surgery and surgical education in India?
Yeah, surgical education point of view, definitely it can do well because one is the tele-education and telemedicine. These two we talked about there. Now bringing as a part of tele-education, imparting the medicinal, the education of the medicine also, it's very much feasible. Practically we can show, the laboratories you can open it out, like nominally we'll use in conferences how it open. That can go in the classrooms itself, possibility exists. And beyond that you look at here, now we talk about even telesurgery. Conventionally we talked about a fixed station at the super specialty hospital. Surgeon is sitting there.
Yes.
And another fixed location, it can be even if it is a humble primary health center, it can be there. But still it's a fixed station. Between these two only it's happening there. But now there exists a possibility to making one of them mobile to start with. Okay, that means that the station which is going to the surgery, that can be moved elsewhere, and it can be positioned accordingly from your place you can do. Next level, it's possible even surgeon on the mobile. Surgeon can be on the mobile, but he can get connected through the satellite to that. That means need not fix your locations, operation theaters, one place.
Yes.
It is very much feasible because when you are away from the patient, your operation theater can be even your own wherever you go.
Okay.
Because that serenity is not called for. That place only called for. So that way, but the connectivity is called for. Okay, secured connectivity is called for. So more reliable connectivity called for. So this way, satellite can help, and patient to surgeon connectivity can be made much faster. And beyond that, it can be prompting.
Yes.
Okay. Then by senior surgeon can be doing a surgery there, but you can help him in terms of diagnostic, in terms of prompting. So that way, possibilities are huge.
Sir, robotics and autonomous systems are key in space. What's your vision for artificial intelligence and robotics in cardiac surgery over the next decade?
Yeah, basically trying to take the knowledge base of, for example, what I'm supposed to react for the satellites, some problem. Sometimes I cannot react. For example, around the Mars satellite is going around. The communication delay is as high as nearly 30 to 40 minutes. That means something happened to the satellite. I'll come to know only 15 to 20 minutes later. Even if you react it immediately, my reaction will reach only 20 minutes later.
Yes.
Okay? So even though I'm sitting there, I cannot reach it out there. That means my knowledge has to be there. As if I am sitting with a satellite, the knowledge has to be better there. So then what I would have reacted, the autonomous system will react it there. I think similar thing is not a very distant dream. Okay? Today we saw the avatar of Hermet.
Yes.
For diagnosing. I don't think so. Surgery also, it's an impossible task.
Okay.
Impossible task. Provided you plan it properly already. So you know that previous liver scans, everything is available. You plan it properly and you feed it to them. That means the real-time surgery can be done there, but the planning and what to do for that particular patient can be fed there. This is called autonomy, automatically. My knowledge is fed into the system, yes, and that reacts. But still my knowledge is with respect to that situation, that scenario. Yes. Similarly, that patient, that issue, you plan it and put it, and it's doing it autonomously is not a distant possibility.
Yes. Sir, you took India to the moon and the Mars when many said it was not possible. Cardiac residents today face huge challenges, long training, limited resources. What would be your message to young surgeons who want to innovate but fear failure?
Okay, if you fear for the failure, you cannot move forward. Okay, a little girl, she walks on the rope. If she fears a moment, she cannot walk. Yes. Okay, the first and foremost is be take away from the fear on that. So then, but just fear alone going not enough. You should learn. You should learn how to walk. Okay, so that both together. That means ever learning situation. You should be there. Okay, and the fear of failure probably needs to be taken off from that. And this is the thing it happens for our own satellite missions. Okay, fear of failure, if it is there, we cannot do that. But we are able to circumvent that problem. Something happens, you must be able to overcome that and proceed further. So that mentality, if we keep it, definitely we can do. And anytime you can rely on your peers, anytime you can rely on your mentors and take the lessons and keep move forward.
Yes. So ISRO works with 100 plus industries and academics. How important is this ecosystem approach for cardiac surgery innovation in India between surgeons, engineers and startups?
Yeah, this is, you look at here, the rockets, they will tell about morning also, I repeated that word. Something is difficult, it's not rocket science, people will tell. The one of the reason being is one is beyond multidisciplinary. It is not an individual brilliance that helps. It's a common wisdom. It's a common wisdom of a common effort, common wisdom that prevails. I think so is the case here also, because though you are attending one patient, though I am attending one satellite, beyond that, the knowledge of hundreds of satellites, knowledge is there with me through somebody else. I think similar thing. Okay, whatever the knowledge of that surgery at similar situations, that is the one which feeds how to react is concerned. So the same is the case where when you're talking about so many firms and so many academia is concerned. Finally, if the common goal, a common wisdom prevails, bringing all the people systems together. And I think so is the case when you are attending for the surgeons. Yeah, I understand a satellite to satellite is different. Similarly, patient to patient also different. Heart may remain as a heart. Spelling alone may be the same, but heart need not be the same one patient to another patient. Yes.
Sir, you have mentored hundreds of young scientists. If you had to mentor a cardiac surgery resident today, what 3 qualities you would ask them to cultivate?
Okay, and be ready to learn anytime.
Yes.
Okay, and never the saturation of learning should not be the case first and foremost.
Yeah.
And second thing is don't give up. Don't give up.
Don't give up.
Okay, because anytime you must be able to revive them, because we have seen that there, and so don't give up this. And beyond all these things, how to get the cooperation of the patient also. Okay, because I cannot do that my satellite. But here, the satellite is a machine. Yes. I cannot impart confidence whether Annadurai is operating or somebody is operating. Yes. But whereas you can do that, okay, the patients, you can. So because the patient's strength also will help for his own recovery or his own coming is concerned. That way, don't give up, be ever learner.
Yes.
And try to give the confidence to the patient. Because this is what morning you told.
Yes.
Your avadar of that, whatever told is, your junior could have done the same job what you are doing, but
yes.
still you are trying to reach it out to the patient,
yes.
because that is to instill a confidence.
Yes.
So this is the lesson I learned.
Okay, very nice. From the moon to the human heart, both are on the frontiers. As a scientist who has seen the earth from a mission perspective, what does serving humanity mean to you?
Yeah, because whatever said and done, in the vastness is the one thing which used to always make me to wonder. And in this great vastness, the human beings is another wonder. Okay, whatever said and done, the life form we are yet to see beyond Earth. Among the life form also, we are yet to see something like human, because this is the one which evolves. What was 100 years back, what 1,000 years back, 10,000 years back, but what we are today, extending this where we are going there. So it's a really humans are real wonders, and we are lucky to be part of this planet, which makes us to be safe. Because beyond this place in the universe, anywhere, life species is going to be very difficult. The very treacherous environment in terms of weather, in terms of cosmic radiation, in terms of no air. So all put together, it will make our life miserable. But whereas we are everything being preserved in this way, and we are growing also. So that way, it's a wonder to be life form, and wonder to be part of. You are also a life form of that nature. So life form is a wonder.
Sir, at Sri Madhusudan Sai Institute of Medical Sciences and Sanjeevani Group of Hospitals, They all run a model of totally free healthcare. ISRO also works for national service, not profit. What drives you personally to work for societal impact over commercial gain?
Yeah, if you look back, what I have done over the 40 years versus monetarily what I would have gained, now you look back, there is no real correlation. Definitely, I can tell that. You can impartially look at what is materialistically what you have come and what has been given. That is not there. But definitely, the sense of accomplishment, the sense of pride. Yes, I am part of that system. Which morning Satish Babu has told, very modest beginning ISRO. When I joined ISRO was like that only. But that didn't stop me because when I did schooling, my schooling was in a cow shed, makeshift arrangement of cow shed was my primary school. Same thing, makeshift arrangement of a church, ISRO started.
Yes.
So it was looking like a parallel. Okay, but it didn't stop. Actually, you are part of that growth. So that makes the sense. No materialistic gain could have replaced that joy. So I feel that means you are part of a bigger cause will take you better than whatever the bigger check you are going to get.
Yes.
That's what my personal feel as I stand today.
Sir, before I go to the next session, I have a few rapid firing questions to you between space and cardiac surgery. Moon or human heart, which is more complex to the engineer?
I think both are equally strong.
Thank you, sir.
Yeah. Winning a heart and winning a moon, one and the same.
Very nice. The next one is one ISRO protocol every cardiac operating theatre should adopt.
Never give up.
Never give up. I think this is in the blood of every cardiac surgeon. Never give up. Thank you, sir. Chandrayana countdown versus aortic cross-clamp time. I will just brief you, sir. When we stop the heart, as I was mentioning, when we give a cardioplasty solution, we stop the heart. How we stop the heart is we clamp the aorta. So that heart, whatever it pumps, it goes to the blood, it goes to the aorta. So once we clamp, more the clamp time, clamping is like squeezing one's neck. It's like killing. So once we clamp that, the heart should be protected well. That's where the next lecture in this is Pedro Del Nido from USA invented his own solution. How to protect the heart by stopping it and how it should revert back to its activity. So my question is, Chandrayana countdown, you will count down, no sir, 10, 8, 9 before it flies, versus aortic cross-clamp time, which is more tense?
Okay, first one I have seen many times because I prepared for that. Definitely it is.
Let me in this context. The more time we clamp the aorta, the more morbidity, the more mortality.
I understand.
Yeah, with that you should tell me, sir, which gives you more tension?
No, here also what is happening, that's what I was telling is, there is a time, I'm telling you now, in that time, for some of the machine, it has to be started from that time only. Yes. If you are not starting that time, when you go over there, Mars will not be there. Okay, Mars is going nearly 30 kilometers per second, its travel. Okay, if you make 1 second error, or 1 second delay, or 1 second ahead, where supposed to be there, you are 30 kilometers away. Just think about over the 9 months of travel, if you make 10 minutes error, even 1 minute error, so that many 60 into 30, 1800 kilometers away. When you go over there, Mars will not be there.
Okay.
You got the point, no?
Oh, we never knew this. It sounds like it's more tense for many people rather than one person. Here the tension is only for the surgeon. It's for the whole country and the whole world. Yeah, that is a good learning for us. Sir, if you would launch one cardiac device into space for testing, what would it be?
No, I think already in the form of human beings we have launched.
Yeah.
Correct, no? Actually, when we, today you look at here, astronauts where they're going, many vitals are being tested, purely speaking. They are all part of this testing rehearsal only. So that means Sunitha Williams survived for 9 months.
Yes.
Her heart has been already tested for 9 months of survival there.
Okay.
In a way.
Yeah,
look
we
at
got
that.
it, yeah.
Yeah. So this translates in is slightly different because this is so many humans are already there, and their vitals are being tested. Actually, they may be part of that, but one of the reason is their vital system, how it behaves. I think that is a part of the space exploration when the man in loop. Human in loop, rather. I don't want to put man in loop. Human in loop.
Yes. Sir, Mangalyaan succeeded at 1/10 of NASA's cost. Your one tip for frugal cardiac innovation to cut down cost.
Okay, first and foremost, if we look back, Mangalyaan, we didn't work for the paychecks, we worked for our name in that mission. Because that is the one such thing in your lifetime, such a mission. Okay, so that's how it is. There is no paycheck behind us, that is the one which make. And beyond that, you know that Mission Mangal story itself, that hardware supposed to have flown to the moon, and because some delays it got there, and we have taken that mission there. So instead of putting waste, we have rejected and we have done the mission there. So that is the way of frugal has come. But bottom line is, even though such a historic missions have done, we are shown to the world we are second to none. But in terms of pace, we are shown we are second to everybody in the world. Okay.
Yeah. So telemetry in space or hemodynamics in cardiac intensive care, which needs faster decisions?
I think it's the context based.
Yes.
Depending on the context based, because depending on the situation that varies. That's what I don't think so. We cannot tell this or that. Depending on the context that here or there it happens.
Yes. So one word of advice for residents who fear failure in surgery. They are operating, they have the fear that where the patient dies, it's difficult for them to continue the surgical field. I want one word of advice from you to these residents who fear failure in surgery.
Anyhow, I told, don't fear, I told, but somebody fears. Leave it to God.
Leave it to God. That's the final answer. Yeah. Thank you for that. Sir, if you had to build a mission control for cardiac operating room, what is the first display you would put up?
Okay, it is more like here you look at here the parallel of telemetry systems of the satellite. All the vitals will be made available to them, and if possible, what is expected versus what is happening.
Yes.
Okay, so that will help for that way. So one that way is concerned. All vital parameters trying to reach it out. And as you are seeing right there, and you are able to see here. Yes. Today's you have AR and VRs enabling in much better than the numerical. So beyond the vitals, what's really going on, and that you are able to. Today we can give many things as if you are standing in front of that.
Yes. Sir, ISRO or cardiac surgery, where is teamwork more critical?
I think both places, teamwork is more important.
Both the places. Yeah.
Both the places, teamwork more important.
In 3 words, your message to the India's future cardiac surgeons.
I am told India is having a large number of cardiac cases. More than 60% is like that. It was told there, but by number we don't have that many surgeons here. So that means to overcome that, be ready to use the technology. Technology will help you. So be aware of the, say like your computer literacy, we have literacy about what the technologies. So I think this can help. And beyond all these things, definitely the young surgeons must be able to take with the wisdom of the elders. That also will help to multiplying factor point of view. That will help them.
Sir, if ISRO designs a pacemaker, what would be its coolest feature? As you know, pacemaker, God has given his own pacemaker called the SA node in the heart, which continues to beat, on which you and me are sitting here on the dais. The moment that stops, the artificial pacemaker pitches in, which sometimes as elderly it degenerates, or following surgeries it degenerates, and we need to put an artificial pacemaker. So currently India does not have its own pacemaker. We import pacemakers, which are quite costly. So what are your thoughts?
Yeah, one thing is it's life, is it possible for to have an extended life? It's a replacements whether you can avoid. And it's how it can be environmental friendly.
Yes,
how it can, because some of the places you are not supposed to go, something like that being told there. Is it possible to overcome that? I think that's probably we can.
Yeah. Sir, Mars by 2035 or rheumatic heart disease free India by 2035, which excites you more?
Possibly my heart also will be expecting that at the time there. Both ways. Expecting a Mars vision 2035, and my heart also to be safe by 2035. Both are same.
Yes. To be on the lighter note, we at Madhusudan Sai Institute of Medical Sciences, we are working in collaboration with IIT Madras to come up with a rheumatic heart disease vaccine, sir. The ground level work is ongoing process. So hopefully in the next few days, we are planning to come up with this technology. Yeah. Sir, what is your next frontier after the moon and the Mars?
Okay, basically you look at here to go to the moon and Mars, our cryogenic engines, whatever we used, oxygen and hydrogen, that is the one which is a fuel help there. Now right away I'm working, when I'm talking it here already, some of my gadgets are in the pilot mode, starting from kitchen to your iron ore industry. That means one of the finest thing science has invented is a fire. Okay, that is the one which started there. Then only wheel came, then electricity came, many things came there. But the man started using the fire in slightly different way. To create the fire, he has started using slightly things. He started using a coal, using a firewood, using a petrol, diesel, many things. And that made our environment totally thing. Now I'm thinking, why to go that way? Is it possible to find an answer? We have gone to the moon. We are happy to discover water on the moon. We are trying to find a solution from the water itself. Take hydrogen oxygen from there. And today, kitchens are working in a pilot mode, commercial restaurants, using electrolyzed hydrogen oxygen, no LPG. And similarly, LPG metal cutting or kilns, we are using this hydrogen based. So this, I think, in the near future, whatever the existing problem has given us an opportunity to come out with a solution, so that the fire, you need not rely on the firewood, you need not rely on the coal, you need not rely on any of the fossil fuel. From the water itself we can take. For that, so solar is a power.
Yes.
So full green hydrogen we can make, and that you can create it where you need. It is not like the conventional way of creating hydrogen, storing it, transporting it, and using it. You generate where you want. So that is the one we are doing. So that sooner or later, I think that will keep coming out. Beyond that, yes, I'm also working with Mantra 3 for the surgery point of view, surgery robot, and that extending to the tele surgery, and the telesurgery also connecting with the our drones, how it can reach out a place where now there is no station, fixed station. That's what I told. You can even move the end robotic arms to a place where you want.
Yes.
That possibility also we are talking about.
Sir, when the mission doesn't go as planned, what is the first conversation you have with your team, technically and emotionally?
Mission, if it is going...
Yes, if it doesn't go as you planned.
Okay, basically, I actually worked more than 60 missions. I never ever gave up immediately. Whatever I told is never gave up. I never ever gave up immediately. Actually, I should to see to that. And already you have, you ask my people, more than my contribution in Chandrayaan, Mangalyaan, personally, and as well as my colleagues know, the missions would have been given up elsewhere.
Okay.
We brought back to life. There are many occasions. Yeah. So one second year of the launch, one mission, both redundant systems of, like our eyes, two sensors wait. Elsewhere, people could have abandoned, they looked for the subsequent mission. But we didn't do that. Okay, we came out with an idea, with the ground computer and that, we worked together. This mission lived its life for another 13 years.
Okay.
Another 13 years, earning $10 million foreign exchange 20 years back. That's what happened. So this is one such example. Actually, as far as my heart is full of such incidences. When I told never give up, yes, it is my personal life journey. Because when I born also, now I know why the reason, but in a village, people may not be knowing. When I born, I was not crying for quite some time.
Oh.
Okay. Then my mother got up and these people thought this will already die. They were looking for my mother only. But my mother didn't give up. He asked us to basically red hot a needle and put on my forehead.
Okay.
It was put, first time I didn't try, second time when touched I cried, it looks. So this baby was not given up by my mother at that time.
This is an amazing
That's the story
innovation.
of...
I think science can't explain that if the child does not cry after birth. I think you have hypoxic cerebral damage. Here, I don't know what kind of hypoxia happened to his brain, where it went on innovating and landing multiple satellites on the moon. So you are a living example, sir. Tomorrow in our hospital also, I think if there is hypoxic damage, I think we always have some room to breathe ourselves that something can happen. Sir, was there a failure that fundamentally changed how you approached further missions?
Yeah, basically, I have shown the failures, not failures, I used to tell the setbacks. Setbacks are the things which will, like whatever I told, setbacks are the things which will help you to understand who you are. Okay, your strength is known when the setbacks coming only. If the satellite without problem would have survived 15 years, my name would not have been known. Actually, I became project director because of such missions only.
After
okay,
failure?
After failure, this man is able to get back faster.
Yes.
Actually, that is the one which brought me to be a youngest project director for Chandrayaan mission. Okay, because not trying to give up. Not to give up any time. You try to research and come back. So that way, I used to see many occasions, people elsewhere, they would have told the failure. We are able to regroup and come back there. So that's it there.
Sir, in both mission control and the operating room, pressure peaks in critical moments. How do you prepare your mind and your teams for those no-error situations?
Okay, don't be a subjective of that. Be an objective.
Okay.
Okay. If you are putting yourself there, and already there is a problem, you also should be a part of the problem. You should not be a part of the problem. You should be away from the problem. Then you can do.
Okay.
That means you should not hold the hand here, hand away. Okay. Be away. Then only you can see that. I think this is the.
How do you prevent a culture where fear of failure limits decision making or innovation?
Yeah, fear of failure is a stumbling block for your normal way itself. The fear of failure is the thing that needs to be overcome. That's why I told, don't be a fear. Okay, and that by any cost, I think we should see to that is going out of.
What differentiates individuals who grow stronger after failure from those who lose confidence?
Yeah, that makes the difference between the winner and the thing. It is not the winner, he always succeeds. The winner refuses to take the failure as the last chance.
Okay.
The winner always thinks about failure, he also a chance to get back and move. Okay. That is the one which makes a difference.
Sir, when faced with incomplete data and limited time, how do you decide whether to proceed, pause, or abort?
Yeah, abort is first removed out between pause and proceed.
Okay.
Okay. And the pause is to understand so that you proceed better way. Okay. Pause and proceed has to be in a proper combination. So that what you are proceeding in a proper direction. For that pause definitely, this is what I told, be objective.
Yes.
Be objective definitely will enable you to understand the things properly so that you proceed better way.
Sir, in mission control, communication must be precise and unambiguous. What principles ensure clarity, and how might these apply to surgical teams, especially in cardiac operating theatres?
Yeah, this is like pre-operation preparation. Mission also we will prepare ourselves. Okay, that means the known path, wherever something is gone, what will go wrong, and accordingly how you will react. I think this is called a normal flight control procedure and something called contingency procedures. It could have been already discussed, reviewed, and rehearsed it. Okay, so that means a known problem, you will have the known way of attacking, known problem. Okay, so that means we need not even spend too much of time for the known problem really occurred. But an unknown problem comes, your mind should be free to attack that. Okay, so that means you should have an exhaustive way of exploring and foreseeing what will come. Okay, so that is the bottom line of the mission control, which though the countdown we are talking about there, each countdown means this second, this parameters, this is, read this like this. If not reading, what should happen? So like that it is there. Similarly, we have the normal path and abnormal path. So this goes and comes back, so and comes back. Then beyond something comes, towards that your mind is free.
Yes.
To attack further. There only the pause and proceed comes there.
Sir, ISRO is known for achieving remarkable outcomes with limited resources. How do constraints drive innovation rather than compromise quality?
My life lesson is like that. My primary school, being a cowshed, didn't stop me to sit here.
Yes, sir.
Okay. The constraint is not a stumbling block. A constraint is the one which makes you to learn, in spite of that, how you can grow. Okay. I think the same thing is gone when I joined ISRO also, when I grown with ISRO also, when we make the mission also. So constraints need not constrain you. Basically, constraint need not constrain you.
Nice. Sir, what defines a mission-ready team, and how do you build trust among individuals handling different critical components?
Yeah, basically this is more like a chain. Mission is like that. Like a building, every brick is essential. Okay, every member, it is my duty is to instill. Every one of their contribution is equally important. That means for the bigger mission, every one of my team members, irrespective of what he does, he is in the Chandrayaan team. He is in the Mangalyaan team. I think that is being instilled very heavily. So in that thing, definitely I used to tell them, actually even before Chandrayaan mission, to make the people to believe we can make this mission. That is more important for me. Okay. Actually, first initial times we spend enough time. And we have been given opportunity. If we make it, we are a part of the history. Not many people have got that opportunity. Yes. You and me have got this. You and me, every individual of my team, yes, same. Okay, you are part and parcel of making a history. Do your duty, history follows you.
Very nice.
I think that is the essence we have done that.
Yes. How do you balance long-term vision with immediate high-pressure execution?
Yeah, so now the long-term vision should not come in the way of taking my next step. That's where definitely it is called for. But how aligns my this step towards the long term also should be taken care. The immediate step, whatever I taking, should also take me lead to that position. But keeping that, I should not falter this thing. So this has to get balanced. Your immediate step, what you are taking, with the immediate steps all put together only coming a long term. Long term will not come all of a sudden. But looking for the long term, I should not lose this.
Yes.
Both are equally same.
Sir, how do you personally recover mentally and emotionally after intense missions and setbacks?
I live for the present moment. While making for the future, I live for the present moment.
Live for the present moment. That's a very important take-home message what we can get. What daily or weekly habits have you sustained your performance over decades?
Last 54 years, I am no days goes without reading at least 2 pages of Bhagavad Gita.
Wow, that's the secret. No doubt, sir, that's the reason why you are here with us today. 2 pages of Bhagavad Gita, no day is completed. Very nice. Looking back, is there a failure you are now grateful for because of what you are today?
I didn't get my extension from ISRO. Okay. I didn't get my extension from ISRO, which everybody thought I will get it. But that was the failure. But today I am here because the extension I didn't get.
Sir, as we all know, you have been called as the Moon Man of India. How this title came after all these innovations, and how you feel when somebody calls you as the Moon Man of India?
Okay, this basically, this name was coined by, not from any one of my Indian friends. It was coined by the NASA colleagues.
Okay.
Because we carried so many instruments to start with. I told to tell unambiguously, no, water is not there anywhere in the moon. We should carry so many instruments. It is not there in the atmosphere. If water is there, it will evaporate, can create an atmosphere. If atmosphere also not there, no what, then I can tell. And another, some set of instrument to look for the surface, which water, sun rays hits and reflects back.
Okay.
During IR spectrum, you will be able to see that. So then surface look for that. If water is here and it evaporates, it cannot simply go away because this being some gravity being there, it will pull. So that means it has to go and settle somewhere like in the poles. There never ever sunlight has gone there.
Okay.
So that means it should be in the form of ice. Okay. If ice also not there, surface also no water, atmosphere also no water, then we can tell no water on the moon.
Okay.
Everybody laughed. This moon, with 99 missions have gone to the moon, we have not seen anywhere in the water. You are telling, you want to probe this many instruments, atmosphere, surface, and the polar regions. Everybody laughed. Then they told, if really it happens, man will go to the moon. So you will be called Moon Man of India. Moon Man, not even Moon Man of India. They told Moon Man. Everybody told like that. This man is to tell no water on the moon is carrying like this. But later when it really happened, we have found the water molecules in the tenuous atmosphere of the moon. We have seen the water molecules on the surface layer of the moon. We have found the water in the form of ice for the few meters of depth from other instruments. Then within 1 year, NASA launched once again one more unmanned mission. One of the impact probe went and hit the place where we have told water is in the form of ice. This ice oozed out in the form of water. They have taken the picture. They have seen that and they sent to me with a congratulatory measure. Man, you are a moon man.
Thank you. Thank you for sharing this secret, sir, which many of us were not aware. The next question was, how do you feel, sir, when you have been called Moon Man of India? Can it be expressed?
No, it is not, I don't know, I was feeling, to be frank, that time I was feeling empty. Empty.
That's a very great feeling of feeling emptiness when you have been given the highest title. It's really amazing, sir. I think with this, I would like to conclude. I have few options of asking questions from the audience. Yes, please take a mic, sir. Give a mic to sir.
So one question, sir.
Yeah.
This is just curiosity. So was Sunita Williams really lost in space, or she was just finishing her experiment and coming back? For my knowledge, I want to know, was she lost in space?
No, I'm not getting. See, his come back now.
No,
What?
she's back.
Yeah,
But
okay.
then there was so much hue and cry about her coming back and then the spacecraft docking and getting her out, all those things. So that means she was lost or she was on a mission?
To the best of my knowledge, to my understanding, she was made to be there at 9 months.
To test whether the heart functions well at space, sir. That was one.
No, there are multiple things. There are multiple things. One is this. Basically, to go to the Mars, you have to live 9 months under space. She has proved when she was there. That is one portion. Second portion is, this is a second, another dimension is there. Anyway, it is only within this thing, not recorded.
Okay, we will cut it, sir.
Then I think I should be.
Yeah. After we switch off, we can tell that, sir.
After Tamil Nadu elections, you can talk.
Mike.
Yeah, basically not only going to the pole, we have to put a mission around the polar region itself is a very tough. Okay, now Artemis has gone behind the moon and come back, something like that. Say, putting onto the thing, say now you look at here, the moon is there. Moon also like Mars, moon also going around the earth nearly 1 kilometer per second. Actually, that's moving like that. So, but even if you take 6 days early, you would have taken off to going over there. So now, when you make a small error, few kilometers this way, that way, no problem, as long as you go around like this. But when you have to go like this, you have to go over a point. 384,000 kilometers away, and particle is moving 1 kilometer per second. Over that, you have to cross over a point. Then only if it goes like this, when it's turning, you should be over the pole. Then it will not come back, it will go around that. Okay, first making that itself is a tough. People have not made it before that. You got the point now? Because when I told about all these things, then you have to go over the pole. It's Chandrayaan itself. Then over the pole, how you will go? Nobody has gone like this. And your mission is PSLV is a very, very tiny compared to that. With this, how you will plan? That's what originally people. So this going over the pole itself is different. To land on the pole, you should go over the pole first. Then from there, you should descend. Correct, na? Then while descending also, we don't have a great pictures of where we are landing. Correct, na? So that means one leg here, one leg there, it will tilt. Okay, so that means your autonomy, I told, na, you should put your knowledge there, such that when it is going over there, you must be able to understand, first going to the pole stuff, and then landing down here, the terrain where you land, if it is a hazardous, up to landing you will okay, after landing you will tilt. That's what happened Chandrayaan 2. Okay, then you should take a bigger pictures, make sure that if there is some problem, you must be able to go like that, such that all four are landing there. So that is a toughest situation. Going there, coming there, and landing there. So that is the one. You look at here, even 2-3 nations tried, including Russia. Russia just a week before our Chandrayaan 3, the launch, they had a failure. Okay, so it's a toughest job, like Everest climbing only. Not every human being can climb, but some people can climb. It's not that it is totally beyond, but it's a challenge. We made it.
Any other questions? Yeah, please go ahead, sir. Give the mic to him, sir. Kindly introduce yourself.
Sir, I'm Mohammad Ashraf. I'm from Maldives. I'm studying in Chennai in third year.
Okay.
So my question is that humanity as a whole have achieved so much. Recently we have gone, humans have gone the farthest we have gone. And it's been almost 40 years humans have sent Voyager 1 and 2 and it's still traveling further away. But with the information age, we are supposed to get more educated. But along with the information age, the opposite is also happening. There are people, educated people who should know better, like pilots and all, who are seriously arguing that the earth is flat. There are people, people who doubt the moon landing. So I would like a comment from you about, like one way we are going forwards, but some part of it is being dragged backwards also.
I agree. Moon has two sides. Moon has two sides, no? Yes. The side which you can see, the side which you have never seen. Correct? That is also there. So like that, human beings are not all are alike. That is the good or bad, we don't know. But science has to correct it. Humanity has to correct it. That's what we feel. I think that's all about this institute.
Yes.
One family.
Yes. One world, one family.
One world, one family. I think we should nurture this. Basically, what we are telling is such a things we should nurture. Now you look at here in a field, you are growing the paddy. Weed you don't want. Two ways. One is this grows better, weed automatically will go out. You got the point now? So it is our responsibility who feel we are the paid to grow faster, to grow better, to overshadow those people. I think that is our responsibility.
Yeah. Yes, sir. Please go ahead, sir. Dr. Sitaram Bhatt, yeah.
Quite a few times in cardiac surgery, we experience the presence of God. Do you experience the presence of God around you during your missions? Second question is, how religious you are? Spiritual you are.
No, I am a spiritually connected person. No doubt on that. Okay, but to define what is spirit, still it is. I am still comprehending on that because definitely something beyond me is there. So what I would have answered all these things, but none of the questions I knew before that.
Yes. This interview was not discussed.
Not even a single
rapid
question.
fire here.
Not even a single question. Okay. So the questions came, the answers came. I use an instrument.
Excellent. Yes, Doctor.
Sir, supposing you think that a particular failed mission is because of one particular person, how do you face the situation? You are convinced that it is because of one particular person your mission failed. How do you face it?
I will add on to that. How do you face it and how do you deal with that person? Extension that in cardiac surgery, yes.
Okay, making, it's a human, it's a human. Okay, correct, no? It is not something beyond. Because when you make something big, that when I told about, I felt empty because I felt I have been given, but whether I am fully responsible for that or not, I don't know. I was driven to the situation, like that I told. But that is, when we talk about success on that, why I should blame somebody else for failure?
That's an excellent take-home message, boss.
Yeah.
Thank you, sir. Thank you. There's
So
a lot of learning in this.
One last.
Please, sir.
thanks a lot for a real enlightenment, more enlightened than the moon and sun and the entire galaxy. Just want to a small correction. We are constantly talking about fear of failure. Doctors have a fear of failure because of the hanging sword of legality. And legality, they not only drain you mentally, they drain you socially, drain you economically. ISRO doesn't have to face.
No, our auditing is not that easy.
No.
Facing auditing also not easy.
No, I'm saying good. I'm saying good, ISRO doesn't have to face it.
No, I'm telling about, we also have the fear, something happens, we have to face the audit.
But here, law, legality,
Okay, that is not.
and it is constantly hanging on our head. And just now you said, no, he rightly asked question. Surgeon is the captain of the ship. And anyone, including the ward boy, who brings the patient on a trolley, if the patient falls, at midnight 12, the surgeon sitting in his quarters, sleeping in his quarters, is responsible for that. So that is the absurdity, and that perhaps is responsible for this fear amongst surgeons about failure.
Yeah, possible. But only thing is, just I want to add this. For example, this sort of thing somebody else is making. There is an occasion, very, very vital element, everything tested and supposed to be fitted on a satellite. While bringing, like whatever you told, while bringing, somebody dropped. Okay? But still, immediately I got a call, we dropped. He would have simply kept it back and kept quiet. Okay? Well, you got the point, na? The reassurance given is, because once it is fallen, that faulty thing that I put it there, that could have been one of the reasons for failure. Correct, na? So this man, then I may not be even knowing where it failed. But now this helped to correct it and to fly on that. So we have to, that's what it would, you have to reassure the team.
That's an excellent message. Any other questions from the medical students? Yes, please. Kindly introduce yourself. Take the mic, give the mic to her.
Good evening, sir. I'm Tejasa Vaidyanathan, pursuing third year MBBS. My question is, what is your opinion about space settlement projects?
Space settlement?
Projects of NASA.
No, that is when Columbus discovered a place which falsely he thought of going to India, he discovered US. And that is the land of this generation. So I feel the continents which are separated by the ocean, I see an extended earth sitting on the moon, separated by space. So lunar settlement is not very far. Okay. When that happens, I used to advocate among our people. One of my friends asked, so we should show to the world. I say, as intellectuals, we are not separated by the borders. We are not separated by the language. We are not separated by the religion. We are all one as a human. Okay. This is what I echoed the sentiments of this thing. That should happen in the moon. Okay. I think International Space Station, India is not part of it. International Lunar Space Station, India will be active partner because the whole world is going back to the moon, to the South Pole. South Pole, somebody is looking very seriously. Moon itself, once again, they're looking back seriously because of India. So the settlement on the moon is not very far. When that happens, Indians need not ask for a visa for this land going to US. Similarly to that land going, I think that is also part of the thing will happen. For the whole humanity, that should be the common place. So settlement, I think it will happen for various reasons. I may come back another day and tell you the 100 reasons why we are back to the moon, because this life form is very, very precious one. This need to be saved elsewhere also. Okay? And that is nearest place is a moon. So moon settlement in our lifetime is a finite possibility.
Thank you, sir. I think this with we conclude. I think he needs a standing ovation, the Moon Man of India. Thank you, sir. Thank you for being with us. We look forward for multiple further collaborations. Already we have set up certain collaborations coming in the month of July to exchange certain MOUs, wherein how to create an air ambulance using his drone technology to transplant hearts. That's one thing we are looking at. Second is he also told we can always vision forward to operate open heart surgery on the moon. So we'll sit and work on that. Oh, sorry, the camera had to come down. Yeah, please. Can you give him the mic? Dr. Del Nido is waiting for us. How to stop the heart, he'll be teaching us.
Sir, in all of these missions, have you ever had to assume, like, there are universal truths in our calculations? Like, have you ever had to assume that the universal truth has a negative hypothesis and then come back to the universal truth?
No, as of now, no, we have not come.
Like no situation like where you would have to, like, let's just say this is what science has discovered as a universal truth so far. But what if we have to assume that this as a negative hypothesis and prove that same hypothesis in a different way?
No, basically not exactly the same way, but until, for example, until our, one is the water. All hypotheses talked about, all the science, whatever they have seen, talked about no water on the moon, no atmosphere on the moon. Yes. So that, unless otherwise really fully go through, you cannot see that we have seen. Similarly, when the mission Mangal, when we did, so many missions have the failures. But we made our modest mission, still we have to succeed. To succeed means we would have gone the same path as other people have done. Out of 51 missions, 31 missions are failure. We also could have got failed. That means not to fail, we should know why they failed. Okay. While going through that, we have seen to that until then the model in which we are, the gravity models what we use when we go out of Earth to the interplanetary missions, we used to keep sun is the center. Sun is the center only. But the gravity point of view, all other planets also playing a role. Okay. So then we came out with the thing, keeping the sun alone, the convergence of fixing the time, fixing the velocity, fixing the direction, we are finding it difficult. So then, so much of iterations, then we came out something called barycenter. Barycenter is not on the sun. Barycenter is away from the sun, because these are all other systems also playing a role. So because of that, though we talk about all other places, sun is the center, but our spacecraft goes, taking this as center, and we calculate back, to get back that Mars, you calculate back a time, calculate back a position, calculate back a velocity, convergence not coming. So then we worked out to come back, then the barycenter came. So with this, all other 51 missions, once again we rerun. Like our digital simulation, we rerun. So all the 51 missions we made success, making this correction of the barycenter. Okay, that is the one which gives us confidence. Our mission also will succeed. We have done. Then still en route when we are going, we beyond gravity also we have seen some forces. Okay, that is basically the solar radiation. Even though it is sunlight, that also gives a pressure, very minute but the pressure. But the integral effort of 9 months, it is like sailing into a sea. And the satellite has a solar panel, antennas all put together. So this was disturbing. So when you disturbs, you have to correct it using a thruster. When you do that, say we have originally calculated some numbers which that you have gone, so you are correcting that. So this may create a problem there. So to overcome that, like how to sail in the water, so we also manipulate the satellite such that it sails through. So these two things was not known before our Mangalyaan, our mission. So now you look at here, after us, UAE made another mission. Okay, they are scientifically, technically, they are nowhere near America, Russia, Japan, or even India. They also succeeded because they followed our path. Yes. You got the point now? So that means that these two corrections, which scientifically was kept one way, we corrected it.
Okay. Thank you, sir. I think we have the next session with Dr. Del Nido. Thank you once again, sir.
After that wonderful session, we are now moving towards another opportunity to interact with a pioneer from our specialty. I am privileged to welcome and introduce Professor Pedro J. Del Nido. Dr. Del Nido is Chairman and Cardiovascular Surgeon-in-Chief and the William E. Ladd Professor of the Child Surgery at the prestigious Boston Children's Hospital and Harvard University in the United States of America. Dr. Del Nido once again needs no introduction to anyone in the cardiothoracic community. He is a pioneering surgeon, innovator, researcher, and teacher who has been at the forefront of advancing science for patient care from the laboratory to the operating table. He is most popularly known in our community for developing the crystalloid cardioplegia solution that bears his name today, rightfully so, for being a game changer in cardiovascular surgery. Sir, we are privileged to have you on board with us. We eagerly look forward to your insights on myocardial preservation and protection. Thank you.
Okay, well, first of all, thank you for the invitation to participate in this training course. The topic that I'm going to cover today is the principles of myocardial protection, what every trainee should know. These are my disclosures. None of these are relevant to the presentation that I am going to make today. So the learning objectives today, I have outlined 5 that I thought were important. One is to describe the 2 most important principles of myocardial protection from ischemia reperfusion. Sorry. And the other is to discuss the neonatal myocardium and its susceptibility to ischemia and reperfusion injury. The third top learning objective will be review of strategies for achieving myocardial preservation during cardiac surgery. And the fourth is considerations for managing the post-ischemic heart with dysfunction, the stunning. And then a review of the literature available on myocardial protection. And my focus will be on children. But most of the principles are actually applicable to adults as well. So the outline of the presentation is, how did we developed a cardioplegia formulation to protect the heart during ischemia? What were the considerations that we had in order to come up with this? We will discuss the energy demand by myocardial cells as well as endothelial cells, how ions are regulated for function of the heart, and how energy metabolism occurs in the cardiac myocyte as well as endothelial cells. We'll talk about clinical evidence and practice concerns, and if there's time, a bit about future. So as all of you, I'm sure, have studied already, the cardiac myocyte is a very high energy requiring cell. Why? Because it generates force, and in order to generate force, it has to translate ion flux, that is flux of calcium and sodium sodium ions, through a very high gradient, and that requires ATP generation. What are the sources of the ATP? Well, there's 2 that are typical. One is the glycolysis, that is the breakdown of glucose to pyruvate, and it can be done in aerobic or anaerobic conditions. What happens to the pyruvate after that depends on whether you have aerobic conditions, in which case it can enter the tricarboxylic or TCA cycle and electron transport chain, which generates a very high amount of ATP. Or in cases where in hypoxia or ischemia, this cycle is usually inhibited because of lack of oxygen. Then you have anaerobic glycolysis, which is the pyruvate can be turned into lactate and a proton. That's an important factor, and we'll discuss that later. But these are the 2 main generating sources of energy. TCA cycle and electron transport is the most important. We'll cover that in a second. So what is the organelle that actually does much of this work? Well, the glycolysis occurs in the cytosol. And so if you take glucose and you convert it to pyruvate, it generates 2 moles of ATP for every mole of glucose that you metabolize. You create NADH, and therefore you create a proton as well in this process. And then what happens from there depends on oxygenation. If you have the normal oxygenated state, then that pyruvate enters the electron transport chain. And by doing that through the TCA cycle and electron transport, instead of generating 2 ATPs, it actually generates much, much more. It generates 32 ATPs in the electron transport, 2 through the ATP cycle. So that entire process of 1 mole of glucose entering through the entire process generates 36 moles of ATP. So a hugely important mechanism. The problem is that during ischemia, we don't have that mechanism. And so this is why injury occurs. We have inadequate delivery of oxygen. We have inadequate removal of waste products. And these metabolites begin to increase in concentration, and particularly H plus or protons, which inhibit many of the other normal processes that occur. And so the buildup of these compounds causes the injury. Warm, unprotected ischemia generally is very poorly tolerated. Less than 30 minutes is the rule of thumb. But injury with warm ischemia that's less than 30 minutes can result in myocardial stunning, that is reversible dysfunction. Once you get beyond about 30 minutes, and we're talking about at 37 degrees, then you begin to see irreversible injury. And it's not a uniform process, it's a very focal process, but nevertheless, it begins to occur. Now, how does the myocyte generate force? Well, this is important because this is part of the strategy that we use to protect the heart during ischemia. We know that the cardiac myocyte in the normal state shuttles sodium and calcium back and forth from inside the cell to outside the cell. The extracellular, in other words, the outside of the cell concentration of sodium and calcium gradients are much, much higher than the intracellular. So there's an 8-fold gradient between extracellular to intracellular in cardiac myocytes of sodium. But if you look at calcium, it's a 1200 to 1 gradient. It's an enormous gradient. And so you need these very high energy consuming enzymes that or channels that pump the calcium and the sodium out in order to maintain this gradient. When the cell depolarizes, calcium and sodium enter. The cell begins to recognize that, and then you have actin and myosin interaction, and that's what generates the force. But then the calcium pumps and the sodium-calcium exchangers then begin to pump that calcium out of the cell, and the actin myosin molecules disengage, and you have relaxation. So that is your cardiac cycle. In order to maintain that, though, you need very high levels and very high rate of production of ATP. During ischemia, you don't have that. And so what begins to happen in a relatively rapid process is that through these various channels, the sodium proton exchanger, sodium calcium exchanger, these cations, and in particular the damaging one is calcium, begin to accumulate in the cell. In addition to that, hydrogen ions begin to accumulate in the cell, partly because of anaerobic glycolysis, but in part because of the sodium-hydrogen exchanger. This lowers the pH, and this further inhibits any of the glycolysis. We'll cover that in a minute. And so what happens during ischemia is you have this progressive accumulation of these very harmful cations. Calcium can enter the mitochondria and actually destroy the mitochondria. It opens what's called a transition pore, which is a membrane transition pore in the mitochondria, which then allows a massive influx of calcium, resulting in destruction of the mitochondria. So when that occurs, that the cell will die, either from necrosis or from apoptosis. If you have reversible injury, then when you have reperfusion, you have now the regeneration of ATP. However, reactive oxygen species because of the sudden influx of oxygen, can cause further damage. Now, there are many, many protective mechanisms to sop up these reactive oxygen species in the cardiac myocyte, which protect the cell. But if those protective mechanisms have been damaged or inactivated, then the reactive oxygen species will then cause further injury. And this is what's called a reperfusion injury. So this is the process that we are trying to slow. We can't stop it completely, but we're certainly trying to slow it down during ischemia. And when people have looked at this in experimental studies and they've looked at the intracellular pH during ischemia, normal intracellular pH is about 7.1. It drops very rapidly within minutes. It drops into the low sixes. And then on reperfusion, if it's a relatively short period of ischemia, begins to recover. ATP, on the other hand, also drops very, very rapidly. It is consumed very rapidly by the cell, almost to non-existent levels, and then gradually begins to recover. And notice it doesn't recover as quickly. This is the early reperfusion period when the heart is still stunned. It typically will take at least a good 30 minutes, sometimes 60 minutes before you begin to see full recovery of the ATP. And often it's in particular in unhealthy myocardium, it can take as long as several hours before it fully recovers. So just to recap, what we've talked about is the main damage to the cell and to the mitochondria is from calcium. And you have this mechanism of exchanging calcium in and out of the cell for normal activation contraction coupling. But in ischemia, this process can then create a very serious irreversible injury. So what are the aims of myocardial protection? Well, number one, and probably the single most important one, is to reduce demand. So if you reduce demand, then the need for ATP is far, far less. Your stored ATP will last longer. And the processes that damage the cell, such as the entry of sodium and calcium, are then slowed. And this prevents mitochondrial swelling, which eventually can lead to disruption, and it can maintain some degree of high energy phosphate. So that's the goal. Well, what is the single most important strategy that you can use to reduce the oxygen demand? That is, there are two components to it. One is heart arrest. So stop the heart, stop the activation contraction coupling, because we know that that's the process of bringing calcium in and out of the cell. And then the other is hypothermia. Why? Because in hypothermia, the process of consumption of high energy phosphates is markedly reduced. And so the need for oxygen is markedly reduced. And this is a graph in a study that was done many, many years ago. This is in animal hearts, where they looked at the myocardial oxygen consumption of the left ventricle in mLs per minute per 100 grams of tissue. And under the normal empty beating, this is non-ejecting, so you're on a heart-lung machine, the heart is empty, but it's still beating, quite a high degree of oxygen consumption. As soon as you stop it, you arrest it, there's at least a fourfold decline in oxygen consumption, just simply by stopping the heart at 37 degrees. As you lower the temperature, the oxygen consumption begins to go down, but most of your gain is really in the first 10 degrees or so. So if you go from 37 to about 28, that's where most of your gain is. So really, you don't need deep hypothermia necessarily, unless you're going for a very long period of time. So most of the protection is really by these two maneuvers: arresting the heart, so that it's no longer empty beating, but truly asystolic, and then some moderate hypothermia. What are the methods of arrest? This is an important concept, and this is where some of our strategy came in. There are two main ways to stop the heart. One is a depolarizing agent, which opens the sodium channel and allows for a depolarization of the transmembrane potential. Most common cation that's used for this is potassium. It's a short acting, but you can it can be used on repeated dosing, but it's very rapid, and that's why it's become the most popular form of protection. or at least for cardiac arrest. But there's another mechanism, and that is the concept of hyperpolarizing. The way you hyperpolarize the cell, in other words, increase the transmembrane potential, is by blocking sodium channels. And this was discovered very early in the research back in the 1970s. People discovered that sodium channel blockers such as procaine or lidocaine actually can be even better protective for the heart because they actually maintain the transmembrane potential very high. That keeps calcium and sodium and protons out. So both of these are strategies and both are important. So the idea is to reduce oxygen demand, prevent sodium and calcium entry into the cell by arresting the heart. And we talked about depolarizing versus hyperpolarizing to prevent myocardial swelling. How do we maintain high energy phosphates during ischemia? Well, as we talked earlier, the normal mechanism of ATP generation is mitochondria. In oxidative phosphorylation, oxygen electron transport chain we know is extremely important and extremely efficient, but unfortunately in ischemia, we don't have this mechanism. So what's our alternative? Well, anaerobic glycolysis can produce a low level of ATP. Remember, 2 moles per mole of glucose versus 36 moles for aerobic metabolism, but that 2 moles can be helpful in periods when there's very little consumption, that is, when you combine it with hypothermia. The process has been well described. Glucose gets broken down into pyruvate, but in the absence of oxygen, it goes into lactate. What this does is it regenerates some of the NADH that you need. However, it does produce protons. And that production of protons inhibits further glycolysis. It's one of the most potent inhibitors of further glycolysis. So this is the problem with the strategy of anaerobic glycolysis, that as soon as you get acidosis inside the cell, proton accumulation, you inhibit the glycolysis. What can you do about that? Well, there are these agents called buffers, which sop up the protons, such as bicarbonate is the most commonly known one. But in fact, the most useful ones are actually amino acids, histidine being the most important one because its pK is exactly where you want it to be inside the cell. It's about 7.1. And so histidine, which is the most ubiquitous amino acid, is a very, very good buffer. And then there are enzymatic systems that red cells, for example, contain. Carbonic anhydrase can actually convert the bicarbonate, combine it with the protons, and create CO2, which is very soluble. So these are the strategies that we can use in order to continue to drive some degree of glycolysis during ischemia. Now, cardioplegia is the solution that we use to flush through usually the blood vessels of the heart, either the coronary arteries, or occasionally we will do it through the venous system. The system that we had developed is a blood-based, but it's a very dilute blood. So it's 1 component of blood of red cells to 4 components of crystalloid. So you end up with a hematocrit of about 7 to 10%. It's a physiologic salt solution, so it's an extracellular, low calcium. Sodium is normal for a physiologic extracellular solution. It does contain bicarbonate. It does contain high concentrations of potassium for rapid arrest. Magnesium is helpful because magnesium, remember, is a divalent cation. It competes with calcium for the binding sites of many of the proteins inside of the cell, and therefore having a high concentration of magnesium can actually be a competitive inhibitor of calcium and can protect the heart. Lidocaine is a sodium channel blocker that we use in this concentration and is extremely effective in maintaining the hyperpolarization. Mannitol is primarily an osmotic agent to reduce tissue edema. The dose is typically about 20 mLs per kilogram as the initial dose, and usually after about 45 or 60 minutes, we give a half a dose in order to maintain the heart cold. The methods of delivery are several, depending on whatever technique you find most useful. In most common situations, it is administered once the aorta is cross-clamped and the heart is made ischemic. You flush it through the coronary vessels in an antegrade fashion. Retrograde cardioplegia has actually become quite useful, particularly in patients with coronary artery disease. That is where you engage the coronary sinus with a balloon catheter and then infuse retrograde cardioplegia. All of these are techniques that are standard for cardiac surgery. Generally, we have used, and we have, with our cardioplegia, we have used a single dose. And why did we choose a single dose? Well, partly it's convenience, so that it doesn't disrupt the flow of the surgery. The other part that we find, and particularly the reason for why we like it in children, is because repeat dosing in children, particularly at high pressures, can induce actual endothelial cell injury. It can actually disrupt the endothelial cells that are attached to the capillaries and cause obstruction. And so we prefer to only infuse once, and if we give a second dose, we give it after an extended period of time. What are the risks of the single dose? Well, obviously the heart can rewarm. So you need to keep the heart cool, particularly if the body is warm. Then you need to isolate the heart so that it stays cold. If you have problems with inadequate cardioplegia distribution, for example, in coronary artery disease, you can use retrograde perfusion. If the heart begins to beat again, then you need to redose. You cannot let the heart start beating again. Remember the oxygen consumption curve. As soon as the heart begins to beat, oxygen consumption goes way up. How long is too long? Well, depending on the myocardium itself, in severe hypertrophy or chronic ischemic myocardium, you should probably give the dose more frequently. And again, it depends on whether you're doing adults or children. But you need to understand the strategy in order to use it well. The effects of the cardioplegia on the endothelial cells, I just mentioned earlier. Endothelial cells are just as susceptible, and so are smooth muscle cells, to ischemia. And so part of what you're doing with your cardioplegia is you're protecting those cells as well. Smooth muscle cells have a similar mechanism to cardiac myocytes with calcium, but so do endothelial cells. And the problem there is that if they detach from the inner lining, particularly of the precapillary arterioles, then you produce contraction by the smooth muscle cells, and that capillary bed will no longer get perfused on reperfusion. So that's what you're trying to prevent. So to summarize the basic concepts here, the goal of the cardioplegia is to preserve the myocardium during ischemia. Cold temperature, usually under 20 degrees, is the ideal temperature for administering the cardioplegia. We use hyperpolar arrest, and we combine both potassium and lidocaine. And the administration depends very much on the disease process that you're treating, and again, the dosing scheme. What is the clinical evidence for this cardioplegia? Well, there are pediatric studies and there are adult studies. One of the larger ones, one of the earliest studies, was a pediatric where they looked at single dose protection versus other types of blood cardioplegia. This is a study from Colombia, 34 infants. They used single dose for ischemic periods of 2 hours or more, so relatively long ischemic time. And their conclusion was that it was safe to use in congenital heart repair, and it is certainly at least comparable and does have some additional benefits in reducing perioperative glucose concentrations. This is a prospective randomized, one of the few prospective randomized trials done in children. It's by the group at All India Institutes. This was published in 2017. And it's really one of the landmark studies in that. And this was a randomized trial comparing our cardioplegia to St. Thomas, and they found that our cardioplegia led to lower troponin I levels, higher cardiac index in the postoperative period, lower ventilation settings. So they found it to be favorable. This is a prospective randomized trial that was done in adults. This is organized by Dr. Niv Ad. They enrolled nearly 100 patients. These are adults undergoing coronary artery bypass grafting, and they had 2 arms. And what they found was that our cardioplegia had led to much lower troponin release in the first 12 to 24 hours after surgery, and therefore was deemed to be superior. And this is a meta-analysis, and their conclusion, reviewing 6 separate publications, was that our cardioplegia required lower volumes, and therefore it was less fluid for the patient, shorter cross-clamp times, less interruptions during the procedure, less hyperglycemia, and shorter ventilations. It was equivalent in their analysis as far as troponin release and CK levels. Alternative formulations, one of the things that I've been asked about many times is that the base solution for this cardioplegia is a compound called Plasmolite A, which is made by a manufacturer that is not available necessarily in all parts of the world. However, Ringer's solution is available everywhere in the world. And this was a very nice study also done by the All India group, randomized trial comparing Ringer's solution versus the Plasmolite A, and their conclusion was that Ringer's was equally effective. So you can use Ringer's solution as your base solution, which makes it much more readily available in countries where this Plasmolite A is not available. So what are the practical lessons? Simple measures achieve most of the protective effect. Hypothermia is by far the single most important maneuver, and cardiac arrest, maintaining the heart asystolic. How often should we give the cardioplegia? In order to maintain arrest. If the heart begins to beat, you need to get redosed. And you want to maintain hypothermia. And obviously remember is that ischemia, no matter how good your protection, is not perfect. And so you need to have an expeditious conduct of the cardiac procedure. The goals of cardioplegia in summary then are to preserve the myocardium during ischemia. Cold temperature is important. Hyperpolarizing arrest is in our view critical. The method of administration is a technical factor that you need to take into consideration, and multi-dosing if necessary. So with that, I'll conclude, and I want to thank again the organizers for the invitation to participate in this important teaching conference. Thank you.
Thank you, sir. That was a very detailed and pristine presentation. I'm sure our residents will benefit from your valuable insights. I would like to open the forum for any question and request Dr. Sitaram Bhatt to moderate it.
What is the question like?
So if we need to give a repeat dosing, will it be something worth considering to separate out the potassium?
The question is, I think from the resident, if patient requires a repeat cardioplegia for whatever reason, not maintaining the temperature properly, a longer duration, is it possible to arrest it further with only potassium?
Yes, yes, you can.
For additional period of cardioplegia, that was your question?
Yes, you can hear me?
Should the second dose contain less potassium if required?
Okay, can you hear me well?
If a repeat dose of cardioplegia is required, after say 65 minutes or 80 minutes, or when the heart contracts again, and the heart is active again, can you give a cardioplegia with a lesser dose of potassium in that, instead of 20?
Can you hear me at this point?
Yes.
Okay. You can, but that defeats the purpose. In other words, the idea of giving a second dose most of the time is to keep the heart arrested. And so the current concentration of potassium is only 20 millimolar. So it's not a very high dose, and in and of itself, it doesn't damage the heart. However, the lidocaine can, if you give excessive amounts, that can cause problems. So that's why we only recommend in the repeat dose half the volume, so 10 cc's per kilogram per dose.
Some of the surgeons have expressed their opinion that whenever they give cardioplegia, sometimes heart takes a longer time to recover. Is that your experience?
Yes. The lidocaine is a long-acting sodium channel blocker. And so you get a prolonged arrest from the lidocaine. In fact, it's the reason why we only usually give one dose for 45 to 60 minutes of cardioplegia. or ischemia. And so when you reperfuse, it will take some time for the lidocaine to be washed out and for the normal depolarization to occur. In my view, that's actually a beneficial thing because then the heart isn't beating. It is being reperfused, so ATP is being regenerated, but you're not having the increased oxygen consumption from the actual empty beating.
If there is a long period of quiescence after you release the cross clamp, to what extent do you wait until it beats? 30 minutes, 40 minutes, 60 minutes to give a secondary perfusion?
I'm sorry, I didn't understand the question.
So, I have got a patient, say, I have done a Bental's procedure, I have given a single dose of cardioplegia, and then repeated it, say, at around 80 minutes because heart started beating, and then now release the cross clamp, and the heart is not beating for the next 60 minutes. But luckily for me, that patient, at 65 minutes, heart started beating. Now, when do you want me to interfere? What is the time duration I can wait till I need to give a...
Yes, I understand. Usually what I do in that situation is if it's gone over more than 5 or 10 minutes, I just simply start pacing. Because once you start pacing, then the normal cardiac cycle will begin, and you don't need to pace for very long, but the heart cycle will begin again, and then the normal normal depolarization will take over.
Thank you very much, Delnido. We enjoyed your presentation.
Thank you.
Thank you so much, sir, for joining with us. We have reached a power-packed 12-hour worth of learning, fine-tuning, and inspiring dialogues with patient, expert, and stalwarts. We hope you had as much enlightenment and insightful experience as the program was meant to provide. Let us continue the spirit of dialogue tomorrow and discover the other side of the itinerary. This concludes the end of day 1 of SCORE. We look forward to seeing you all tomorrow. We thank you all, those joining us virtually and via social media. We shall resume day 2 of SCORE at 8 a.m. Indian Standard Time tomorrow. Thank you. Till then, do take care.